to just be there without knowing what is happening here in Kigali, Marriott to be specific. So now we're going to actually hashtag the conference that we are attending today. Whether you are offline, whether you are online, we just do not want anyone to just be there without being shaken with what is happening today. So let's tweet about it. Let's post it on Instagram. Let's post it on Facebook. Let's post it on WhatsApp statuses. So let's just let the world know what is happening now.
Who made a post yesterday about what's going on here? Raise your hand. Only? Why are we few?
Why are there some people who are not raising their hands? Why don't we post about it right now? Let's now have the opportunity.
So who is going to post today? We all have smartphones. We all have people we left behind. So let the world know what we are doing here, because we are doing a fantastic job. So ladies and gentlemen, without further ado, we are about to start. And as you can see on your agenda, we are about to recap what we discussed yesterday. So we kicked off the day by sharing our expectations. And we really had high expectations as we were discussing a serious issue. And from that, we challenged each other to come up with recommendations, which I think everyone did. And we tackled all the components as responses to NCDs, either be detection, either be screening, treatment, and palliative care. So, and as we know, as fighting NCDs requires sectoral approach, we had from different stakeholders. We had a pleasure to hear from government officials and the Ministry of Health. As we shared best practices also, we recommended to duplicate interventions that are being done in one country or another to be duplicated in other countries. So we had from people living with NCDs, and we have also a dedicated session today. And also we identify gaps, but also we provide solutions. We had media engagements. We reached more than 200,000 people on social media, and we have about 150 tweets. So that was a fantastic job. And we keep emphasizing on reaching more people as we kick off today. So we have a lot today. We have a lot to cover. And I hope you guys are energetic. If you're not, that's our job here, to keep you engaged. And without further ado, we would like to invite anyone in the public who might have expectation for day two. Anyone?
The mic is open to everyone.
Did we cover everything? We don't have any expectation today?
Can we call it a conference?
Anyone? Please, let's engage. Yes.
There.
Thank you very much. I am Talibita Moses. I come from Uganda. I work with an organization called Uganda National Health Consumers Organization. My expectation, typical of every civil society or non-state actor, is to participate, because we have been hearing from people who have the power or those that have the knowledge. But I thought it was important that even the audience also either raises questions, gives comments, and the like. So my expectation is that this time around, this very Friday being the very last, you will get feedback, or at least there will be discussions or questions be expected. The other is that, because I realized yesterday we were rushing on presentations and the like, and I was afraid that maybe we are suffering from information overload. But I also want to thank the organizers for the interlude. The dance was good. Maybe you will give us more today. Thank you.
Definitely. That is promised.
Wonderful.
Anyone else?
Probably this side, if we can get somebody saying, what is your expectation for today's session? What is your expectation for your day two? Would love to have one in this side. We already have one on the other side. Now let's come here. Should we do tossing?
Good morning. I expect good practices on how to integrate NCD with HIV. Because of competing priorities, our governments are struggling with the resources, lack of resources. So we have to come to reality, and we have to take health as one issue. So there is no need to talk about communicable and non-communicable. So I think we have to come into our senses, and without, for example, Ethiopia, HIV prevalence is less than 1%. Don't quote me, but we are wasting something like 40% of our expenditure on HIV, which is not fair. So I want to see how on this the launch of policy report, how in this part of the world you are trying to integrate communicable and non-communicable disease. Thank you.
Wonderful. Anyone with a burning expectation? Great.
Good morning, everyone. I'm Zora Vieira. I'm a pharmacist, but also I'm a lifestyle coach. I've been expecting some people to talk about lifestyle because we are talking about East Africa free of NCDs, and yet we are not focusing on prevention. And in Rwanda, we have started things like lifestyle to health, where people can put into practice some good habits, and they can even the diabetes is reversible at that time. Type 2 diabetes, people recovered from type 2 diabetes, hypertension, just because they are putting into practice a healthy lifestyle. Except Professor Kaushi, other people didn't talk about something like how to improve lifestyle to health. And I'm expecting people who will be presenting today to put some emphasis on how we can teach our population, our people, to stop drinking too much alcohol, to eat veg and fruits, to exercise. All those habits will really make a difference. Thank you very much.
Thank you too.
Well, we all have expectations. Okay, one last more. Yeah.
Thank you. Good morning. My name is Jean Paul. I work for the organization called ISP Rwanda. By profession, I'm DHIS2 customization data use expert. So looking to yesterday presentations, mainly the one presented by WHO, we have seen that there is a gap in M&D systems. So today I'm expecting to see how digital systems can be used to avail those data with quality to enable the efficiency in M&E systems for specifically NCD cases. Thank you very much.
Thank you.
Well, I can say that at the end of the day, we will meet our expectations. So with that being said, we heard about interventions, digital, integrating digital transformation. And with that opportunity, it's my pleasure to welcome our keynote speaker, Mr. Jean-Baptiste Biringiro, who is a Chief Digital Officer in the Ministry of Health, Rwanda. He joined the Ministry of Health in 2010 as an e-health expert, hired to manage and strengthen e-health systems. Being an e-health expert, he hugely got keys in the development, implementing e-health tools and supporting end users. Mr. Jiringiro, welcome.
Ladies and gentlemen, a big round of applause.
Good morning. Okay, let's do this. Good morning. I'm Jean-Baptiste Bienigiro. I'm the Chief Digital Officer for the health sector. So it is a pleasure to be here in front of you talking about the digitalization as one of an enabler of a successful healthcare delivery. So, I thought you have had enough time to talk on diseases, but how the digital tools can enable the continuum of care, how the digital can help in decision making. So the Minister of Health has been implementing and investing hugely in digital health system. And of course, as we moved into the implementation, we have had a couple of challenges. So here I'm going to share with you the digitalization landscape, as well as the strategies that we have developed to overcome those challenges, and our outlook to have the unification of patient records in Rwanda. So next, so one of our pain points is the image that you are seeing here. So Rwanda, I think, like other countries, we are facing the same challenges where we have a mixed up with the paper and digital, and which is actually a high burden for the providers to fill out all of this. This is a result actually of a non-harmonized digitalization strategies, because we've been actually in the future being driven by, like implementing the digital solution driven by diseases, like if you are coming to support HIV, then you bring a solution for HIV, NCD, you bring a solution, and you end up having like many solutions scattered, fragmented across the sector and mixed up with the papers. And this is actually our scenario here, which might be your scenario in your country. Next. And then the bad of this is to have a disconnected data. So the patient or our client, our customer, who is supposed to be one, is considered as many patient where he's, is being, seeking healthcare, and there is huge disconnection of his record where, he's seeking the health services. And this really result to double payment, waiting long time, queuing in our health facilities, waiting the service, telling the same story to the doctor, being asked to provide the same test, the same consultation, and so on, because there is a high disconnection of your previous medical records. So next. And then, after observing all of this and analyzing our situation, we came up with the digital healthcare strategy plan with a 3 big milestone to deliver over 5 years. Next. So, for Rwanda, this is a blueprint we have developed in 2020, which really highlight the 3 big phases. One is just to build upon an enabler of the rest of the 2 phases, which is basically building, establishing the health information exchange standard and building a health information exchange as enabler environment where information will be able to be exchanged across our health facilities and solving this fragmented system, at least remain with few systems that are able to talk each other. And then enhancements for our existing tools like electronic medical record, because in Rwanda we've been implementing this electronic medical record since 2012. And we had a huge gap in terms of make it really comprehensive, to make sure that the patient flow is catered and there is no mixed up with the paper and digital solutions. So there is, for that specific phase, which we are in actually, the first one for 18 months, it is the one that we have tackled last year, and working closely with our partners, make sure that we have a HIE standards, building upon this HIE framework. HIE, it's a health information exchange, as well as improving our system to make sure that they are catering all information from the entrance up to discharge of our patient when there is a visit. So the rest of phases, phase 2 and 3, they are just for after having the basic, the foundation, and then we will move to the clinical operations. How do we optimize clinical operations? Analytics. How this tool can help our providers to quickly take a decision. How this artificial intelligence, emerging technologies can be embedded in our system to make the life easy for the doctor and increase the production. So go next. So I wanted just to show you with this slide, to show you how the one of use case we have managed to tackle, because we thought that if we can have this interoperability framework, this will solve like 80% of our issues. Because if you have our system connected, sharing the information, and then this will increase the visibility for the doctor to make sure that he's really giving the quality service, and make sure that there is a quick follow-up of this specific patient. So this is actually the starting of the beginning of our journey, establishing the unique patient identification. Because the holistic vision for the Minister of Health is to have one patient, one record. So our current situation is that we have many, like I'm Baptist, so if I'm visiting one facility, so I left my information there. Tomorrow I go to another one, I left another information there, and there is many Baptists, many IDs, many records scattered across country. And at the end, the doctor doesn't have the visibility of what is happening, what was done on this specific patient. So we need to have a unique identification for our patient, and this is different scenarios that we went through to make sure that whatever situation, whatever situation our citizen or our patient will be presented in our health facilities will be catered for. So the one means the patient might be present at health facility having an ID, any ID documentation. It can be your national ID, it can be your application ID, it can be your NIN. NIN is a number which is given at birth. You can come using your passport. But when you are coming, this sign means there is internet. So we thought about also how the service can be provided when even there is no internet. So the first scenario, you are coming, you present your ID document, but there is internet as well. The second one, you don't have your document, but there is internet. The third scenario, none is there. No document, you don't have any document, ID document, but you don't have as well, there is no internet at the facility. The last one, you have your document, there is no internet. So we try to exhaust all scenarios that the patient might be present at health facility to be able to be given an identification. So next, please. So I have planned to give you a demo. Unfortunately, it won't be feasible right now. I want to show you from last year what we have been able to develop in line with the blueprint. So there is a unique patient ID that we have managed to develop. Make sure that we have one patient, one citizen, one record. Second is an interoperability bus. Interoperability bus means we have many systems, but we have one patient. So there is a need to have a middleware that will enable the information exchange across our health facilities. So that is the middleware that will enable this data exchange. The third is electronic medical record enhancement that actually when you look, it is not only Rwanda, most of African countries, they are lacking of strong internet in our health facilities. So how can we have a centralized system, but ensure that at the point of care, the patient will be received using electronic tools. So we have adopted to have an hybrid approach whereby we'll be having a local instance, but centralized in a way that if there is information collected at bottom, at lower level, then can be kept synced or exchanged at national level to enable the continuum of care. So here the metadata is the way that we use to harmonize our metadata in our health facility. So if there is a new guidelines or any change in our electronic medical records, then it doesn't require to go into each and every facility and then update. So we update at national level and then replicated to our health facilities connected to the interoperability framework. So harmonization of clinical terminologies. This is also an important thing because if, for example, in one of our hospital, the way that they are coding diseases, it is not harmonized across. And then when you are at national level, want to have a visibility or putting the information, then you will be having a worse data. So we need to have a harmonized way of our clinical terminology. For example, if it is a diseases, then there should be a standard to code our diseases. If it is malaria, it can be like, or hypertension, it can be coded in the same way across the sector, so that when, for example, you want to have that visibility or to pull out the data, then you can have the accurate number. So this is actually in brief the the interoperability framework, and it's a component that the government is implementing right now. So we are at piloting stage in a few hospitals and health center. We have started with the government public facilities, and later on we will go to the public as well. So the top layer is just the centralized repository to harmonize our patient level, the bottom layer patient level systems. So there is a couple of components that we thought that will be needed. The entire framework is dynamic. If there is a need, you can keep adding the component, but we thought that for this starting, let's start with harmonization of identification, harmonization of our healthcare providers, because the Minister of Health, in its mandate, he's the one deploying the healthcare workers. And then we need to know where the health worker is deployed, if his license is still valid, and so on. So we also need to harmonize our health facilities. The way it is coded, currently they are not standard. You might find that the way it is coded in the electronic medical record, in the HMIS, in the ELMIS, they are not the same. So we need to have a national master facility list, whereby once there is a new facility or any change on facility, category and so on, and then it can be replicated without go into each and every system, changing the facility and doing those kind of manipulation and edits. So there is also, we thought that we need to harmonize our lab system. We need to harmonize our terminologies, like there is a disease, there is procedures, there is a lot of things that we need to harmonize so that our system, when they are sharing information, they can have the same language. So there is also a NPC, which is National Product Catalog. This is a repository for medical product. So it has to be harmonized as well, because from Rwanda FDA up to RMS, where for supply chain up to the dispensing, the drug should be one. So actually on that, recently we have released NPC for mobile. You can go in your Play Store and then you can download the NPC mobile. So whoever is able to download it can check whether the drug is approved or counterfeit. So you go and check, and then maybe after this conference, you let me know. So this is the way actually we wanted to put in place the solution for any citizen, just to check before even buying a drug or medicine. Check if it is really an approved medicine. So the middle one is an interface. It is a backend that will enable those information exchange. The bottom, they are more on standard and the patient level system. You see there is a NIDA, and this is a national identification. This is the one that gives the basis of creating the unique patient ID. This CRVS, we have medical record, we have RAB, we have DHIS, we have, there will be many systems because in our health sector, there is a lot of system, but they have to comply with a certain standard to be able to share the information. That is the beauty of having this information exchange. We don't oblige you to have a system, but you have to comply with a certain standard to be able to exchange information. So I think that's all. What I can say here is that the entire framework is under pilot. We have started this pilot a couple of 3 weeks ago, and then we are adding the hospitals to see how this framework is behaving. So as we move, I think it's where we can see if really the pilot is successful or not. But we are hoping that with the previous experience, we are seeing it really responding to our big mandate. So thank you very much. Thank you. So if I'm still here, if you have any question, then I'll be able to respond. Thank you.
Thank you so much, Mr. Jirinjiro. Another round of applause. Yes, digital health is a broad topic, and I'm pretty sure we all have questions. You know, there have been a series of debates regarding cybersecurity, ethics, privacy, inclusion. So we reserved a panel discussion on that, entitled "Embracing or Integrating Technology and Digital Health Innovation to Strengthen the Response to NCDs in East Africa." With that being said, it's my honor to welcome the moderator of this panel discussion, Mrs. Andrea Manongwa. My apologies, Mr. Andrea Manongwa. Yes. Please note your questions. After this panel discussions, we will open the floor. We will allow the audience to ask the questions. Also, you address the questions you have to Mr. Biringiro. Andrea Manongwa is a seasoned finance and business professional. He has been working in healthcare for over 8 years. He now is the head of operation for M-Pharma Rwanda. A warm welcome to Mr. Manongwa.
Thank you very much. Good morning, everyone. As the MC said, our topic of discussion today is embracing technology and digital health innovations to strengthen the response to NCDs in East Africa. To discuss this great topic, I have with me four. I'm not very sure whether it's four, but I think we have three. I've confirmed three. I'll start by calling upon Mr. Eric Angola, the head of strategic partnerships and government affairs in Africa from Medtronic Labs. Thank you. Please, that's it. Thank you. Okay. Next is Mr. Placide Abishuti, Senior Manager, Partners in Health, Rwanda. Thank you very much. And then we have Dr. Charles Kamoto, Founder and CEO of Daktari Africa. Thank you. Very well, thank you. I'm not sure, but I'll try. Dr. Kalliope Simba, the Chief Medical Officer of Babil, Rwanda. Okay, that's fine. Thank you very much to the panelists. And to the audience, please, we really need your engagement so that we can make this interaction fruitful for all of us. Thank you. Okay, to get started, I'll just give each panelist 59 seconds to, yeah, to just very briefly introduce yourselves and your organizations. Thank you. I'll start with Eric.
Yeah, thank you so much, Andrew. Good morning, everyone. My name is Eric Angula. I lead strategic partnerships and government affairs for Medtronic Labs across the region. Medtronic Labs is a non-profit organization that focuses on improving access to care for underserved patient populations. And we build tech-powered solutions, innovate around service delivery models, specifically around communities and primary healthcare. Today, we focus on NCDs, primarily starting with hypertension and diabetes and mental health, obesity, but we're expanding that focus to be able to build an integrated community health platform that also looks after oncology, cancers, and also looking at general maternal health. So it's a pleasure to be here and looking forward to the deliberations. Thank you.
Thank you very much.
Thank you. Morning, everyone. My name is Placide Abishuti. I work for Partners in Health Rwanda. I'm the manager of the Health Information Systems. So Partners in Health is an international NGO that has been working in Rwanda since 2005 to improve healthcare. So we work in primarily in the 3 rural district areas, 2 in the eastern, Kayonza and Kirehe, and the 1 in the northern. Since 2005, we've been accompanying the government in improving healthcare, but also focusing on improving systems that improve care delivery in NCDs and other different diseases. So we have cancer screening, but also NCD screening that is ongoing at a different sites in a collaboration with RBC and CHAI, where we are using different systems to innovate care. Thank you.
Thank you.
Thank you very much. Firstly, I would like to thank the organizers, in particular, Professor Muchumbitsi, for the invitation to speak at this esteemed audience. My name is Dr. Charles Kamoto, consultant physician, and as you heard, the founder and CEO of Daktari Africa, which is a telemedicine company that focuses on increasing access to quality care, to quality doctors, to the majority of the population. I have a brief presentation in a few minutes, if the Mr. Andrea will enable that. Thank you.
Thank you very much, Dr. Charles. Okay, great. Yes, the technical team, are we ready with Dr. Charles' presentation? Okay, I think we'll proceed for now. You will let us know when we are ready. Okay, to get things started, just like each of you to just briefly, very briefly, describe how you are using digital technology to provide access to care, specifically to my grandmother in the village. Because everyone here, these guys, they have iPhones, so it's very easy. But I want to understand how you're doing it for my grandmother. Thank you. We'll start with you, Dr. Charles.
Thank you very much for that question, Andrea, because that is precisely why Daktari Africa exists. And also why digital health has such great potential to improve the quality of health for everybody, including that grandmother at home. Let me begin by saying that digital health has grown enormously, and we are having impact also at the village level. COVID-19 increased the number of digital health organizations. We've seen that in Kenya, for example, where now we have over 40 digital health companies, which are getting to the level of those grandmothers and grandfathers back home. We designed and started Daktari Africa in 2008. And at that time, I was working with a lot of grandmothers and also young working people in a very busy district hospital called Thika District Hospital. My Kenyan colleagues will know where it is. I was the consultant physician at that time. And over the years, I began to see how many people, both the elderly, village people, and also the young working people like ourselves, how many people were coming with NCDs. There was a lot of hypertension, a lot of diabetes, but more importantly, they were coming in with complications. And what was concerning was that over time, I noted that the age of presentation was no longer in the 80s and the 70s, but also in the 40s, young people in the 40s who were coming in with heart failure, with kidney failure, they needed dialysis, with other complications of the NCDs. And interestingly, many of those people were suffering because they would have to travel to other towns and villages for work. So they would be posted or go for business in other cities. And so by the time they came back to the district hospital, the complications had already set in. So I asked myself, how could I come up with a solution to help to increase access to care, even for those people who travel, the young ones and the older people in the villages? How could I come up with a solution so that even while they're out there in those towns or those villages, they can still access their doctors? And that is actually where Daktari Africa came in. So initially, the whole idea of Daktari Africa was to have a directory for doctors in different parts of the country so that wherever they were, they would be able to know who is the right doctor in every city or every town. And with time, and it was good that Jean-Baptiste showed that initial image of the many, many documents. That was a challenge I faced as well. And we developed a way by which you could have an electronic medical record so that all those documents would be on one page. And over a few years, we brought in the video teleconsultation. So Andrea, I'm sure you're asking, how will that village lady or gentleman be able to have a video consultation when they probably don't have the gadget, they don't have internet? And so what we have done is we work with existing health facilities. So we enable health facilities to be internet ready and to be telemedicine ready. And we have gone down to the level of even level 2 institutions. So what we are essentially doing, we are bringing the doctor and the specialist to even the level 2 institutions. So patients in level 2 don't need to travel to level 4 or level 5 to be seen by a doctor or a specialist. They can be seen by a specialist even at the level 2. And so that is one of the ways in which we are bridging that gap. The second way is by working with community health workers who are enabled with a gadget. So those community health workers go to people's homes, and that way they are able to actually give access to the patients back in their homes. I'll just quickly bring up the aspect of medicines, because I realize that we've been talking about digital health, but let's remember at the end of the day, the solution will be a prescription and will be medicines. So Andrea, I would like to just bring in the aspect of what we are seeing in the pharmaceutical world. There was a question by a pharmacist earlier on about his expectations and lifestyle, etc. But even the medicines are becoming fewer. And we find that pharmaceutical companies, the large companies, are closing shop. They're closing shop and contracting. And yet this is when we need them most. But the message I have for them is that telemedicine is a solution for the pharmaceutical industry. Telemedicine is what will help people to actually receive those medicines effectively and be able to get better.
Thank you very much, Dr. Charles.
Yeah, thank you. To respond to your question, I will talk about what we've done recently on NCDs. So there was a problem of what we've been seeing at our district. For example, on cancer, many women were coming on advanced stages. You see, like mother coming for cervical cancer, but they are stage 3 and 4. And in that case, the treatment outcome were not good. Like most of them were defaulting to treatment, or even worse, like dying. So we decided on doing community outreach to go and do cancer screening in the community, so that those women can be spotted early on early stages. But there was a problem, even though screening was being done, but there was a problem on linkage to care. Like those women you screen, how do you ensure that they get to the health facilities? So we solved that by leveraging an existing tool called Muzima. So that is a mobile tool that was being used to collect the data when those women were being screened. And those data were syncing automatically with the existing system that is OpenMRS, so that when a screening is done at the health center or even at the community, the person at the hospital is able to see that these women were screened. I'm expecting these women to come to the health facility to follow up if they've shown that they have some probable symptoms. And if those women are not able to attend care, the contact were there and the clinician was able to call, which is different on how it was before, because if I've screened 30 women in the community and in the next month I see 30 new women registering on care, I wasn't able to know like these 30 women are the ones that I screened, but with that tool, we're able to know it, so that those who missed, because we saw that many women were being screened and having symptoms, but not going to the health facility for interest to care. And that has increased follow-up. Also, another example will be earlier during COVID, when there were some people were not able to travel. PH worked with a company that deliver different tools using drone, Zipline, and we were able to deliver cancer medicine using drone near to where the people, those grandmothers you were talking about, where they stay, without having them travel a lot of distance to go and get care far. Thank you.
Thank you very much, Placid.
Yeah, thank you so much, Andrea. Just to address the issue of access. And the issue of access is not only to the persona that you've shared with us, that is the 80-year-old grandmother somewhere in the village. As you know, with NCDs, we are seeing young people succumbing to these conditions. And as Dr. Charles Kamodo said, we are seeing even younger population, coming up now with hypertension and diabetes, and obesity as well, which is now becoming a very worrying trend. But really for us, the focus is And when we define access, we don't stop at the ability of this particular person or persona that you've created to get access to a technology that is able to either diagnose, but we look at it in the full patient continuum of care. So we talk about, is this person able to access education? Is this person able to access a facility that is closer to them, or a mechanism within the existing health infrastructure, that is the community health system, to support this patient to be able to access some sort of, pre-diagnosis that then would initiate a patient referral to a facility that is closest to this patient. So we're talking about level 2, level 3, where then this patient can access care, but also most importantly, looking at how then does this patient get access to the commodities, but most critical for NCD patients, because we are talking about NCDs in this forum, is how do we follow that patient back when they go to the community? A grandmother who is in the community will not be able to come to the facility every single week. Majority of the populations that we serve in the 6 countries where we work today are people who also have other issues that would keep them at home as opposed to them getting to the hospital. These are the breadwinners. These are people who are also active in their farms. And I'll give an example of such kind of a project that has really supported access in Kenya. And of course, as we work with the government in Rwanda to also look at community, but then also linkage to the health centers and back into the communities. Specifically in Kenya, we've implemented a comprehensive access program in collaboration with our partners, Path, who spoke yesterday about commodities, and really looking at using digital health technologies to be able to support the entire patient continuum of care in a way then that after you identify this patient, there is the aspect of education that needs to continue happening. Then how do we leverage on digital technology to be able to improve access to education, to awareness? During COVID, we realized that people actually walk to the hospital, which is very unfortunate. Why should somebody travel? And specifically in this county in Kenya, to travel 100 shillings, Kenyan shillings, to go there and to come back, that's 1,000. Just to be able to access a blood pressure reading. Why should that happen? So that is introducing a huge cost into the health system and a burden to the patient that really also drives them towards non-adherent to care. So when we talk about access, for us and partners that we work with, we look at the entire patient continuum, not only to access the diagnostics, but also to ensure that there is a follow-up and continuous mechanism that we drive these patients towards lifestyle changes, to drive these patients towards compliance, and also to adherence to care. Thank you.
Thank you very much, Eric. Okay, so please, this is not a four-man show. Very soon I'll come to you, the audience, to ask some questions. And we've just received communication that the slide for Dr. Charles is ready. But before we do that, just the technical team, please be on standby. I'll just ask Placide and Eric one question each, and then we'll do Dr. Charles' presentation. Yeah, Placide, thank you very much for your presentation, and I had a chance to look at your website and the work that you're doing. Great work to you, especially around cancer. Currently, you are in 3 districts, 2 in the east, right, and 1 in the north. Do you have any immediate plans to expand across Rwanda and eventually across the region?
So how Partners in Health has been working is we go in some districts, those 3 districts that I talked about, and we implement different programs, several programs, but we've been also had an opportunity to work with the government, MOH and RBC, to expand in different districts, but for specific diseases. For example, the NCD screening that I talked about earlier is happening in more than those, like I think around 80 districts or even expanding to more, but in partnership with RBC and CHAI, because how the ministry has set how NGO are working, we don't just go into different districts, but we make sure that we see a partner who is working for another district, then we partner together to deliver specific services there. So with NCD, but also with cancer, we've expanded to more districts apart from those 3 that we work from, but to make sure that when we go to another district, we are working with the government, but also if there is an NGO that is already in that district, we partner together so that the feasibility of implementation can be very smooth. So briefly, I would say that we expand on district upon need, but for specific diseases, but not like fully how we do the health system strengthening in the 3 districts that we work from. Thank you.
Thank you very much. And how about your expansion plan outside Rwanda, other countries?
Yes, outside Rwanda, it's existing. So Partners in Health is working from, I would say, I think 12 countries. So what we do, we have a head office in the US in Boston, but we also have other sites, for example, in Liberia, Malawi. So that's where we work from. Currently, I would say that there is no plan of extending to another district soon, but when there is an opportunity, we go there. So for example, I would say we were not in Malawi and Liberia, but when there was Ebola, we went there to respond to the Ebola crisis. So yeah, I would say that wherever there are diseases, there is an outbreak, we go there. Yeah, thank you.
Okay, great. Thank you so much. Back to you, Eric. Yesterday, I remember we met for a brief chat, and we discussed around issues around regulation and policies when it comes to digital health. Could you just briefly share with us the experience and the learnings so far? Thank you.
Yeah, thank you so much, Andrea. And I think the issues of regulation, especially for digital health, innovation and startups, is really a thorny one when you compare that with how fast the country wants to move in terms of the digitization efforts. And Dr. Baptiste actually explained it very well earlier on in terms of really having a very clear digital health policy and standards across the country that then enables innovations such as the work that we do and the platforms that supports patient management and care to really speak to each other and integrate across the entire health system. And so across the region, that is the East African region, we see countries are at different stages of being able to appreciate some of the standards that guide then how to work with specific disease technologies or digital health technologies such as the work that we do. Yes, yesterday there was a lot of talk about verticalization of some of these diseases, but I think there is a very big opportunity to leverage on digital technology to be able to harness all these technologies that exist outside there. And as Dr. Baptiste showed, one of those that are currently really missing across the region is the health information exchange standards and policies that then allows technologies to speak to each other, but also most importantly, to feed into the national digital health policy that drives some of these policy directions and also investments into some of this work. The other part that I will talk about also in terms of the regulation and the policies is that across the region we still are sort of battling with how to place digital health solutions. So we have EMR systems that are primarily M&D tools within the facilities. And then we also have primary data collection tools that then support surveillance. And we also have specific disease management tools that really focus on patient outcomes and focusing on longitudinal patient management that then also needs to be taken into consideration. So part of the challenge that we've seen as a digital health organization that works within health systems is that there's no clear guidance on how do you implement such type of solutions, and how do you work within an interoperability framework that most often does not also exist in majority of the countries. So back to what Dr. Kamoto said, you find that in a country there are about 40 solutions, and all of them are talking to one patient. And so you find there is a lot of fragmentation to the countries, because at DHIS level or aggregate level, then it means we don't have quality data that can drive policy decisions. So across the region, and I must applaud Rwanda, because when we sort of approached the government and wanted to work with MOH and RBC, one of the key things was that and was very clear that as you're coming in, this is what we have. And so the
question goes to Dr. Charles, and it is with regards to telemedicine. I think medical workers here, in one way or the other, we have all done telemedicine, maybe through text messages or maybe through phone calls. But there is a problem with telemedicine because medical consultation actually forms part of the administrative obligation of a medical doctor. Automatically, there is a part of it, which is the physical examination, which must be conducted. So we can talk of a medical consultation without talking about physical examination. So it becomes difficult because if you're doing telemedicine, how do you physically examine this patient? So I'll take a case. There is a case in Cameroon where a pediatrician had a phone call from a lady. Questions and participation. Thank you.
Okay, thank you very much. One last question from this gentleman here. Sorry, sir, we're running out of time, but we can get your question.
Is a quick one. I'm Makomi from Kenya. And it can go to any of you guys. I have not heard anyone mention whether you are working with the telecom companies, the providers, whether it's MTN or Airtel or whatever. What is their role in advancing the digital health agenda? Because some of them actually have their own kind of health or information platforms. So, and I've had a lot of challenge. You mentioned challenge with availability of internet in some of the rural areas. So how are you working with them to either avail the infrastructure and also lower the cost? Because then it's not exactly free. I've not had that mentioned. Maybe any of you can make a comment. Thank you.
Thank you very much. Okay, so we have 5 questions here. I'll summarize them. The first one is, how do we involve other healthcare workers, not just the doctors, in telemedicine? So I'll give this question to Placide. Please just answer this question for our lady there. How are we using digital technology for every health worker in the chain apart from the doctors? Just briefly, please. We are out of time.
Yeah, I would say when I heard her talking about doctors and nurses, I was like, oh, this is not for me. They talk about computers. But I would say that when we talk about digital health, we we are not talking about just doctors specifically, because the examples that I've been giving, I've also heard my friend talking about Muzima, how they are working on it. So, for example, if I talk about using Muzima in a cancer screening, nurses have been very important in that role, because the chain starts from the health centers to the district hospitals. And in Rwanda, I don't know about other countries, but in Rwanda, at health centers, we have nurses. Where we have doctors could be in, there are very few, but mostly they are nurses. And those nurses are the ones who are screening the women in the community or even at the health centers. And they are the ones who are entering those data, managing those systems, and connecting to other nurses at the hospitals. So it comes to doctors who are specialized in a cancer care at the hospital, but it's something that has started with nurses. So they've been very important in that, but also in ensuring data quality, because if something, data entry is not good at the level of the health centers, everything will not be accurate even at the level of the hospital. So we are involving the nurses in all the chain of digital health that we're using, and they are very important, mostly at the health centers. They are the ones doing most of the work. Thank you.
Okay, thank you, Placid. Eric, are we working with any telcos or ISPs?
Yes, we are. And maybe just a quick comment on the other cadres that we involve along the patient continuum of care. Yes, we do. And I'll invite you to the stand, Medtronic Lab stand out there in the passageway, and then we can walk you through the different patient touch points. But indeed, in the spirit of task sharing, and as we focus on devolving NCD care to primary, healthcare facilities, definitely we cannot only rely on doctors. The community health workers have a role to play. The nurses, the lab techs, the pharmacists also have a role to play. So, but we can discuss that offline. In regard to tech, companies like Vodafone, MTN, Safaricom, of course, these tech companies have a very significant role to play. And if you remember, I mentioned about when we talk about access, it's about patient education as well. It's about how do we deliver those, even through digital technology, but then most importantly, how do we provide specific decision support tools, real time, that then can support patient management. So in Kenya, for example, we have a very advanced discussion with Safaricom looking at how do we deliver patient education not only to those who have been identified, but also to the general population. And how do we do that concisely in a way then that we have verifiable information that can be accessed. In other countries where we work, like in Ghana, we work also very closely with MTN, really focusing again on patient education. So yes, they have a huge role to play also because of the reach that they do have. And of course, we all know mobile penetration right now across the region is above 80%. So if you don't leverage on those platforms, then we'll be doing a great injustice to our population.
Okay, thank you very much. Jean-Baptiste, the gentleman here is saying 5 years implementation plan is too long. What do you have to say to that?
Yes, there were two questions. The one is
other one is
about
cybersecurity.
the cybersecurity. Yes, yes, we know that the cybersecurity is a threat worldwide, and there is a couple of actually initiatives that we have done in line with this this strategy. One is that there is a law governing how the information will be shared. There is a law that will govern how the personal information will be safeguarded. So that's one. So the ministry itself is doing the policy around data sharing, security, and governance. that we also accompany this law for the implementation of this holistic health information exchange framework. So in addition to that, there is a regular scanning of vulnerability of our system. We know that there is a lot of attacks worldwide, and every week there is a support from cybersecurity team to scan the government system. And where there is a suspect, then they alert the ministry or affiliated institution just to act accordingly. So, which means that there is a lot of thinking around this to make sure that the information is well safeguarded. The 5 years blueprint, yes, when you read, you might say that it's wrong. But when you go into the implementation, it is not. Because 5 years, it does include the implementation or scale up of infrastructure. You know that a digital solution can't not work if there is no enabler, such enabler. You know that the internet in Africa countries. So here we've given these 5 years considering all of these challenges as well as literacy, because this digitalization, it has to go with literacy, increasing the capacity of our citizens just to embrace the technologies. So, and as I touched a bit on the phases, but when you go down into the strategy, there is a lot of work inside. Actually, as you know, it has been done during even some couple of months before COVID. And actually, now we are revising it because it has been hindered by COVID issues. So 5 years in brief, it's not wrong, but we are playing. So
thank you, Jean. But
can have it.
Thank you very much. And the last one on physical examination, Dr. Charles. How are we doing that with all these gadgets we have?
Yeah, thank you very much, Mr. Gakumba, for that very important question. Sometimes I like to think of the options that people have. So very often the options are either not to be seen by a doctor or to have a teleconsultation. So given those two options, you would rather have that teleconsultation if the option is not to be seen by anyone. Let me explain. So I remember a lady whom we began to see in the middle of COVID. This was around June 2020. And so we established, we began doing teleconsultations for her. And the way we do teleconsultations with Daktari Africa, we use video. So this was in the middle of COVID. There was no traveling. There was lockdown in Kenya. You could not travel from certain parts of the country to the capital, for example. But this lady was hypertensive. She was diabetic. She had arthritis. And for a period of time, our clinics in Kenya, both the public ones and the private ones, had closed. And she needed care. She needed medicines. She couldn't travel. So her son, who knew about us, connected us. And we began to see her on video. And sure enough, with that, we were able to control her blood pressure, which was out of control. We were able to control her diabetes. And she did not agree to travel in a public means until February the following year. So all through, on a monthly basis, we had consultations with her. And by the time she came, she was, those parameters were controlled. All we needed to do was now the physical exam at that time. We did an ECG, we did an echocardiogram just to assess her cardiovascular status. We sent her for a physical exam to a rheumatologist for her arthritis. And actually, we have continued to see her that way to date. And she comes very, very seldom for the physical exams because of how well she's doing. Then we also, if she actually was discovered to have cataract because of diabetes. And so we connected her using the network that we have of Daktari Africa. We connected her to a doctor who was close to her. And that way she was able to get the surgery done for her cataract, pay using her NHIF, and eventually get home. So it was complete care. But coming back to the whole aspect of the physical exam and what constitutes a physical exam. So normally, when we see a patient, the first thing is actually to take a history. And actually, 80% of the evidence, shall we call it, right, comes from the history.
Dr.
80%
Charles,
of the
please just wrap up. So
Sure thing.
yeah.
This is an important one, Andrea. So, so 80% of the information to come up with the verdict or the diagnosis comes from the medical history. So when we're teaching our students, we talk of 80% of the information coming from there. So that's the most important part. Then 10% will come from the medical exam, just 10 to 15% of the information. And 5% will come from the medical tests and the x-rays. So that is the whole basis of the validity of telemedicine as a practice. So why do we insist on video teleconsultations? It's because of that 10%. So when you do a physical exam consists of inspection. So you look at the patient and see what does the patient look like. It consists of palpation. It consists of percussion, etc. So those are some of the ways by which we get the medical evidence to be able to make a diagnosis. So with video, you are actually able to carry out the inspection, and you can see a lot. I remember a patient who I was seeing as well, and who I had seen before. So I had the advantage of a previous physical exam.
Sorry, Dr. Charles, I'm going to have to cut you short. Thank you very much for that. We've run out of time, sorry. You can still see him after the meeting. Thank you, everyone, for your participation. We really appreciate. And thank
Another
you
round of applause
the
to our panelists. As I mentioned before, we have a lot to cover, and we are glad we still have our panelists here, especially the digital health topic, which is really broad. We can go on, but you can still access them. So we have been sitting for long. What do we do, Ansh?
Thank you. It looks like it's going to be a very long day of networking. Now, since it is actually the technology we've been talking about, let's use the technology right now. As a .com generation, I want to propose something to you. Now we're going to have the break, and I would like to ask each and every one of us to stand up on our feet. Kindly, with all due respect, let's all stand up, and then I will let you know what we do before we get to the break. Yes, I see people standing up and I see people who are still sitting down. Great. So here is the thing. We're going to have a selfie. I think you've seen a lot of people here. Myself, I cannot feel in their feet because their profiles, their qualifications. I have seen the doctor and the lawyer at the same time. Ladies and gentlemen, let's use the opportunity to take a selfie with that person. The person sitting on your side, take a selfie with them, and let's use the technology to make the awareness of NCDs.
Oh, by the way, yesterday we really had media engagement, which is really impressive.
Yes.
We talked about how we reached about 200,000 people. And then if you didn't make any post yesterday, this is your chance.
Yes, let's trend in Rwanda, East Africa.
Yeah, I can see.
Africa.
I can see beautiful
Alright.
pictures of it.
Yes.
Can I?
Use your mobile phones. Take beautiful pictures and then shout out to Twitter, Instagram, wherever, and make people know exactly what is happening here. Let's make the awareness. Let's leverage our platforms.
All right.
Yes.
We now have 10 minutes of tea break. Then we'll come back. Thank you.
Remember to use the hashtag of the conference. Maybe the team on the Take It can actually reflect the hashtag on the screens. Hashtag of the conference. And tag everyone that you're taking a picture with. And of course, the platform of NCD Alliance.
Kindly use the 10 minutes for tea break.
yarasanze nanze umutima uri ku murimo ingamba narwanye ni nyinshi n'amayeri n'ubuse ni menshi ubu bwinshi mbonganye insinzi nacyuye
You can take your tea inside the hall, please. Protocol, please usher delegates inside the room. Thank you.
Ladies and gentlemen, can we move back inside? Let's resume the program. The time is not on our side.
Kindly regain your seats as we resume our program.
The ushering team kindly supports. Ladies and gentlemen, can we come back inside and regain our seats? Time is rushing like never before. Yes. Yes, that's okay. Fine, thank you. Thanks for bribing. Wonderful. We need to resume our program and we would like to request everyone, to move back to their seats. Thanks. In the meantime, like you can see on the screens in front of you or even on the sides, those are the hashtags. And we would like you to keep making fun of the conference. Make sure that it's going wild. The first hashtag is NCDC, all in caps lock, conference 2022. The second is ACT on NCDs. The third is NCD voices. Make sure that you hashtag that and copy and tag the important platforms. So ladies and gentlemen, welcome back in the hall. I would like to kindly request people who are still outside to move back in the hall. We would like to just catch the time as it is running away from us. Wonderful. Thank you. So for everyone who is back in the hall, from technology to numbers now, we're going to have the next session, which is going to typically talk about the research. And I would like everyone to be here because we all need to know the evidences. We need to know what is happening in terms of numbers. Allow me as well to kindly request people who are still standing to gain back their seats before we resume our program. Amazing. Thank you so much. I'm very glad again and honored to be in front of you today as the MC. So now we're going to have the next session, which is going to be basically on research. What do we understand when we say about research? What do we want to hear? That means we're going to talk about numbers, data. So now allow me to introduce someone which I'm even afraid to welcome on the stage to give us the keynote speech on forgive me, I get back on, all right. On the situation and challenges of research in NCDs in Africa. So a very big round of applause as Professor Christina Stefan steps on the stage. She is the professor in global health and medicine, and she's the director of the Institute of Global Health Equity Research at the University of Global Health Education in Rwanda. Much interesting because personally I'm passionate about that. Proving leadership and developing in the young generation of global health and oncology scientists. Ladies and gentlemen, I can't even feed the feet and the shoes of this woman because she was the first woman elected as the president of the African Organization for Research and Training in Cancer and was voted as the most influential African woman in business and government. If I talk about the education qualification, you will just know that she is the best dynamic scholar in the whole world. So a very big round of applause to Professor Christina Stefan. Thank you.
Thank you so much for the introduction. Really a lot of pressure on me after that introduction. I hope I will be really at the level expected. And I also thank you for the kind invitation of being here to Dr. Francois and to RBC. It is really an honor for me to take part in this, I would say, wonderful conference. It's actually my first attendance to the Eastern Africa. I'm originally from South Africa, but moved to Rwanda at the beginning of the year. So now I'm one of you. So I would consider myself an East African as well. So I stand here today to talk about research. And of course, one of the first things that you might ask, what is research? And there are so many definitions. And what does research for you mean? Again, if you look through the history of research, there are many great quotes, also from recognized scientists and researchers. I would say perhaps that something for all of us that we could relate is that research is to see what everybody else has seen, but think about what nobody else has thought. So what I'm going to talk today in the next 10 minutes or so will be really about the situation and challenges of research of NCDs in Africa. And I will start by just saying no research without action and no action without research. So my first slide starts actually with University of Global Health Equity, which is a relatively new university. And what is so special about this university, and I'm almost sure that everybody in Rwanda has heard about it, but also I would really like to raise the awareness to my colleagues and friends in Eastern Africa, is that this University of Global Health Equity, to which we refer as UGHE, is a unique university. That is a university which is building the next generation of global health professionals, not only doctors, nurses, researchers, public health, policy experts, into leaders and also change makers, exactly what we need at this moment in time in Africa. So I'm the director of the Institute of Global Health Equity Research, an institute, again, extremely new, which could be defined by 4 words: research, innovation, impact, and more than anything, equity. So our vision is really to produce the most impactful and innovative research, again, with the scope of reducing health inequalities. And it is perhaps by no surprise to anyone that NCD is one of the top priority of research at the Institute. And of course, research goes hand in hand with training the new generation of top-class researchers in Africa, but also beyond. And of course, I could not resist the temptation to add a photo of our beautiful campus in Butaro, in the northern side of the country, where our university is placed. So after this short introduction, which I really thought was necessary, let's go and let's move to really our topic for today, the situation analysis of NCD research in Africa. And again, perhaps I don't know if I could make justice to this topic only in few words, but at least it will give you an overview of the situation of NCD research in Africa. So if we look, and we've learned a lot in terms of the number of deaths from NCD in Africa, and we've learned the differences between different countries. Africa is underrepresented in research, but however, carries about 25% of the global disease burden. And as you all know, and as you all talked about, really with a rapid shifting from communicable disease to NCDs, to non-communicable disease. If we talk about research in Africa, this is a slide that perhaps says it all. This is a map, mapping the top African cities by research output, showing where the hotspots of research activity, but also from our point of view, highlights once again the inequities in research and research productivity across the continent. And just to make it easier for you, obviously, is our map, is the map of our continent, and those red dots that you see on the map reflect the number of research. And the bigger the red dot, obviously, the more research takes place in those specific cities. But as you can see, again, in unequal distribution between the south, perhaps expected in a certain way, South Africa, to the north, and maybe not as much research which is needed in Central Africa, as well in Eastern Africa, which we could definitely much more than what we are doing at the moment. If you look again at this slide in terms of research in Africa, so what we could see is the type of disease which are affecting disease which are disproportionately affecting Africa and which are under prioritized. So if you look on the left side, and the slides will be all available for any one of you who would like to have access to them, you will see on the left side the disease burden, and on top still remains HIV, AIDS, lower respiratory, diarrhea, malaria, TB, and so on. But only with 21, so less than a quarter of all articles with at least one African author focusing on conditions causing the highest disease burden in Africa. And this reduced research also is reflected in the number of clinical trials. Only a third really, and cancer comes on top of the list. If we look in terms of research priorities in non-communicable disease, which is the topic of our conference and of our interest, definitely now is the time to go beyond prevalence studies. And then you have listed, if we can have the next slide, please. You can have on this slide the 8 key points for NCD research in low-medium income countries, starting with defining the best practices. Again, what are the most effective interventions, and this time clinical and community-based. And of course, perhaps it's no surprise to any one of you when I make the statement that our research starts at the level of the community with the patient. That's the patient who is actually giving us these research questions and these research priorities. The patient is in the center of all our research. And then, of course, I'm not going to read all of those. We are talking about best practices. Again, we are talking about primary care models for NCD management. We need large cohorts. We need approaches to make sure that our patients understand and they follow the treatment and the treatment protocol. We need to look at the economic evaluation. And of course, why not? We need to explore the complementary and alternative medicines in tackling NCDs altogether. Going a little bit more into science, and again, I'm not going to read and give you all the details. It's only that I wanted to share with you a systematic review done recently, so that means only a few months ago, with few questions. Why do we do research? Why was the study done? And again, the evidence for clinical effectiveness of non-communicable disease and treatment intervention well established. However, we need to have these care delivery models of scaling them up to entire population, which at the moment is not happening. And again, we need to pause for a second and to reflect what does and what does not work in preventing NCDs or achieving NCD control. And then again, what did the researchers do and find? We looked between 1990 to 2020, so over a long period of time, focusing on the WHO priority, NCD prevention and control, and there were about 265 priority prevention and control interventions. But what is extremely interesting, and I would like really to underline and for you to make sure that you have this message, is that the vast majority of treatment were, one, screening, 49%, which is perhaps of no surprise, treatment, 39%, but prevention, only 12%. This is how we stand today after analyzing 30 years of research. So definitely something needs to change. Again, a distribution of priority NCD prevention and control interventions. Those in yellow show prevention. On blue screening. So you see, for example, cervical cancer was on top of the list, a lot of screening, not as much prevention, treatment even less, and then followed by diabetes, hypertension, myocardial infarction, other CVCs, colorectal cancer, and so on. So what do these findings mean? That means that we need to prioritize implementation at scale. We need also to make sure that our NCD programs are sustainable. And also we need to make sure that the implementation science outcomes to effectiveness research and regional collaboration represent the way of going. I will end up just mentioning the challenges in NCD research in Africa. Of course, we need to acknowledge them, but more important than looking at the challenges, really looking for solutions in the future. And one of them is really still the fact that we have a gap between infectious disease and NCD. We do see a move, we do see a transition from infectious disease to NCD. We need to be moving faster and together. Again, we see some silos diseases. We need to integrate as much as we can. For example, HIV research, prevention, screening with cervical cancer. We need to acknowledge that perhaps we do not have as many mentors as we need, and that is our role to really trying to build up capacity. And again, we need to make sure that we are going to have cancer registries, regional data repositories. Data is basically the backbone, the platform from where we could really move forward with the research. We tend to see still a low demand for NCD research by policymakers. It is changing, but not as much as we would like. And almost from the research point of view, non-existence of postdoctoral placements in Africa. So still research careers have a place to go. Of course, the way forward includes many options for us to consider. No doubt that NCD alliances and partners need to move forward with the agenda on the African continent. We need to bridge the existing gaps, and I'm extremely pleased to see so much interaction and so much collaboration in Eastern Africa. I think it will be just the only way on how we move forward. And perhaps I went a little bit too fast with the slides. The slides are all available, but I had a specific reason in mind, and that was really that I wanted to share with you a short video. It's only 5 minutes long. And why I'm sharing it with you, it represents the staff, the team who is working at the Institute of Global Health Equity Research. Is an institute which is ours just as much as is yours. And I wanted to share with you the young, vibrant team who is back at home in Kigali, in Butaro, in Drinkwavu. I have the honor and the privilege to stand here in front of you, but actually the merit, it's not mine. It belongs to all of them who are really dedicated people, and I wanted to make sure that they are part of this NCD Alliance. And if you allow me, I would ask my colleague to start the video with a staff presentation. With the invitation, of course, please join us. We are here to go together and make sure that we will obtain the most impactful, innovative, effective interventions in research on NCD in Eastern Africa.
The Institute of Global Health Equity Research is part of the University of Global Health Equity based in Butaro, Rwanda. As a pediatric The Institute of Global Health Equity Research is part of the University of Global Health Equity based in Butaro, Rwanda. As a pediatric oncologist, my main task for more than 20-25 years was to treat children with cancer, one of the most emotionally challenging but also rewarding careers that anyone in this world could dream of.
What made me join the Institute is that I saw this as an opportunity for growth, not only for myself, but also for the next generation of African researchers.
My reasons for joining the Institute of Global Health Equity, in fact, the interest dates back to 2019 when I first visited Rwanda. So I thought this is, the Institute actually offers the venue for more collaborations to bring in research funding and to help train the scientists from Rwanda and within to address issues of global health.
Before joining UGHG, I worked as a medical doctor in both rural and urban hospitals here in Rwanda. I noticed some undocumented challenges due to lack of equitable research in all health aspects. For instance, we used to rely on evidence generated by others in our daily practices because very few clinical trials take place on the continent, yet Africa represents the most diverse genome in the world, and this leaves many health issues unaddressed. That prompted me to join IGHR to contribute to health research for equity.
My goals in life are to conduct meaningful research projects and to improve health equity for my patients.
When I came to Rwanda for the first time, I was looking for a host institution to support my research permit application. Given the prestigious status of the University of Global Health Equity, it was the ideal institution. In fact, it turned out to be more than ideal. The IGHER has an international team full of talent and expertise in global health research, and a strong network in the health system of Rwanda.
I'm Abel, I'm a visiting fellow at IGHR. I did work through the University of Global Health Equity, and then through a fellowship that I received, I was able to come as a visiting fellow. Joining the team here was an easy choice for me as it presented the opportunity to work with. Well, here I'll be working to identify barriers in accessing cancer screening and diagnoses.
IGHR focus on conducting research, and second component is training. So joining an institution that combines both research and training is an opportunity for me to liberate that.
I joined the Institute of Research because I was curious as to how research can contribute in eradicating health inequities in Rwanda, in Africa, and in the world.
For me, global health was born through global oncology, love and care, empathy, and sharing protocols so much needed on the continent. The commitment and passion and of partnerships and collaboration on the continent, which was so much and is so much supported and encouraged by many in all parts of the world. The Institute of Global Health Equity Research is also about bringing the best scientists in Africa and also unite them with the best scientists and researchers in the world. Why? To focus on some of the most critical problems in the world. And it is also to be able to produce the evidence so much needed for transformation and change.
The research I plan to do when visiting the IGHER is part of my doctoral project to study the impact of social health insurance on the incentives of healthcare providers in East Africa.
So what I really bring to the Institute is my experience. I have trained various students at undergraduate and master's level and have been successful in many competitive funding opportunities.
In terms of focus on research, I would like to see more researchers focusing on both infectious as well as non-communicable diseases, which has been in the
and still growing day after day.
There are many challenges and inequities we're facing in the world today that I believe as an institute we can challenge ourselves in creating solutions for today and tomorrow.
And I'm very confident that we will be able to do this. We will be able to shift the center of gravity for Africans by making sure that our trainings are tailored towards addressing the equity challenges that we face as Africans.
As one of my great influencers, Nelson Mandela, said, education is the best weapon to transform the world. Our institute is advancing well on the mission of training and forming the next generation of researchers, scientists, women researchers and scientists, health leaders who will stand on our shoulders and see a broader horizon for all.
All right. Thank you so much, Professor Christina. Allow me now to welcome a dynamic panel discussion that is going to be moderated with Dr. Catherine Karechezi and have a keen presentation to the speakers. Big round of applause as she steps in front. Dr. Kathleen, you're welcome. Yes.
So, good morning, everyone. My name is Catherine. I'm from the NCD Alliance of Kenya, and I'm actually stepping in on behalf of Grace Dubois of the NCD Alliance, who was not able to join the conference this week. I'd like to call up our panelists who will be participating in this panel discussion. And I'd like the panel to be as interactive as possible. So we'd like to try and give time for each of you, or for those who'd like to ask questions, to the panelists as we progress. And I think I'd just like to thank Dr. Our keynote speaker for giving us a very good background about NCD research and general research in Africa, and especially in East Africa, and the challenges that we face in this regard. So on behalf of the organizers, I'd like to invite the panelists to come up. Firstly, Professor Rulisila Stephen from this, what's this? Let me just look at my notes. Who's a professor of obstetrics and gynecology, and also a principal investigator at the Collaboration for Evidence-Based Healthcare and Public Health in Africa. He is the chair of education and research at East Central and Southern Africa College of Obstetricians. He's a visiting professor at the Department of Obstetrics and Gynecology and Women's Health at Albert Einstein College of Medicine of Yeshiva University, and also a full professor at the University of Rwanda School of Medicine and the Department of Clinical Research at the University Teaching Hospital of Kigali. He has primary interests in clinical care, teaching, and research, and is an active member of different organizations. And he has a passion for strategic problem solving within the health system with the aim of improving clinical care. So please welcome Professor. Our second panelist is Professor Andrew Swai, a founder member and the current chair of the Tanzania Diabetes Association and the Tanzania NCD Alliance. He is also the Dean, Faculty of Medicine and Pharmaceutical Sciences, Kampala International University in Tanzania. He previously served at the Muhimbili National Hospital and Muhimbili University of Allied and Health Sciences as Professor of Medicine, Director of Postgraduate Studies, Director of ICT, and Reform Manager and Director of Clinical Services of Muhimbili National Hospital. He is an accomplished researcher with over 100 publications in peer-reviewed journals. So please welcome Professor Swai. Our third panelist is Dr. Vincent Chubuka, who is a medical doctor, health researcher, and educator. He practiced for several years as a rural clinician, then served as senior researcher and head of the Department of Primary Healthcare at the University of Rwanda. He is currently Director of Research and Training at Partners in Health Rwanda. So please welcome Dr. Chubuka. Chubaka, sorry, I have been corrected. Yeah, Chubaka. Apologies. Okay, maybe I should sit down.
Mortality and morbidity in the world actually surpassing maternal health. So we've been doing a lot of work in NCDs. I'm based at the University of Rwanda and the University Teaching Hospital. So for this particular project, maybe I reserve the rest for questions later if people want more information. SEBA is Center for Evidence-Based Healthcare. We generate data from government or programs on policies, and then we use the data to improve healthcare. We're doing this in 5 countries, which is Rwanda, Malawi, Ethiopia, South Africa, and Uganda. We compare data generated from these countries. We use evidences, and we compare. The uniqueness of this project is that we collect clinical data on NCDs, we collect community data, and we compare with existing policies that are available, and we generate informed policies to improve healthcare, especially on NCDs. Our particular focus is on hypertension, diabetes, and road traffic injuries. I think I will stop here for now, and maybe can elaborate more later. Thank you.
So thank you very much for giving us a snapshot of the work that you do at the Institute. I'd like to pose the same question to Professor Swai, if you could, and maybe also talk about the issues of research in East Africa.
Well, my interest in research began back in 1981 up to 84, when we wanted to find out, can we manage diabetes in the developing world? You know, at that time, these diseases were considered diseases of Western countries. And so we started off a clinic at Maple National Hospital. We followed up the patients for 5 years, and we showed that it is possible. And even with one of the concerns at that time was whether the diet the people were having would allow them to have good control and things like that. So we showed that it was possible to have good control, provided the resources were there. And so my interest in research continued until when I became director for postgraduate studies. I went on to mentor students, many of them. And then after that, I continued the work on diabetes, and not only diabetes now, NCDs in general. And so back in 2014, we formed as a founding member of the East African NCD Alliance to continue this work. And so that's what we are doing at the moment. Now, what I'd like to see happening with the NCD alliances, we are not a research institution, but we are an advocacy institution. So we should advocate for research to be done by those who are supposed to be doing research. We have the National Institute for Medical Research. We have the East African Institutes for Medical Research. What research are they doing, and why should they not research on non-communicable diseases? And so that should be our effort, to push, to advocate for research on NCDs, because we don't have the funds. What we are doing, we're even running the alliances at the moment, we are relying on funds from outside. But we have those research institutes, KEMRI, NIMRI, the East African Medical Research Council, that is their responsibility, and it is for us to push them to do the appropriate research we want. We have things like the state surveys. In Tanzania, they were last done in 2012. nearly 10 years back. They have not been done again. In some other countries, the picture is the same. But who should do that? We cannot, they are costly to do, but it's not for the alliance to do. It is for us to push so that they can be done by the appropriate people. We have the WHO monitoring tool, NCD monitoring tool. Again, governments are supposed to report on a yearly basis to WHO as to what is happening regarding NCDs. We should be advocates to ensure that the tools are filled properly so that we have appropriate data. It is not for us to do the actual reporting, but we should encourage and ask the governments to do that. One thing I think we should be doing ourselves is probably some little research. There are issues like, for example, we are saying we want more funds for NCDs. How much is that? And where should that come from? That information the governments are probably not going to do that. But we can look for small funds to do that information ourselves, because we need that for advocacy. If you want to advocate for the government to push in more funds, you have to show how and where the funds are going to come from. The funds have to come from the resources, the government resources. But then how do we allocate the little budget we have? We have to show the way. And so there are things like that, research required for advocacy. That is what we really need. The other area I think we need to do research is on the intergovernmental, the international trade and the regional trade. And I'm interested in this area because down the line, we are thinking of having regulations on various commodities like sugar, tobacco, alcohol, and so on. Now, we need that research to show us how much of the current trade we have is regional, international, and so on, so that the appropriate regulations can be made. Again, we need to emphasize on our governments to implement the programs we have for the centers of excellence in the East African region. Back in 2012, I think, when our President Magufuli came in power, he realized that there was so much money going out, referring patients outside for various things. And he banned that because it is so much money. Again, so we have the stuff cancer for respiratory and so on. We should again advocate find out what is happening with them, why they are not functioning as they're supposed to do. That again, we can advocate, but we need the research to show how useful that is going to be.
Yeah.
Sorry, I'm taking too much time.
Okay, thanks, Professor Swai. I'd like our last panelist to just give us a brief about the research that you've been doing and how this impacts on NCDs in East Africa.
Thank you, Catherine, and thank you to the organizers for giving me the opportunity to share about the research activities we do at Partners in Health. But I'd first like to talk about my own interest again as a researcher that also started from my clinical work practice. That's where I could realize that there are questions that we have without answer, or if we have an answer, it's an answer that is applicable to the US, to France, to the UK, but not necessarily to our specific context. And that's where I realized that we need to do more research. But as healthcare providers, as doctors, medical doctors, we are not prepared to do research. We are prepared to provide clinical care. And that, I guess, is what is really needed the most, first in our setting, but research is also needed. And that's where I ended up actually learning to do research. And I particularly focused my interest in exploring the best way to capacitate nurses at health center level here in Rwanda to better do their work. As you know, nurses in Rwanda are first trained to work closely with doctors at hospital level. That's the way they are trained in Rwanda, and yet most of them end up working in health centers, in primary health care level, doing both the doctor and the nurse. And then for me, it was important to find ways to fill that gap in their education through supervision, through mentorship, and I've been doing a lot of research around that. Of course, that will include determinant of health and act on them when needed. And that also requires to generate knowledge in informing the interventions, in evaluating also the interventions. Placide, one of my colleagues who talked early this morning, have been talking about screening activities that we are conducting among the general population in the district where we work, but also in specific population at risk like HIV patients. We do that as a programmatic activity, but it's important to embed research questions that will help us not only to know the best way to do it, but to generate also data, information on how impactful, how effective those interventions are for our own use, of course, as an organization, but also to share with others who want to do the same, engage in the same activities to know how to proceed. I can share more about research we are doing, not only in the space of the fight against NCD, but let me stop there.
Okay, thank you very much, Dr. Vincent. I'd like to go back to Professor Stephen, just to give us a bit more about what you're doing in your institute. And then from there, we'll take some questions from the audience. Thank you.
Thank you. What we basically do is we started with desk reviews, whereby we studied screening approaches for hypertension and diabetes, like what is done on the ground, how do people manage hypertension and diabetes. We also studied about the integrated approach for hypertension and diabetes, policy-wise and clinic-wise, how is it done. And then we also went deep into population-level interventions. How is it done? For example, the policy, the government policies on car-free day, screening for NCDs in general. We studied all this, and then we work with the RBCs and the ministries in those countries we work with to have informed the policies that we try to advocate to the government to generate policies that are evidence-based, that are applicable to our communities, and make sure that the community is aware of the impact of these infectious diseases and they can implement them. We have several examples we discovered about the knowledge at the community level of NCDs. We go to the communities, work with them, make sure they understand the impact of NCDs, and then generate policies and policy briefs that can be used to do this. On road traffic injuries, we are actually even now working with the city of Kigali on generating the hotspots in the country, especially in Kigali. Where do we have most accidents? Who caused these accidents? How can we prevent them? You find people here talk about like, we have many people dying of accidents, but you ask who caused accident? Or maybe buses, or maybe motorcycles, but the question is, how much is accountable for what? So we wanted to generate real data in a real time, and we went even to the level of saying, where do most accidents happen? Which part of the town? Which road accounts for more? And then we can work with the police and the city of Kigali and say, hey, maybe you need to put the speed limits at this point, or maybe you need to put this signpost there, maybe it can reduce. And our advocacy is to make sure that we use real evidences to impact the policies and reduce NCDs.
So thank you very much for reminding us that we need real evidence to inform policy, to inform clinical practice, and everything that we do need the evidence to support. And one of the things we really need to do is to generate credible data that can stand up to scrutiny and to any other criticism that may come up. So I'd like to, even as we open up the questions to the audience, if you do have any questions to our panelists, please raise your hand. I'd like to give you the opportunity to contribute Okay, I can see two hands on this side. There's somebody right at the back, and then a lady here in front. How about this other side? Yes, but please keep your questions short so that the panelists have opportunity to answer as comprehensively as they can.
Thank you so much.
Thank you. Please identify yourself and your country.
Yes, I'm called Liberata. I'm a Rwandan critical care and trauma nurse, and I'm teaching at University of Rwanda. So my question goes to Dr. Vincent, who had a good way of assessing skills of nurses where they are serving as they are having like a position of doctors at health center, and as educator and nurse educator, as we review curriculum of nurses, I would like to hear from you if there are some evidence base that you found that can be considered for the next curriculum review for nurses, for us to strengthen their skills while they are serving our people outside there. Thank you.
Thank you. That's a very important question because it's linked the work we are doing in research and how it can influence actually practice, and this in this particular class how it can influence a curriculum review. I've been previously working also. I'm actually a former colleague from the University of Rwanda. And of course, everything we've been publishing around that particular work has been shared with colleagues from the School of Nursing. One of the gaps actually was about the limited of information, skills nurses they get in the diagnostic process, how to diagnose diseases. Yet at the health center, they are the one who are supposed to diagnose disease. Actually, they are at the front line at the, in the Rwandan health system. They're the one who see most of the patient, let's say through patient, outpatient visit. Yearly, they will be seeing more than 10 million patients, while at the tertiary hospital, they are seeing less than 500,000 patients in outpatient visits. Then we have to make sure that they are well prepared in diagnosing diseases, and they have all the tools to do that at that level. And that was a gap actually that could be identified through our study. And interestingly, it was coming from them. They wish to see their primary education as nurses improved to align with their current practice in Rwanda. They should be able to know who is the patient to send back home, because they will improve, no need to give medications, who should be referred to the hospital, and they will say that they don't feel that they are well prepared for that. Of course, with the vertical way of providing care we sometimes have, they'll be doing a good job in dealing with HIV because they got a specific training about how to diagnose HIV, how to treat HIV. That will apply perhaps for malaria. But when you are sitting in an OPD, in an outpatient clinic, you receive all kind of patients, and you may be good in dealing with HIV, but not necessarily in dealing with gastritis or other conditions. Then there are ways to train them to get some kind of generic knowledge that will help them to find what may be wrong here, what are the tests I have to ask here, to request, to inform the diagnosis and the management. And we've been sharing all the knowledge, and we've been even publishing about this work. Another component of that work involved exploring the interaction between patients and healthcare providers, how this happened. And it was at primary care level again, and it was clear that we don't live up to patient expectations when it's about communication, the way we interact with them. And healthcare providers at that level, they will also recognize some gap in their training. They are not well prepared to communicate specifically
with patients. And interestingly, that specific findings triggered a change in a curriculum, not only for nurses, but also for medical students, where we are now emphasizing, I know that because I've been also teaching at the University of Rwanda, we are now emphasizing communication skills as one of the important topics healthcare providers should be prepared for, especially in interacting with patients, but also colleagues, other healthcare providers. Thank you.
So thank you very much, Dr. Vincent, for your response, and thank you for the question. We had another question in that corner. Please identify yourself and your country or organization.
Thank you. My name is Mignon Umurerwa, and I'm a University of Rwanda student. I'm Rwandan, and I'm doing clinical medicine. My question is not going to go specifically to one of the panelists, but any member can answer this. I want to know, do you think there is a connection between strengthening and securing the political will and commitment towards research implementations and today's need for in-depth implementation of research, since we are targeting people-centered interventions and transformative development? Do you think there is a connection between the two? And how does it affect research today, especially in screening, treatment, and prevention of NCDs? Thank you.
Thank you for your question. Professor, would you like to take that?
Yeah. I can take that up. Thank you very much for that. I think there is a huge connection between the political will and the research. The missing link, in my opinion, has always been, I think from the research perspective, researchers are scientists who always look in a tunnel and generate evidence and only keep the evidence to themselves with the assumption that everyone will read it and make use of it. Now, the politicians are always, whenever you sit with them in the room, are struggling to get evidence to inform their policies. So as long as the scientists open up and reach up to the politicians, I don't see any reason why there is no political will. There is always a political will because the government are always looking for ways to solve their problems. And the easiest one is for researchers to generate data for them. If they have the easy way of, if you show them that here is the evidence, if you do this, you will get this impact. Now, that's not the work of the government. It's the work of the scientists to generate this evidence. And now we need the link to put in the same room, like here, the political policymakers and scientists, and we generate this data, we show them, if you do this, you will get this. So I think that was the missing link. Now the IT is the link between them. So we can, what we've been doing in SEBA is that we generate evidence, we generate policy briefs, we invite the government and say, hey, if you want, let's say, to reduce diabetes, or if you want to spread information on what causes high blood pressure or to prevent it, here is what you can do and how. I will give you an example how we challenged. I'm not going to say the ministry here, but let's say the car-free day. Yeah, everyone moves on Saturday, and people like it. You morning and you run. Maybe you run around a bar and the restaurant. You do some exercise, but you say, "Hey, meanwhile, prepare some chicken and 5 beers there. After my 30 minutes run, I will come and take 5 meat and 1 chicken." And you say, but why do you run? They say, well, prevent NCDs. No one told them that the exercise is not per se a treatment. It's to reduce the calories. As long as the intake is bigger than what you spend, you're just wasting your time. And so we tell the government, here is doing exercise is very good, but you can add up something like this. Like even if you take 1 intake, make sure you spend 2 outside in terms of calories. And then people get it to know. So we tell them the best way to solve this problem is this link, but you need to generate evidence. Yeah, otherwise, the policymakers will just write a paper, do exercise, and stop there. How much exercise have how much impact? No one will tell them. The how much exercise reducing how much impact of disease can only be proved by scientists, and that is our work. So I think if you see these things failing, I think you blame the scientists, not the government. It's not their job to generate data. It's not the work of the policymakers to generate evidence, like how much calories do I need to burn a day to prevent this weight. It's not the work of the government. We generate as a scientist and tell them this is how much they need to do. They put it in a policy and we make use of it. Thank you.
Thanks, Professor, for reminding us that we should stop talking to ourselves. We need to include everybody in the discussion and speak to them in a language that they can understand. I think that's the other challenge that we have. We tend to use big words, which only we can understand. So we had a last question on this side. Please make it brief because we do not have very much time. We are running late. So please, straightforward question, which will ask for a straightforward answer. Thank you.
Yes, thank you. My question is to Dr. Vincent. What I would like to know is that considering the fact that we need a good workforce to combat NCDs, and we know that the WHO has set a standard for one medical doctor to a population of 1,000 people. I would like to know, in your role as in the Partners in Health, how do you talk to the government and influence the government in reaching that target? Because I feel like governments are fleeing away from their obligations towards international conventions. That's my first question. My second question goes to Professor.
Sorry, can we only have one question? We don't have time. Thank you.
Thank you. That's a very interesting and relevant question. Just talking about the situation in Rwanda. And of course, I'll be talking about our moral mission as partners in health to make care, best care, quality care accessible to those most in need. And talking about that, there's a problem in Rwanda and as well as in many other African countries. It may even be a global problem. When you look at, I'll talk about Rwanda specifically. The population in Rwanda, it's mostly based in rural area. Actually, 80% of the population is based in rural area. Then when you look at doctors who are practicing in Rwanda, 80% of them are based in urban area. That's already a problem of equity there. How can we assume that 80% of population will have access to the doctors that they need? Then when you look at the ratio, doctor population in Rwanda, we are, of course, we've been doing a good job in improving that. 10 years ago, we were at around one doctor for 16,000 people. Now we are at around one doctor for 8,000, I think, and we keep improving that. But there is still inequity in terms of where those doctors are based. And that's why PIH, we preferentially work in rural area. If we have to help the government to increase that number of doctors, we'll prefer to send them, to motivate them to work in rural areas. Myself, actually, I'm not a doctor who works in Kigali. I work in a rural area. I'm actually based in Ringwavu, which is 3 hours from here, just to make sure that patients there, the majority of patients actually in Rwanda, have also access to those doctors. They have access to nurses. They have access to the care they need near them. There is still a long journey to go, but part of our job also is to advocate, not only to increase the number of doctors, okay, the intake at the university. We even had Professor Christina talking about the new university that we have in Rwanda, UGHE, which is actually an initiative of Partners in Health. And this will not only help to increase the number of doctors, but healthcare providers in general, and preparing them to be ready to work in those rural setting, remote setting, and that's why actually that university is also based in a very remote, one of the remote areas in Rwanda. For those who don't know, Burera, it's in northern region and near actually the border with Uganda. Difficult to access, but having the university there has, of course, given opportunity to increase the number of doctors and other healthcare providers, but it has also contributed in improving I would say general life conditions in that area and giving jobs to people there. Because one of the issue also we have in dealing with that misdistribution is we have to be realistic and pragmatic. It's not only about increasing the number of doctors, it's also about making life interesting where they're supposed to work. It doesn't make sense for me to get well paid, yet I can't get the opportunity to buy that beer Professor Rulisa was talking about. I will leave that area to go where I can buy that beer, okay? And it's very important for us also to...
Sorry, Dr. Vince?
Yes, please.
We need to end the session, so if you can please wind up.
Let me just wrap up by saying that it's a progression, actually. We are doing a good job in improving, increasing the number of doctors, but we still need to do a good job in attracting them so as they work in those rural areas, because that's where the population is. Thank you.
Okay, so thank you very much. I know we are running out of time. I'd just like to give Professor Swai the parting shot to finalize this panel discussion so that we can end. Just very brief comment.
Yes, a sort of an answer to his question. In Tanzania, we have the manning levels approved by government. Only 62% of the people are in place. We have 2,000 doctors, graduates, they are lying there unemployed. And sometimes some years back, there was a strike in Kenya, and we were ready to send doctors to Kenya. So the problem is financing.
So thank you, Professor Swai. Thank you. Yes.
Thank you. Just a quick comment to complement what Prof. Rulisa has said about Car-Free Day. We don't have that on the agenda, but I wanted people not to be misled about what we do with Car-Free Day. From the beginning, Car-Free Day has always been having two targets: mass sports, but also education and free checkup and screening on NCDs risk factors. So not only they do exercise, but the Rwanda NCD Alliance has, from the beginning, been offering that screening component. After sport, they come to have screening, and we take that opportunity to educate them on the NCD risk factors. Thank you.
Yes, the professors have the day. Professor Yonga.
Mine is also very brief, just to add on to what my colleagues in research have said. One glaring area of research in NCDs is health economics. We now advocate for NCDs and health in general not to be positioned as a cost to our governments, but as an investment case, because we know that NCDs can affect the gross domestic product growth of our economies in the sense that it's an expenditure. At the same time, the able-bodied will not be able to produce. So if we position health as an investment to our economy, politicians are more likely to listen to us than as a cost to be incurred. And therefore, the cost of not intervening for NCDs and the cost effectiveness of the different types of interventions, especially primordial prevention interventions, like the best buys, which WHO has positioned, that data can be very powerful in advocating for increasing investment
in the health sector for NCDs. Thank you.
So on that note, thank you, Professor Yonga, for reminding us that we need to invest in health and just change the narrative from health being a cost to an investment for our different countries. On behalf of the organizers, I'd like to thank our panelists. I also like to thank you for your attention and for your interaction. We look forward to continuing the discussion and changing the narrative on research. As Professor Stefan reminded us this morning, that to see what everyone has seen, to see what everyone else has seen and to think what everyone has, but we need to think what everyone has not thought about in order to do research. And also to remember that there's no research without actions, and there's no action without research. So on that note, I'd like to thank you for your attention and wish you a good rest of the day. Thank you very much.
Thank you so much for an insightful conversations. Another big round of applause to the panelists. Yes, now that we have captured the message from Professor Rurisa that we don't need to speak to ourselves, we need to disseminate data to inform policymakers. We are about to hear from researchers, from their abstracts, and the first presenter is Dr. Simon Nyosaba. Nyosenga, I'm sorry. He is a public health specialist with master's degree, Masters of Science in Epidemiology and a Masters of Science in Diabetes. He has a professional experience in program developments, implementation and evaluation over the past 10 years. Currently, he is the Director of Diabetes and Other Metabolic Diseases at RBC within NCD division. He is going to present on using health digital system, NCD tracker, for early case detection and real-time case follow-ups. Please welcome Dr. Niseng.
Good morning again. I'm Simon Pierre Nyonsenga. I work for RBC as Director of Diabetes and Other Metabolic Diseases. And first of all, I want to thank the organizers of this conference for having invited me here, and also allow me to present this abstract on behalf of my co-authors. The abstract is using digital health system for non-communicable and diseases, early detection, and real-time management. So this is the outline, and again, we'll start in NCD in Rwanda. What are the challenges? What is the possible solution, among others, digital solution, and what we have found as a result, and the way forward and conclusion. We will start on NCD in Rwanda. Next slide. That has been presented also with by other presenters here, that we have many undiagnosed NCD patients in our community. And this results in late consultation and occurrence of NCD complication. So we are lucky in Rwanda, we have different policies that's strengthening the NCD screening in the community, starting by a ministerial instruction that came out in 2014. And also we have what we call performance contract, Muhigo, that the Ministry of Health is jointly implementing together with the Ministry of Local Government. So whereby the Ministry of Local Government is responsible for sensitizing population and also supervise the implementation of the performance and report that performance, because the health facility in Rwanda, the hospital, health centers, and community health workers all are under management of local administrative district. So the role of Ministry of Health in this domain is to strengthen the capacity of health facilities in matter of procuring of equipment and make them capable for screening of NCDs. So then the NCD checkup is concerning all people, mostly the male beyond 40 years and female 35 and above. So as I said, we have few cases that we have in our program. So I'm going to take a simple example for diabetes and hypertension. So where, if we look in that category of age 35 and above, we have almost a million of people that we need to have in our NCD clinics in the hospitals. Similarly to diabetes, where we are supposed to have more than 100,000 people in our hospital, but if you see the numbers of people we have already in our program, we are still at 12% of people we are supposed to have in our programs. That means, like the previous panel that was here, if we trust and believe in sciences, so we have a big gap to have people in our program. They are still in our community. So from that, we have analyzed the root cause of this late consultation, and also what are the possible solutions that we can base on to have these people in our programs. So we found that there is a low public awareness on NCDs that cause low uptake on NCD, low uptake on NCD screening, and also few people that we had managed to screen were on paper-based, the flying papers, the registers that were not allowing to make a close and real-time follow-up in our program. And some people not even screening at any time because the information was on paper and registers, where the follow-up of them and linkage to care is not easily possible. So this has motivated us, any digital tool that can help us to following up and have the real data of people screening of NCDs. So again, here I want to, for the next slide, I will show the government where the NCD screening here is free of charge, at least once per year. And if you don't even wish to have a free of charge and you go in any health facility or medical insurances in country, they can screen, and that the service is covered by any of medical insurance in Rwanda. So again, we have invested also in development of this digital tool where the Ministry of Health, Rwanda Biomedical Center, has partnered with HISPE Rwanda to develop this NCD tracker that is based in the DHS2 and can help us to speed up the process and follow-up of screening people across the country. So here are some elements for the next slide. There are some elements that's showing which element that our system can capture. So it have what I can call three parties. One is a profiling of population. The second is looking on anthropometric measures and assessment of NCD risk factors. The last one is measurement of blood glucose and blood pressure. So with this system, the system has features that can allow the clinician that can help clinician that take a decision and quickly the system can interpret the results depending on the numbers they put. I'm not sure if you can see that, but what I want to say, we wanted to make a unique identifier and that everyone has, will not be duplicated in the system. So whereby if you go to the screening site, they will ask you your ID number. So whenever they put your ID number, so the system itself can populate the name correctly, and then there will not be any duplication or errors in typing your names and your location. So then the next step is to put the measurement. The measurement to have been put in the system, whereby if you put any number, any figures or blood glucose, the system itself can predict if this is high blood glucose, it's normal, prediabetes, or is in emergence instance. And for each interpretation, there is aligned action, whereby maybe the system can tell you if your measures are good, maybe you come next year because this is annual medical checkup, you come annually. So there is a step, you are in prediabetes, there is a line education. For people with high blood glucose, that's the same for hypertension. You are invited to go to the health facility for diagnosis confirmation, that's to follow or guidance in diagnosis of diabetes or hypertension. And sometimes if you high values, it's in emergence, the system can say, please bring this person immediately to the health facility to look for medication. So that's what the system can provide. And you go next. For these people who are interested to know, maybe to see this instance, how they are working, in break time, in lunch time, we can have a demonstration outside at the screening. And for sure, people who were in the screening yesterday, we were using this system and maybe had able to look on how is working. So the next slide. Next slide again. That's the normal values and abnormal values. This is to summarize what I've been saying, that is customized to generate unique patient identification, is integrated in a national population registry. The system automatically provides the status and action to be taken using NCD protocol. And again, the system itself can generate dashboard on daily basis or depending on the time you want. And specifically is focusing on diabetes, hypertension, and obesity. And again, we have a different module that's being used by the cancer program with its specification, but the modalities and the functionalities are the same. The next question, the next slide. So since this program has been starting this year, I can say all the health facilities are now using the system. 594 health facilities are using this, and with a big number, at least 3 people at each health center or each health facility are using this system. So from the last 3 months, we have screened 440,000 from the target population. On the right side of the slide, where we have to screen at least every year 3 million of people, and today we are so have screened 404,000 people in the last 3 months. So then you can see it's easy to monitor the progress And we see this because we have used the national level view, but if you go to the health facility, to each community, they can see each target population and the progress they are making. Next slide. Yeah. Other result that we have found is that the tracker assists clinicians to minimize errors by providing outcome, action to be taken, and statistics. And then this system will help us to build cohort, and we can see if we are screening in this year, what your profile next year, and over the year, we will have a cohort of Rwandan population in this age category, together with risk factors and the measurement that we'll be having over the time. So I said that because that everyone will have his unique identifier, and the main document to use is national ID, which I believe we have a high coverage of people. I can say 100% of Rwandan almost have their national identification card. So the next slide will say, even though we have this program in the community that can help us to screen for NCDs, we have a different case management system that is being used in the hospital. And today, those systems are not yet connected. That has been presented before with our first speaker in the morning, Jean-Baptiste, that they are working on that exercise, and even they start piloting the first result from that integration. So in the future, in the way forward, we wish, and we are working that this NCD tracker could connect with EMR, which is a case management in the hospital. So we will see the first bar in blue, and the red one, the very small one. So that cascade of people, identification, the people eligible for screening, how many were diagnosed, how many are starting on treatment, how many are on treatment, and how many are coming for referral or presenting complication, so that we will be able to have one system with all different instances from the community to the health facility and following the same patient for all the levels. So as to conclude with the last slide, we have found that this system is extremely useful as the tool track NCD case as individual level. It creates community cohort, and it will contribute to overall health outcome through NCD case detection, treatment, and reduction of fatality from NCDs. So, I thank you for your attention, and also this is on behalf of people we work together to develop this abstract. Thanks.
You're welcome. Thank you so much for a very nice presentation of the abstract. Ladies and gentlemen, like you can see, I just do not want you to be this quiet again. I can read on your faces that you are feeling tired. So again, with all due respect, stand up on your feet. Kindly. Great. We have different 3 abstracts coming in, and I don't want you to feel that tight. So do anything to stretch yourself as we are fighting NCDs. Yes. Then thank you so much. You can again gain back your seats. So we're going to have Dr. Tahil presenting the abstract about the prevalence and social demographic association of diet and exercise risk factors of non-communicable diseases in both Sierra Leone. A very big round of applause to Dr. And kindly presenters, stick on the time, use 6 and 59 seconds. Thank you, Andrea, for the trick of the seconds. So please use that time and strictly. Thank you.
Hello, everyone. My name is Tahir Bukhari. I am from Sierra Leone. Thank you for your attention. And again, thank you to the organizers for giving me this opportunity to present the research that I've done. Most of the speakers we've had today or yesterday as well have spoken about the journey that most of the countries are taking. Sierra Leone is just one country that has started that journey. The reason why I say that is that in 2017, there was only about 10 publications in this space. So this is quite good, yeah? Yep. So similar to the point that Christina Stefan mentioned, when you looked at the map, there wasn't any red spots with Sierra Leone. The reason for that is that there's only about 10 publications in this space as well. So that's quite true. Prior to starting this PhD, I wanted to do it for one main reason. So I wanted to be a fighter for my community, because in the country, people are not really aware of the risk factors. So just to give you a background to the country is located in the west coast of Africa. Most people within the country, we refer to the country as Salone. So the next time you meet someone from the country, just say Salone, and they'll be like, hey, you know, they like you. So the country itself, back in 2017, was given about £500,000, and that was to support with NCD-like initiatives. Most of the speakers yesterday and today have mentioned that things around problems with NCDs within the countries. Within Salone, there hasn't been any other stepwise survey. The first one that's been done was in 2009. Since then, there hasn't been a second one. So the purpose of my research was back in 2018, I did a similar stepwise survey. Could you move to the next slide? So this used the stepwise survey methodology, and the study itself was conducted in a region called Bo District. Typically, people would think of Sierra Leone and say that it's only Freetown, you know, but the reason why we did the study in Bo is that Bo has a very good typology of both urban and rural-like areas as well. So the study was conducted there. Within the slides, you can see here the number of participants. Could you go back? The number of participants that we recruited, both from the urban and the rural parts within the district. The survey was carried out on a platform called ODK. And you could also see here as well the risk factors that we collected. So things like fruit and vegetable, salt intake, moderate vigorous physical activity, and sedentary behavior as well. Couched to this, we also did biochemical tests, so things like blood glucose, high blood pressure as well. So, but the focus of this presentation is just to focus on the risk factors. If you move to the next slide, so this is the results. If you move to the next slide, please. Thanks. Yeah, so regarding the risk factors, focusing specifically on salt, here about 92% of the study population do add salt in cooking. It's quite unknown currently what that salt is. Is it pure salt? Is it Maggi? Or is it perhaps some other form of salt as well? What was quite interesting with the salt in cooking was when you look at it kind of across men and female, men also said that they do add salt in cooking. Being someone from the country, traditionally men do not cook. You know, you can have a household that is headed by a man, but for certain, the man will have a female or a colleague that would cook for them. So potentially this could be double counting within my view. So if we move on to the, to not move slides, if we move on to the salts at the table, here we can see that about 41% of the study participants do add salt at the table. So again, it's unknown what sort of salt is it? Is it Maggi that they crush and they put onto their food, or is it perhaps salt as well? So This again was concerning for me in terms of prevalence. And then moving on to salty snacks. Here again, only about 31% of people do have salty snacks outside of the house. Again, further studies needs to be done in this space to try to understand what sort of salty snacks are these, To the next slide, please. So regarding fruits and vegetables, so of course, as you know, it's recommended for you to have your 5 portions per day. Within this study population, it was about 83% of the study population did not meet that. That again is concerning, but further research needs to be done here. The reason why I say that is that the country, we tend to eat a lot of roots, green vegetables. So this is your spinach, your crane, your greens. We kind of look at fruits as in like afterthoughts, or maybe if you have the money, you buy it as well. So further research here needs to be done, particularly trying to understand whether fruits and vegetables varies across season, what are the barriers as well. And focusing on moderate and vigorous physical activity, here it's about 22%, 23% do accrue less than 150 minutes MPVA per week. What this suggests is that the country or that study population is very active, so that's great. But when we go down to physical sedentary behavior here per day, we can see that 44% of the study group are sedentary for more than 3 hours. So similar to like MCs here, they said stand up, be active is very, very important, guys, for you to be active, So within the study population, they're sedentary, and that again, if we are to say that we shouldn't try to address this now, maybe another study 5 or 10 years from now could increase that percentage as well. To the next slide, please. So the next slide looks at the associations, next slide. Okay, that's fine. So this slide looks at the different physical activity domains. So I've highlighted here particularly around leisure physical activity. So within the country, just about 31 minutes of leisure activities done per week. That might be concerning to some people, that might not be. So the reason why I say it's concerning is that this is telling you that 31 minutes is used to either jog or run or cycle within the week. It might not be concerning again to some people because it shows that at least as a baseline, we have something to start to work off with, But thinking about some of the interventions here in this city, particularly around the car-free days, that could be perhaps something that Salone should perhaps consider. Or similarly, something similar to what we have in the UK, which is a community-led initiative called Park Run. So Park Run is where you bring together community on a Saturday or Sunday, every week, and you jog or you walk or you cycle anywhere between 3 to 5K. So again, is it that we need to put such interventions in place in Salone as well? To the next slide, please. So this slide basically just depicts the associations between the risk factors and socio-demographic groups. So here, focusing on fruits and vegetables, this was a risk factor, particularly if you are from the urban area, if you're not married, and also if you are pretty much across all sorts of wealth quintile groups. So again, if we are to develop a strategy stroke intervention, these are the sorts of target groups that you would want to pitch it at, Then focusing on the second bullet points here, particularly around salt intake, this was highly prevalent, again, be it if you're in your 40s or be it if you're in your late 70s, 80s, you tended to salt a lot as well. This was particularly the case for men, both salt at the table and salty snacks as well. And then with regards to moderate, vigorous physical activity, this was particularly concerning for those that live in the urban areas that have no education and that are not married as well. And that is the trend across the age groups as well that was studied. And lastly, with regards to sedentary behavior, this again was particularly a problem across all the age groups, and also if you're not married, and also if you have no education. Linked to what some of the presenters have said today, particularly what Christine Stefan said about research into action. So if we go into the next slide, this just shows you what I have done. So I started the PhD in 2017. I finished a month ago. But in that time span, this is the impact I have created. So I've been able to publish 4 articles that I will list on the next slide. Whilst doing that as well, I have engaged with the Ministry of Health in Freetown. That has led to me basically influencing the next NCD plan. As well as that, I have translated the research into layman terms for the locals to also understand, both at the newspaper level and also with regards to radio talk shows as well. So not just focusing on people that have access to buy. Could you go back a slide, please? Thanks. So not just having people that have access to buy the newspapers, but also trying to focus with people that have access to radio as well. So that's what I've done. And the last 2 points here is that as a result of this research, a stroke unit has been set up in Bow. There's going to be further talks with Cambridge Global Health and King's partnership regarding how to basically fund that second stroke unit. And lastly, with the last bullet point here, I have set up the Sierra Leone NCD Alliance. This was really something that's needed within the country because you have a number of civil society organizations that range from kidney disease, cancer, mental health. So what I am trying to do here is to bring them all together so that we can have one word and to be able to push forward and to take that fight to the community to change lifestyle factors around it. If you could just go to the next slide. So the next slide just shows you some of those publications. There is another 3 that I'm due to publish in the new year. And if you go to the next slide, please. The next slide just shows you my contact details. Would be very happy to speak to people further. Just to give the next slide, please. Oh, it's not moving forward. Okay, that's fine. So the next slide basically just shows my contact details and a bit of a background to myself. And I would be happy to connect with people both from the perspective of population health management or like innovations. So just a background to myself. I work in the UK, specifically with NHS England in the digital health team. I am due to be working in Freetown at the Ministry of Health in January for 2 years. So I will be there posted as a fellow. And there was another thing I wanted to share with you, but for some reason, the slides can't go forward. But if you can find me on Twitter, my Twitter name is Tai, T-A-I, and then _Bob. And there is a Tableau dashboard that I have created, which basically charts out the number of NCD-related mortalities across the country by region. And the Tableau board is quite interactive in a sense that you can tap onto a region and the other charts around it would basically change and like alter. And that just shows to people within the country and also like external people the causes of mortalities related to NCDs and how that charts out across, be it if it's the age groups or certain risk factors as well. So I would like to close there, and if there's time for questions, I'm happy to take one or two questions. Thanks.
Dr. Tahi, you have to excuse us. Due to the limited time, we will reserve the questions for the presenters outside because we do have even more abstracts outside. Thank you so much for your presentation and the work that you have done and the impact you have created. So thank you so much. Our next presenter is Professor Madeleine. She will present on an adapted collaborative care model to manage and the comorbidities of depression and chronic non-communicable diseases in Rwanda. Welcome, Professor.
Greetings, everyone. My name is Madeleine Mkeshimana, of course. I'm based at the University of Rwanda, School of Nursing and Midwifery. I'm presenting an adapted collaborative care model. This is a model which is aimed to manage the comorbidity of depression and non-communicable disease. So I adapted this model in Rwandan context. I acknowledge Professor Divon that has worked at this project with me. WHO is recommending that all countries implement the CCM model. This is collaborative care model to manage the comorbidities of depression and other NCDs. This is not only depression and NCDs, but the comorbidities of mental health issues or mental health disease with other NCDs. This is a model that uses a multidisciplinary team composed by mental health care professionals and medical health care professionals to work collaboratively together to care for the patient who is having both disease, I mean mental health disease and NCDs. This is a model originally developed by a research team from the University of Washington. Since its conception, this model has been used to guide the management of depression associated with NCDs like diabetes, hypertension, cancer, and other different types of cancers. But why are we talking about this CCM model? Why are we talking about caring collaboratively the patient who is having depression and NCDs? You can understand that if the person has NCD, for example, a cancer, diabetes, hypertension, this person has, unfortunately, the high chance to get also depression or other mental health issues. Why? First of all, depression or mental health issues are also NCDs. They share the same biological, environmental determinant. But also, if someone is having NCD, the person has to adjust to the diagnosis of NCD, living with the pain, disability, social and economic consequences. So therefore, the evidence has shown that the prevalence of depression is 2 to 3 higher times in people with NCDs. This is true. It is not something that we are just talking. And we do have some statistics. For example, a systematic review that has been done in South Asia found out that depression was at least 40% in patients with diabetes, 37% in patients with cancer, 38% in patients with hypertension, 39% in patients with stroke, and 44% in patients with chronic obstructive pulmonary disease. Imagine someone has NCD and this person is suffering also depression. What about Rwanda? In Rwanda, we have done a survey. It was in 2018. And we found out, we worked with patients who are having hypertension and diabetes. We did this survey in these 7 district hospitals across Rwanda. What did we find out? We had a sample size of 637 patients. Among those 637, 604 had screened positive for depression. And among those ones, that's mean 94.8%. So among those ones, 61 screened moderately severe to severe depression. People who are there, who are in the mental health sector, they understand what does it mean. So if someone is screening for severe depression, the person can even commit suicide easily, and you don't know what is happening. And among all these people who screened positive for depression, 351 people screened mild to moderate depression. This is something serious. That was a survey done in all 7 district hospitals in Rwanda. However, surprisingly, among all these patients screened, none of them knew that he or she had depression. They never screened for depression. They were never treated for depression. They just come, receive treatment for diabetes or hypertension, they go back home. They go back home with severe depression, and you are there, you think that this person is going to take the medicine. How? So sometimes these people, the mortality is linked with mental health problem, and we are there thinking it is a medical issue. So that's why we are talking about this collaborative care model. So how did we do that? The design, the method. So this was part of my PhD study. And the CCM model was adopted by by a research team composed by 14 healthcare professionals. So we were together as mental health professionals, as medical doctors, and as nurses. So we had two psychiatrists, 3 mental health nurses, 3 medical doctors, 5 registered nurses, and then the researcher. We used what you call a research practice partnership. This is a method you use when the people in practice, healthcare professionals in practice, come together with the researchers to identify the problem and also to propose the solution and implement it. However, we were also guided by what you call impact study. If you go to Google or wherever, you can read this impact study. It has been done by other authors. They use this model, or they implemented this collaborative care model to guide the management of depression in elderly patients. So we're guided by impact model. However, we had also what you call the iterative process just to adapt our model. The iterative process indicates the steps you need to follow when you want to adapt a new guideline or a model somewhere. So it had the steps. First of all, you review the existing model, you identify potential key components, you map data for the adapted. So we adapted the model. Of course, we tested the model. We tested the model in one district hospital, and we used a sample of 30 patients who screened positive for depression, especially moderate to severe depression, and we tested for 12 weeks. Afterward, we went back to evaluate the applicability and acceptability, and the results were positive. So what did we adapt? So normally you understand there is the original model there and there is a model which is adapted. So the original model, we didn't adapt so much, but we had to adapt it to the Rwandan context. So 4 structure components were maybe adapted, added. First of all, we added a registered nurse because in Rwanda we still have to orient our people, and as you say, our medical doctors are not so many at the district level. So that's why registered nurses are there to back up the medical doctors. Second, we relocate this model from the primary healthcare model. The original one is at the level of primary healthcare, but for us, we put it at the district level because it is where we can find the team of mental health nurses and also medical doctors. Thirdly, the initial model, the psychiatrist visit every week, but in developing countries like in Rwanda, you cannot find a psychiatrist to visit every week. So for us, we suggested to visit like every 3 months. So this is the model. I don't know if they are just next slide. You can put the next slide. We have the model, and the highlighted part indicates the part we adapted or we just added. That's what I was talking about. So what has been done in Rwanda up to date? As I said, we were able to implement this model in 7 district hospitals. That was with the help of the University of Rwanda, which gave us financial support. So we screened the people, and I told you the results. Second, we trained the collaborative care teams. 19 people were trained. And then we started initiating the implementation in all these 7 district hospitals. And after 3 months, I think, we went there to evaluate the acceptability and also applicability. The results were really amazing, but also shocking. So, for example, I'm quoting one patient who said, I have never heard about depression before. Now, I understand that I see that even I got my hypertension as a result of my depression, considering the stress, challenges and the problems I had, I see that this depression is even the mother of my hypertension. So please go next. Next again. So I'm calling for actions. For Rwanda, I'm calling any partner, you know, WHO, public, private. You can join us so that we can implement this model in the rest of the remaining of district hospitals. We do have 43 district hospitals. For the regional and other countries, if you are still implementing the fragmented care, meaning you receive a patient with NCD, you just only consider the NCD without considering the mental health part, please be reminded that this is an issue and you can just implement the collaborative care model. Next, please. So those are the references. Next. And if you can put next, I have nice pictures there to say thank you so much. I thank you for attention.
All right, we thank you as well for a very nice presentation. Yes. All right, the lady stepping in front here in red is Dr. Claudine, who is going to present to us the abstract that is going to explain more on the first Rwandan diabetes self-management smart photo application technology here. Women in tech, grab the mic. Thank you.
Thank you. Thank you, Ange. I guess people are hungry, but I try to be short as possible. And from depression, let me take you back to the technology. Oh, if you could have, I know many people here are using their WhatsApp. So I have a question here, and it is, if you could have an application like WhatsApp in your smartphone that could help you self-managing your diabetes, how would you like it to assist you? Of course, you're not diabetic. Most of you are not diabetics, but that question was asked to Rwandan diabetics, that is back in 2018, and their answers read to the development of the very first diabetes self-management application that we called Kira app. Good afternoon. My name is Claudine Kaweza, and I had a chance to be the PI of that beautiful journey, and I'm going to tell you the whole story. If I can have my presentation, please. So that was the question I told you about. Their answers, as I said, led to the development of the first diabetes self-management that we called Kira app. This is in Rwanda, Kira app. Yes. Next slide, please. As we all know, diabetes is a threat to the world, to Africa, and to Rwanda. And when we diagnose a person with diabetes, the first challenges they meet, next slide, the main challenges they meet, first of all, we tell them to accept that, new diet plan that is not fun at all. We tell them to adhere to the strict treatments we prescribe to them, and then we tell them to start exercising. Many people have not even done this before. A key solution to this is to tell our patients to be their own doctors, not to tell them only that, but to teach them how to become their own doctors. And one of the key solutions is to empower them. In order for them to become their own doctors, we need to empower them. And ladies and gentlemen, mHealth technology, next slide, through the interaction with healthcare staff, safe and telemonitoring, has shown to contribute much in empowering diabetic patients and to deal with almost all their health challenges. When I talk about mHealth technology, understand that last year, 3.8 billion people were using smartphone, you included. And at the time we conducted this study, that is we designed this study, that was between 2016 and 2017, we had 25,000 people who were using mHealth. In the world, there were mHealth apps. Maybe I should come here. I cannot see the slide well. Sorry. In 2016, there were about 325,000 mHealth apps in world, and among them there were 1,500 diabetes-related app. And here, for information, there was 0 app in Rwanda. And this year, if you didn't know that, diabetes is expected to be the first to offer the best potential for mHealth apps market. Next slide. So all those numbers, motivated us to develop the very first diabetes self-management application to our Rwandan diabetes. What were our objectives? First of all, we assessed their needs and the expectation from that very first diabetes app. Why this first objective? Well, we wanted to prevent the limitation which are found in existing apps. Some apps are just being readily presented to users without prior consideration. And many studies are recommending that from the planning to the implementation, there should be a user-centered method, to develop it. So this is what we did with our first objective. And our next slide was to develop the app according to the... Now, how did we do this? First of all, next slide. How did you do? For your information, the first and the last objectives resulted in 2 studies which were published. Here we used a qualitative, for both studies, we used a qualitative study design. Our target population were type 1, type 2 diabetics who were registered in the RDA, or the Rwanda Diabetes Association. And for your information, that association is visited by both urban and rural patients. For our eligibility criteria, you had to be Rwandan, you had to be age 18 and above, and to be registered in the RDA. And very interestingly, to have access to a smartphone, of course, because so far, even now, there was no database of Rwandan diabetics owning smartphone in the RDA, even now. We use the same structured face-to-face in-depth interview, and for our data analysis, we used thematic analysis according to the Mary's methods of qualitative data analysis. So, and for the first study, next slide. For the first study, we used an inductive approach because there were no data. We used an inductive approach to form categories in the first iteration and subcategories in the second iteration. For the second study, we used the deductive approach because we had now original categories and subcategories. And of course, we also went back to inductive approach where we had new category and subcategory. Now, what did we find as a result? Next slide. For this first study, we had 21 participants. We had 21 participants participating in our study. There were 11. Next slide, please. Yeah, sorry. We had 21 participants. There were 11 type 1 diabetics and 10 type 2 diabetics. Their age range were between 18 to 69 years old. Yes, we have moms who are using WhatsApp and could use KILAP. And 6 separated their smartphone knowledge and skills as excellent, 4 as very good, 8 as good, and 3 as poor. They also rated, 1 rated their frequency of smartphone usage per day as less than once a day, another one as once a day, and 19 more than once a day. And very interestingly, all the 21 participants reported that they would like to have a smartphone application supporting them in their diabetes management, either by being very strongly supportive and saying, wow, that would be wonderful, that would be fantastic, or just by being just open-minded and say, well, if this can help me managing my disease, why not? Yes. Now, what were their wishes and expectation? First of all, they wished to have, you can imagine how much they were excited. That was going to be their very first diabetes, smartphone application. And we recorded much of their expectations and needs. So after analysis, we tried to categorize them in 8 themes. The first theme, we called it diabetes education and desired information provision. Here, we gathered all their wishes and expectations they had from the app. They wanted an app that could give them general information on diabetes, its management and complication. They also needed an app which could give them information on
medical parameters, on the use of medical devices, on frequently asked questions on diabetes, and on national and regional updates and care on diabetes. They manifested much of lack of knowledge and awareness on diabetes, and they wish to have an app that could help them, fill that gap on knowledge on living with diabetes. They also wanted an app that could give them, true information on prejudice and myth and fake news, which is around diabetes out there on social media. They also needed an app that could teach them on how to use all those digital technology that we are bringing them. As a third theme, we called it crisis intervention. Here we gathered all their wishes and the needs they wanted on how to, on an app that could help. Theme we called it monitoring and reminder. Here we gathered all their wishes they had on the app that could help them managing their blood sugar, monitoring and remind them how to when and to take their blood sugar. The fifth one we called it nutrition and alcohol consumption, and they needed an app that could teach them everything about food and drinks. One interesting component was that they needed to know if they can take some alcohol, because many doctors here out there tell them to stop alcohol. And they wanted those an app which can, bring their pressure to it, because with those that we prescribe them, sometimes they lose their pressure to it. Very sadly. 6, they wanted an app also which could help them to do physical activity, to teach them which kind of exercise to do, or motivate them to do it, and how much and when to do it. 7, to cope with the burden of disease. They wanted an app that could give them emotional and social support. And lastly, it was about app features. They told us how they wanted that app information to be delivered. Yes, and in which languages. Now, from their needs and expectation, we developed Kira app. This is how Kira app looks like on your Google Play Store. You can check it. And for using it, you need to accept the terms and conditions. Next slide. From their needs and expectation, we literally developed all the content of Kira app. It has 10 pages, from general information to food, to physical activity, to blood sugar, to food care, to diabetes health checkup. This we included as they needed and as they expected. And for your information, Kira app is what is called DSME app, which means Diabetes Self-Management Educational App. It's just for education. The information there is provided through images and text. Next. Once KILAP was ready, we went back to the participants of the previous study and we installed KILAP in their smartphone. We taught them how to use it. And then after 3 months, we come up with our last study that was to evaluate their experiences with this app. What did we find? Actually, you imagine the happiness you have when you find that your wish have come true. That's what they were. They couldn't believe that the app was already in their smartphone, and we recorded a bunch of their experiences. Next slide, please. Unfortunately, so the aim of this study was to check whether the outcome expectation assessed during the previous study were met by the initial prototype of Kira app. Here we assessed their negative and positive aspects of Kira app as identified by the users, and then we collected their suggestion to improve the app. Yeah, to finish, what did they tell us as experiences? Next slide. Well, among the 21 participants of the previous study, we only could reach 14 participants. That's the one who participated in this last study. And they were very good users of smartphone, because most of them had some of their smartphone stolen or lost and so on. And those one could afford to buy a new one, mostly because maybe they like it. Last slide. Next slide, sorry. So on the previous theme we have assessed, of course we could not put everything in the app. So with their experiences evaluation, they were happy to find, but they were very happy to find most of their need and the expectation in the app. Of course, few of them were missing,
like the crisis intervention. They wanted an app that could tell them that you are going to fall in low blood sugar or you are high blood sugar, and then to inject insulin or give them something to eat to prevent that. Unfortunately, you couldn't put it in Kira app. So researchers, please take note on this and include this in your application. We had some people who know, they could, those subcategories that striked out. They could, no one reported the experience with it, because most of the time, I mean, most people who express it as a need or wish were not in the study, but the information is available in the application. Something was also missing was the social support. They needed a platform as diabetics in the app where they could chat and, interact. This is also missing in the app. As I said, it is mainly educational application. But they were very happy, with the beautiful colors and images which are in Nikila app. And but they also would say that they wanted more pictures and more videos and more audios in the app. Something which was very interesting was that they were very happy also to have the information they needed on their disease in the language they could understand, because Kirap is both in Kinyarwanda and in English. As conclusion, we were happy because the findings of this project showed that the participants' major expectancies were met. Their reported experiences with the app demonstrated that the use of Kirap can lead to the health behavior changes. However, they expressed their needs for in-app social media platform, chat room, and for more visual elements and plainer language, more simple language. What is the way forward? Of course, we had some limitation which go mainly with qualitative, research design. Last slide. What is the way forward with Killer App? First, we are going, it has been downloaded by more than 500 people, Android users, but it's not available on iOS, so we are going to make it available for iPhone users also. And it has a platform where diabetics can ask questions to a diabetes educator. So they keep receiving a lot of questions from the diabetics, and we are working on studies to evaluate the effectiveness of Kira app on diabetes health outcome. And from user suggestion, of course, we are going to make improvements in the content and the presentation of the app. For further e-health researchers, I will just advise you not to, to develop an app that provides educational content only. Please include utility functions such as automated text message, virtual health coaching, wearable blood glucose meters, and insulin management, because it is, on trend outside there. I thank you for your kind attention, and bon appetit.
Yes, she actually ended it very well. Thank you so much for a good presentation, and she also wished us bon appetit. So which means we're going to launch now. So kindly let's all of us actually agree on how much time we're going to use.
We didn't want to be rude with the presenters this before noon, since it's the last day, so we want to cover it up. But let's try to use as limited time we have to get back here on.
Okay, now we are
Seriously, 15.
We are almost 140, right?
So let's be back here around
2:15.
2:15.
Yeah.
Please. All right.
All right. So, muryoherwe, bon appetit, and enjoy. Thank you. And please, for the people who wants to ask the presenters on the abstract some questions, there are some posters outside, and you can always quick chat with them. So enjoy and kindly pass by and see some interesting researchers.
multi-parametric and random accessible system, providing accurate diagnostic results. Two different models can be used, depending on your workflow requirements. F200 is the user-friendly designed FIA analyzer. Its compact design and convenience of use will make your lab work easier and smoother. F2400 is focused on providing shortened turnaround time with its high throughput feature and highly reliable test results. Standard F is a simple 4-step process that requires minimal training. Just insert the test device, collect specimens, dispense the specimen into the test device, and press the Test Start button. The F200 provides 2 modes. For 1x1 test, you can use Standard Test Mode. For batch tests, you can proceed with the Read-Only mode. You can perform random access test at once, as the 2D barcode on the test device includes information for each parameter. Standard F provides objective test results with COI value. Patient ID written on the test device is scanned on the result paper. This provides user-friendly function, especially when you use read-only mode. 53 parameters are available with Standard F analyzers. The analyzer transmits test results to the operator's smartphone, cloud server, PC, and LIS/HIS for convenient data management. It is a simple process, automated reporting, and a parameter expandable system. Standard F will be the good diagnostic partner of your laboratory. Is it the flu? Am I diabetic? Do I have COVID-19? Standard F can answer these questions. Fluorescent immunoassay method. High sensitivity. Accurate results. Standard F gives you more to predict the disease. Standard F is a next-generation fluorescent immunoassay system capable of quantitative and qualitative analysis. It is a multi-parametric and random accessible system providing accurate diagnostic results. Two different models can be used depending on your workflow requirements. F200 is the user-friendly designed FIA analyzer. Its compact design and convenience of use will make your lab work easier and smoother. F2400 is focused on providing shortened turnaround time with its high throughput feature and highly reliable test results. Standard F is a simple 4-step process that requires minimal training. Just insert the test device, collect specimens, dispense the specimen into the test device, and press the Test Start button. The F200 provides 2 modes. For one-by-one test, you can use standard test mode. For batch tests, you can proceed with the read-only mode. You can perform random access test at once, as the 2D barcode on the test device includes information for each parameter. Standard F provides objective test results with COI value. Patient ID written on the test device is scanned on the result paper. This provides user-friendly function, especially when you use read-only mode. 53 parameters are available with standard F analyzers. The analyzer transmits test results to the operator's smartphone, cloud server, PC, and LIS/HIS for convenient data management. It is a simple process, automated reporting, and a parameter expandable system. Standard F will be the good diagnostic partner of your laboratory. Is it the flu? Am I diabetic? Do I have COVID-19? Standard F can answer these questions. Fluorescent immunoassay method. High sensitivity. Accurate results. Standard F gives you more to predict the disease. Standard F is a next-generation fluorescent immunoassay system capable of quantitative and qualitative analysis. It is a multi-parametric and random accessible system providing accurate diagnostic results. Two different models can be used depending on your workflow requirements. F200 is the user-friendly designed FIA analyzer. Its compact design and convenience of use will make your lab work easier and smoother. F2400 is focused on providing shortened turnaround time with its high throughput feature and highly reliable test results. Standard F is a simple 4-step process that requires minimal training. Just insert the test device, collect specimens, dispense the specimen into the test device, and press the Test Start button. The F200 provides 2 modes. For one-by-one test, you can use standard test mode. For batch tests, you can proceed with the read-only mode. You can perform random access test at once, as the 2D barcode on the test device includes information for each parameter. Standard F provides objective test results with COI value. Patient ID written on the test device is scanned on the result paper. This provides user-friendly function, especially when you use read-only mode. 53 parameters are available with standard F analyzers. The analyzer transmits test results to the operator's smartphone, cloud server, PC, and LIS/HIS for convenient data management. It is a simple process, automated reporting, and a parameter expandable system. Standard F will be the good diagnostic partner of your laboratory. Is it the flu? Am I diabetic? Do I have COVID-19? Standard F can answer these questions. Fluorescent immunoassay method. High sensitivity. Accurate results. Standard F gives you more to predict the disease. Standard F is a next-generation fluorescent immunoassay system capable of quantitative and qualitative analysis. It is a multi-parametric and random accessible system providing accurate diagnostic results. Two different models can be used depending on your workflow requirements. F200 is the user-friendly designed FIA analyzer. Its compact design and convenience of use will make your lab work easier and smoother. F2400 is focused on providing shortened turnaround time with its high throughput feature and highly reliable test results. Standard F is a simple four-step process that requires minimal training. Just insert the test device, collect specimens, dispense the specimen into the test device, and press the Test Start button. The F200 provides two modes. For one-by-one test, you can use Standard Test Mode. For batch tests, you can proceed with the Read-Only mode. You can perform random access test at once, as the 2D barcode on the test device includes information for each parameter. Standard F provides objective test results with COI value. Patient ID written on the test device is scanned on the result paper. This provides user-friendly function, especially when you use read-only mode. 53 parameters are available with Standard F analyzers. The analyzer transmits test results to the operator's smartphone, cloud server, PC, and LIS/HIS for convenient data management. It is a simple process, automated reporting, and a parameter expandable system. Standard F will be the good diagnostic partner of your laboratory. Is it the flu? Am I diabetic? Do I have COVID-19? Standard F can answer these questions. Fluorescent immunoassay method. High sensitivity. Accurate results. Standard F gives you more to predict the disease. Standard F is a next-generation fluorescent immunoassay system capable of quantitative and qualitative analysis. It is a multi-parametric and random accessible system providing accurate diagnostic results. Two different models can be used depending on your workflow requirements. F200 is the user-friendly designed FIA analyzer. Its compact design and convenience of use will make your lab work easier and smoother. F2400 is focused on providing shortened turnaround time with its high throughput feature and highly reliable test results. Standard F is a simple four-step process that requires minimal training. Just insert the test device, collect specimens, dispense the specimen into the test device, and press the Test Start button. The F200 provides two modes. For one-by-one test, you can use Standard Test Mode. For batch tests, you can proceed with the Read-Only mode. You can perform random access test at once, as the 2D barcode on the test device includes information for each parameter. Standard F provides objective test results with COI value. Patient ID written on the test device is scanned on the result paper. This provides user-friendly function, especially when you use read-only mode. 53 parameters are available with Standard F analyzers. The analyzer transmits test results to the operator's smartphone, cloud server, PC, and LIS/HIS for convenient data management. It is a simple process, automated reporting, and a parameter expandable system. Standard F will be the good diagnostic partner of your laboratory. Is it the flu? Am I diabetic? Do I have COVID-19? Standard F can answer these questions. Fluorescent immunoassay method. High sensitivity. Accurate results. Standard F gives you more to predict the disease. Standard F is a next-generation fluorescent immunoassay system capable of quantitative and qualitative analysis. It is a multi-parametric and random accessible system providing accurate diagnostic results. Two different models can be used depending on your workflow requirements. F200 is the user-friendly designed FIA analyzer. Its compact design and convenience of use will make your lab work easier and smoother. F2400 is focused on providing shortened turnaround time with its high throughput feature and highly reliable test results. Standard F is a simple four-step process that requires minimal training. Just insert the test device, collect specimens, dispense the specimen into the test device, and press the Test Start button. The F200 provides two modes. For 1x1 test, you can use Standard Test Mode. For batch tests, you can proceed with the Read-Only mode. You can perform random access test at once, as the 2D barcode on the test device includes information for each parameter. Standard F provides objective test results with COI value. Patient ID written on the test device is scanned on the result paper. This provides user-friendly function, especially when you use read-only mode. 53 parameters are available with Standard F analyzers. The analyzer transmits test results to the operator's smartphone, cloud server, PC, and LIS/HIS for convenient data management. It is a simple process, automated reporting, and a parameter expandable system. Standard F will be the good diagnostic partner of your laboratory. Is it the flu? Am I diabetic? Do I have COVID-19? Standard F can answer these questions. Fluorescent immunoassay method. High sensitivity. Accurate results. Standard F gives you more to predict the disease. Standard F is a next-generation fluorescent immunoassay system capable of quantitative and qualitative analysis. It is a multi-parametric and random accessible system providing accurate diagnostic results. Two different models can be used, depending on your workflow requirements. F200 is the user-friendly designed FIA analyzer. Its compact design and convenience of use will make your lab work easier and smoother. F2400 is focused on providing shortened turnaround time with its high throughput feature and highly reliable test results. Standard F is a simple 4-step process that requires minimal training. Just insert the test device, collect specimens, dispense the specimen into the test device, and press the Test Start button. The F200 provides 2 modes. For 1x1 test, you can use Standard Test Mode. For batch tests, you can proceed with the Read-Only mode. You can perform random access test at once, as the 2D barcode on the test device includes information for each parameter. Standard F provides objective test results with COI value. Patient ID written on the test device is scanned on the result paper. This provides user-friendly function, especially when you use read-only mode. 53 parameters are available with Standard F analyzers. The analyzer transmits test results to the operator's smartphone, cloud server, PC, and LIS/HIS for convenient data management. It is a simple process, automated reporting, and a parameter expandable system. Standard F will be the good diagnostic partner of your laboratory. Is it the flu? Am I diabetic? Do I have COVID-19? Standard F can answer these questions. Fluorescent immunoassay method. High sensitivity. Accurate results. Standard F gives you more to predict the disease. Standard F is a next-generation fluorescent immunoassay system capable of quantitative and qualitative analysis. It is a multi-parametric and random accessible system providing accurate diagnostic results. Two different models can be used depending on your workflow requirements. F200 is the user-friendly designed FIA analyzer. Its compact design and convenience of use will make your lab work easier and smoother. F2400 is focused on providing shortened turnaround time with its high throughput feature and highly reliable test results. Standard F is a simple 4-step process that requires minimal training. Just insert the test device, collect specimens, dispense the specimen into the test device, and press the Test Start button. The F200 provides 2 modes. For 1x1 test, you can use Standard Test Mode. For batch tests, you can proceed with the Read-Only mode. You can perform random access test at once, as the 2D barcode on the test device includes information for each parameter. Standard F provides objective test results with COI value. Patient ID written on the test device is scanned on the result paper. This provides user-friendly function, especially when you use read-only mode. 53 parameters are available with Standard F analyzers. The analyzer transmits test results to the operator's smartphone, cloud server, PC, and LIS/HIS for convenient data management. It is a simple process, automated reporting, and a parameter expandable system. Standard F will be the good diagnostic partner of your laboratory. Is it the flu? Am I diabetic? Do I have COVID-19? Standard F can answer these questions. Fluorescent immunoassay method. High sensitivity. Accurate results. Standard F gives you more to predict the disease. Standard F is a next-generation fluorescent immunoassay system capable of quantitative and qualitative analysis. It is a multi-parametric and random accessible system providing accurate diagnostic results. Two different models can be used depending on your workflow requirements. F200 is the user-friendly designed FIA analyzer. Its compact design and convenience of use will make your lab work easier and smoother. F2400 is focused on providing shortened turnaround time with its high throughput feature and highly reliable test results. Standard F is a simple 4-step process that requires minimal training. Just insert the test device, collect specimens, dispense the specimen into the test device, and press the Test Start button. The F200 provides 2 modes. For 1x1 test, you can use Standard Test Mode. For batch tests, you can proceed with the Read-Only mode. You can perform random access test at once, as the 2D barcode on the test device includes information for each parameter. Standard F provides objective test results with COI value. Patient ID written on the test device is scanned on the result paper. This provides user-friendly function, especially when you use read-only mode. 53 parameters are available with Standard F analyzers. The analyzer transmits test results to the operator's smartphone, cloud server, PC, and LIS/HIS for convenient data management. It is a simple process, automated reporting, and a parameter expandable system. Standard F will be the good diagnostic partner of your laboratory. Is it the flu? Am I diabetic? Do I have COVID-19? Standard F can answer these questions. Fluorescent immunoassay method. High sensitivity. Accurate results. Standard F gives you more to predict the disease. Standard F is a next-generation fluorescent immunoassay system capable of quantitative and qualitative analysis. It is a multi-parametric and random accessible system providing accurate diagnostic results. 200 is the user-friendly designed FIA analyzer. Its compact design and convenience of use will make your lab work easier and smoother. F2400 is focused on providing shortened turnaround time with its high throughput feature and highly reliable test results. Standard F is a simple 4-step process that requires minimal training. Just insert the test device, collect specimens, dispense the specimen into the test device and press the Test Start button. The F200 provides two modes. For 1x1 test, you can use Standard Test Mode. For batch tests, you can proceed with the Read-Only mode. You can perform random access test at once, as the 2D barcode on the test device includes information for each parameter. Standard F provides objective test results with COI value. Patient ID written on the test device is scanned on the result paper. This provides user-friendly function, especially when you use read-only mode. 53 parameters are available with Standard F analyzers. The analyzer transmits test results to the operator's smartphone, cloud server, PC, and LIS/HIS for convenient data management. It is a simple process, automated reporting, and a parameter expandable system. Standard F will be the good diagnostic partner of your laboratory. Is it the flu? Am I diabetic? Do I have COVID-19? Standard F can answer these questions. Fluorescent immunoassay method. High sensitivity. Accurate results. Standard F gives you more to predict the disease. Standard F is a next-generation fluorescent immunoassay system capable of quantitative and qualitative analysis. It is a multi-parametric and random accessible system providing accurate diagnostic results. Two different models can be used depending on your workflow requirements. F200 is the user-friendly designed FIA analyzer. Its compact design and convenience of use will make your lab work easier and smoother. F2400 is focused on providing shortened turnaround time with its high throughput feature and highly reliable test results. Standard F is a simple 4-step process that requires minimal training. Just insert the test device, collect specimens, dispense the specimen into the test device, and press the Test Start button. The F200 provides two modes. For 1x1 test, you can use Standard Test Mode. For batch tests, you can proceed with the Read-Only mode. You can perform random access test at once, as the 2D barcode on the test device includes information for each parameter. Standard F provides objective test results with COI value. Patient ID written on the test device is scanned on the result paper. This provides user-friendly function, especially when you use read-only mode. 53 parameters are available with Standard F analyzers. The analyzer transmits test results to the operator's smartphone, cloud server, PC, and LIS/HIS for convenient data management. It is a simple process, automated reporting, and a parameter expandable system. Standard F will be the good diagnostic partner of your laboratory. Is it the flu? Am I diabetic? Do I have COVID-19? Standard F can answer these questions. Fluorescent immunoassay method. High sensitivity. Accurate results. Standard F gives you more to predict the disease. Standard F is a next-generation fluorescent immunoassay system capable of quantitative and qualitative analysis. It is a multi-parametric and random accessible system providing accurate diagnostic results. Two different models can be used depending on your workflow requirements. F200 is the user-friendly designed FIA analyzer. Its compact design and convenience of use will make your lab work easier and smoother. F2400 is Standard F is a simple 4-step process that requires minimal training. Just insert the test device, collect specimens, dispense the specimen into the test device, and press the Test Start button. The F200 provides 2 modes. For 1x1 test, you can use Standard Test Mode. For batch tests, you can proceed with the Read-Only mode. You can perform random access test at once, as the 2D barcode on the test device includes information for each parameter. Standard F provides objective test results with COI value. Patient ID written on the test device is scanned on the result paper. This provides user-friendly function, especially when you use read-only mode. 53 parameters are available with Standard F analyzers. The analyzer transmits test results to the operator's smartphone, cloud server, PC, and LIS/HIS for convenient data management. It is a simple process, automated reporting, and a parameter expandable system. Standard F will be the good diagnostic partner of your laboratory. Is it the flu? Am I diabetic? Do I have COVID-19? Standard F can answer these questions. Fluorescent immunoassay method. High sensitivity. Accurate results. Standard F gives you more to predict the disease. Standard F is a next-generation fluorescent immunoassay system capable of quantitative and qualitative analysis. It is a multi-parametric and random accessible system providing accurate diagnostic results. Two different models can be used depending on your workflow requirements. F200 is the user-friendly designed FIA analyzer. Its compact design and convenience of use will make your lab work easier and smoother. F2400 is focused on providing shortened turnaround time with its high throughput feature and highly reliable test results. Standard F is a simple 4-step process that requires minimal training. Just insert the test device, collect specimens, dispense the specimen into the test device, and press the Test Start button. The F200 provides 2 modes. For 1x1 test, you can use Standard Test Mode. For batch tests, you can proceed with the Read-Only mode. You can perform random access test at once, as the 2D barcode on the test device includes information for each parameter. Standard F provides objective test results with COI value. Patient ID written on the test device is scanned on the result paper. This provides user-friendly function, especially when you use read-only mode. 53 convenient data management. It is a simple process, automated reporting, and a parameter expandable system. Standard F will be the good diagnostic partner of your laboratory. Do I have COVID-19? Standard F can answer these questions. Fluorescent immunoassay method. High sensitivity. Accurate results. Standard F gives you more to predict the disease. Standard F is a next-generation fluorescent immunoassay system capable of quantitative and qualitative analysis. It is a multi-parametric and random accessible system providing accurate diagnostic results. Two different models can be used depending on your workflow requirements. F200 is the user-friendly designed FIA analyzer. Its compact design and convenience of use will make your lab work easier and smoother. F2400 is focused on providing shortened turnaround time with its high throughput feature and highly reliable test results. Standard F is a simple 4-step process that requires minimal training. Just insert the test device, collect specimens, dispense the specimen into the test device, and press the Test Start button. The F200 provides 2 modes. For 1x1 test, you can use Standard Test Mode. For batch tests, you can proceed with the Read-Only mode. You can perform random access test at once, as the 2D barcode on the test device includes information for each parameter. Standard F provides objective test results with COI value. Patient ID written on the test device is scanned on the result paper. This provides user-friendly function, especially when you use read-only mode. 53 parameters are available with Standard F analyzers. The analyzer transmits test results to the operator's smartphone, cloud server, PC, and LIS/HIS for convenient data management. It is a simple process, automated reporting, and a parameter expandable system. Standard F will be the good diagnostic partner of your laboratory. Is it the flu? Am I diabetic? Do I have COVID-19? Standard F can answer these questions. Fluorescent immunoassay method. High sensitivity. Accurate results. Standard F gives you more to predict the disease. Standard F is a next-generation fluorescent immunoassay system capable of quantitative and qualitative analysis. It is a multi-parametric and random accessible system providing accurate diagnostic results. Two different models can be used depending on your workflow requirements. F200 is the user-friendly designed FIA analyzer. Its compact design and convenience of use will make your lab work easier and smoother. F2400 is focused on providing shortened turnaround time with its high throughput feature and highly reliable test results. Standard F is a simple 4-step process that requires minimal training. Just insert the test device, collect specimens, dispense the specimen into the test device, and press the Test Start button. The F200 provides 2 modes. For 1x1 test, you can use Standard Test mode. For batch tests, you can proceed with the Read-Only mode. You can perform random access test at once, as the 2D barcode on the test device includes information for each parameter. Standard F provides objective test results with COI value. Patient ID written on the test device is scanned on the result paper. This provides user-friendly function, especially when you use read-only mode. 53 parameters are available with Standard F analyzers. The analyzer transmits test results to the operator's smartphone, cloud server, PC, and LIS/HIS for convenient data management. It is a simple process, automated reporting, and a parameter expandable system. Standard F will be the good diagnostic partner of your laboratory. Is it the flu? Am I diabetic? Do I have COVID-19? Standard F can answer these questions. Fluorescent immunoassay method. High sensitivity. Accurate results. Standard F gives you more to predict the disease. Standard F is a next-generation fluorescent immunoassay system capable of quantitative and qualitative analysis. It is a multi-parametric and random accessible system providing accurate diagnostic results. Two different models can be used depending on your workflow requirements. F200 is the user-friendly designed FIA analyzer. Its compact design and convenience of use will make your lab work easier and smoother. F2400 is focused on providing shortened turnaround time with its high throughput feature and highly reliable test results. Standard F is a simple 4-step process that requires minimal training. Just insert the test device, collect specimens, dispense the specimen into the test device management. It is a simple process, automated reporting, and a parameter expandable system. Standard F will be the good diagnostic partner of your laboratory. Is it the flu? Am I diabetic? Do I have COVID-19? Standard F can answer these questions. Fluorescent immunoassay method. High sensitivity. Accurate results. Standard F gives you more to predict the disease. Standard F is a next-generation fluorescent immunoassay system capable of quantitative and qualitative analysis. It is a multi-parametric and random accessible system providing accurate diagnostic results. Two different models can be used, depending on your workflow requirements. F200 is the user-friendly designed FIA analyzer. Its compact design and convenience of use will make your lab work easier and smoother. F2400 is focused on providing shortened turnaround time with its high throughput feature and highly reliable test results. Standard F is a simple 4-step process that requires minimal training. Just insert the test device, collect specimens, dispense the specimen into the test device, and press the Test Start button. The F200 provides 2 modes. For 1x1 test, you can use Standard Test Mode. For batch tests, you can proceed with the Read-Only mode. You can perform random access test at once, as the 2D barcode on the test device includes information for each parameter. Standard F provides objective test results with COI value. Patient ID written on the test device is scanned on the result paper. This provides user-friendly function, especially when you use read-only mode. 53 parameters are available with Standard F analyzers. The analyzer transmits test results to the operator's smartphone, cloud server, PC, and LIS/HIS for convenient data management. It is a simple process, automated reporting, and a parameter expandable system. Standard F will be the good diagnostic partner of your laboratory. Is it the flu? Am I diabetic? Do I have COVID-19? Standard F can answer these questions. Fluorescent immunoassay method. High sensitivity. Accurate results. Standard F gives you more to predict the disease. Standard F is a next-generation fluorescent immunoassay system capable of quantitative and qualitative analysis. It is a multi-parametric and random accessible system providing accurate diagnostic results. Two different models can be used depending on your workflow requirements. F200 is the user-friendly designed FIA analyzer. Its compact design and convenience of use will make your lab work easier and smoother. F2400 is focused on providing shortened turnaround time with its high throughput feature and highly reliable test results. Standard F is a simple 4-step process that requires minimal training. Just insert the test device, collect specimens, dispense the specimen into the test device, and press the Test Start button. The F200 provides 2 modes. For 1x1 test, you can use Standard Test Mode. For batch tests, you can proceed with the Read-Only mode. You can perform random access test at once, as the 2D barcode on the test device includes information for each parameter. Standard F provides objective test results with COI value. Patient ID written on the test device is scanned on the result paper. This provides user-friendly function, especially when you use read-only mode. 53 parameters are available with Standard F analyzers. The analyzer transmits test results to the operator's smartphone, cloud server, PC, and LIS/HIS for convenient data management. It is a simple process, automated reporting, and a parameter expandable system. Standard F will be the good diagnostic partner of your laboratory. Is it the flu? Am I diabetic? Do I have COVID-19? Standard F can answer these questions. Fluorescent immunoassay method. High sensitivity. Accurate results. Standard F gives you more to predict the disease. Standard F is a next-generation fluorescent immunoassay system capable of quantitative and qualitative analysis. It is a multi-parametric and random accessible system providing accurate diagnostic results. Two different models can be used depending on your workflow requirements. F200 is the user-friendly designed FIA analyzer. Its compact design and convenience of use will make your lab work easier and smoother. F2400 is focused on providing shortened turnaround time with its high throughput feature and highly reliable test results. Standard F is a simple 4-step process that requires minimal training. Just insert the test device, collect specimens, dispense the specimen into the test device, and press the Test Start button. The F200 provides 2 modes. For 1x1 test, you can use Standard Test Mode. For batch tests, you can proceed with the Read-Only mode. You can perform random access test at once, as the 2D barcode on the test device includes information for each parameter. Standard F provides objective test results with COI value. Patient ID written on the test device is scanned on the result paper. This provides user-friendly function, especially when you use read-only mode. 53 parameters are available with Standard F analyzers. The analyzer transmits test results to the operator's smartphone, cloud server, PC, and LIS/HIS for convenient data management. It is a simple process, automated reporting, and a parameter expandable system. Standard F will be the good diagnostic partner of your laboratory. Is it the flu? Am I diabetic? Do I have COVID-19? Standard F can answer these questions. Fluorescent immunoassay method. High sensitivity. Accurate results. Standard F gives you more to predict the disease. Standard F is a next-generation fluorescent immunoassay system capable of quantitative and qualitative analysis. It is a multi-parametric and random accessible system providing accurate diagnostic results. Two different models can be used depending on your workflow requirements. F200 is the user-friendly designed FIA analyzer. Its compact design and convenience of use will make your lab work easier and smoother. F2400 is focused on providing shortened turnaround time with its high throughput feature and highly reliable test results. Standard F is a simple 4-step process that requires minimal training. Just insert the test device, collect specimens, dispense the specimen into the test device, and press the Test Start button. The F200 provides 2 modes. For 1x1 test, you can use Standard Test Mode. For batch tests, you can proceed with the Read-Only mode. You can perform random access test at once, as the 2D barcode on the test device includes information for each parameter. Standard F provides objective test results with COI value. Patient ID written on the test device is scanned on the result paper. This provides user-friendly function, especially when you use read-only mode. 53 parameters are available with Standard F analyzers. The analyzer transmits test results to the operator's smartphone, cloud server, PC, and LIS/HIS for convenient data management. It is a simple process, automated reporting, and a parameter expandable system. Standard F will be the good diagnostic partner of your laboratory. Is it the flu? Am I diabetic? Do I have COVID-19? Standard F can answer these questions. Fluorescent immunoassay method. High sensitivity. Accurate results. Standard F gives you more to predict the disease. Standard F is a next-generation fluorescent immunoassay system capable of quantitative and qualitative analysis. It is a multi-parametric and random accessible system providing accurate diagnostic results. Two different models can be used depending on your workflow requirements. F200 is the user-friendly designed FIA analyzer. Its compact design and convenience of use will make your lab work easier and smoother. F2400 is focused on providing shortened turnaround time with its high throughput feature and highly reliable test results. Standard F is a simple 4-step process that requires minimal training. Just insert the test device, collect specimens, dispense the specimen into the test device, and press the Test Start button. The F200 provides 2 modes. For 1x1 test, you can use Standard Test Mode. For batch tests, you can proceed with the Read-Only mode. You can perform random access test at once, as the 2D barcode on the test device includes information for each parameter. Standard F provides objective test results with COI value. Patient ID written on the test device is scanned on the result paper. This provides user-friendly function, especially when you use read-only mode. 53 parameters are available with Standard F analyzers. The analyzer transmits test results to the operator's smartphone, cloud server, PC, and LIS/HIS for convenient data management. It is a simple process, automated reporting, and a parameter expandable system. Standard F will be the good diagnostic partner of your laboratory. Is it the flu? Am I diabetic? Do I have COVID-19? Standard F can answer these questions. Fluorescent immunoassay method. High sensitivity. Accurate results. Standard F gives you more to predict the disease. Standard F is a next-generation fluorescent immunoassay system capable of quantitative and qualitative analysis. It is a multi-parametric and random accessible system providing accurate diagnostic results. Two different models can be used depending on your workflow requirements. F200 is the user-friendly designed FIA analyzer. Its compact design and convenience of use will make your lab work easier and smoother. F2400 is focused on providing shortened turnaround time with its high throughput feature and highly reliable test results. Standard F is a simple four-step process that requires minimal training. Just insert the test device, collect specimens, dispense the specimen into the test device, and press the Test Start button. The F200 provides two modes. For 1x1 test, you can use Standard Test Mode. For batch tests, you can proceed with the Read-Only mode. Includes information for each parameter. Standard F provides objective test results with COI value. Patient ID written on the test device is scanned on the result paper. This provides user-friendly function, especially when you use Read-Only mode. 53 parameters are available with Standard F analyzers. The analyzer transmits test results to the operator's smartphone, cloud server, PC, and LIS/HIS for convenient data management. It is a simple process, automated reporting, and a parameter expandable system. Standard F will be the good diagnostic partner of your laboratory. Is it the flu? Am I diabetic? Do I have COVID-19? Standard F can answer these questions. Fluorescent immunoassay method. High sensitivity. Accurate results. Standard F gives you more to predict the disease. Standard F is a next-generation fluorescent immunoassay system capable of quantimetric and random accessible system providing accurate diagnostic results. Two different models can be used depending on your workflow requirements. F200 is the user-friendly designed FIA analyzer. Its compact design and convenience of use will make your lab work easier and smoother. F2400 is focused on providing shortened turnaround time with its high throughput feature and highly reliable test results. Standard F is a simple four-step process that requires minimal training. Just insert the test device, collect specimens, dispense the specimen into the test device, and press the Test Start button. The F200 provides two modes. For 1x1 test, you can use Standard Test Mode. For batch tests, you can proceed with the Read-Only mode. You can perform random access tests at once, as the 2D barcode on the test device includes information for each parameter. Standard F provides objective test results with COI value. Patient ID written on the test device is scanned on the result paper. This provides user-friendly function, especially when you use read-only mode. 53 parameters are available with Standard F analyzers. The analyzer transmits test results to the operator's smartphone, cloud server, PC, and LIS/HIS for convenient data management. It is a simple process, automated reporting, and a parameter expandable system. Standard F will be the good diagnostic partner of your laboratory. Is it the flu? Am I diabetic? Do I have COVID-19? Standard F can answer these questions. Fluorescent immunoassay method. High sensitivity. Accurate results. Standard F gives you more to predict the disease. Standard F is a next-generation fluorescent immunoassay system capable of quantitative and qualitative analysis. It is a multi-parametric and random accessible system providing accurate diagnostic results. Two different models can be used depending on your workflow requirements. F200 is the user-friendly designed FIA analyzer. Its compact design and convenience of use will make your lab work easier and smoother. F2400 is focused on providing shortened turnaround time with its high throughput feature and highly reliable test results. Standard F is a simple four-step process that requires minimal training. Just insert the test device, collect specimens, dispense the specimen into the test device, and press the Test Start button. The F200 provides two modes. For 1x1 test, you can use Standard Test Mode. For batch tests, you can proceed with the read-only mode. You can perform random access tests at once, as the 2D barcode on the test device includes information for each parameter. Standard F provides objective test results with COI value. Patient ID written on the test device is scanned on the result paper. This provides user-friendly function, especially when you use read-only mode. 53 parameters are available with Standard F analyzers. The analyzer transmits test results to the operator's smartphone, cloud server, PC, and LIS/HIS for convenient data management. It is a simple process, automated reporting, and a parameter expandable system. Standard F will be the good diagnostic partner of your laboratory. Is it the flu? Am I diabetic? Do I have COVID-19? Standard F can answer these questions. Fluorescent immunoassay method. High sensitivity. Accurate results. Standard F gives you more to predict the disease. Standard F is a next-generation fluorescent immunoassay system capable of quantitative and qualitative analysis. It is a multi-parametric and random accessible system providing accurate diagnostic results. Two different models can be used, depending on your workflow requirements. F200 is the user-friendly designed FIA analyzer. Its compact design and convenience of use will make your lab work easier and smoother. F2400 is focused on providing shortened turnaround time with its high throughput feature and highly reliable test results. Simple 4-step process that requires minimal training. Just insert the test device, collect specimens, dispense the specimen into the test.
Thank you.
Welcome back, ladies and gentlemen. Please, the people who are standing, gain back your seats. I can still see people who are still standing. We're not going to start until you gain back your seats. Thank you.
Please regain your seats.
How's your lunch? The lunch was good. That's amazing. People from outside Rwanda, how was the lunch? Did you enjoy our food? Thank you. All right. Let's not take much of the time right now and then go back to our program.
Yes, we are going to resume our program. And next on the agenda, we have the presentation from Professor Gerard Yonga, the chair of the Africa NCD Network. He's going to present about capacity building for civil society organizations in shaping national and regional strategies for NCDs. Please welcome Professor Yonga.
It working? Volume is quite low. Oh, am I audible? Barely. I think that's better. The day has really gone, so I'm not going to bore you by using PowerPoint slides. And I would like us to be as interactive as possible. So capacity building for NCD or civil society, for that matter, or NCD alliances, is a very crucial thing for us in Africa. Around about 2011, when we were preparing for the first United Nations General Assembly on NCDs ever, in Africa, there was not a single NCD alliance. Some of you in the room here would remember a few colleagues, for us in Nairobi, a few colleagues used to meet at a cafeteria at 6 in the morning, trying to plot how to galvanize the country, our country at that time, to meaningfully participate in the first United Nations General Assembly on NCDs. Later on, of course, we formed an NCD alliance. It was not very easy to know advocacy at that time, but since then, that was 2011, we've really grown and have come to know how to structure an alliance and know how to operationalize an alliance, especially for NCDs. So when we say capacity building, what do we mean? Basically, we mean the ability to form an organization which is recognized by the governments and the global bodies to meaningfully engage them in a process of changing the way that they make policies to make it friendly to NCD control programs. So one of the key things in capacity building is governance. And governance is one of the things that can be quite challenging for most of our organizations. I remember even NCD Alliance Global started as a steering committee members. I was a steering committee member in the earlier days. And eventually we got structured and formed a body called the Board of Directors, got registered and actually became a formal institution. Likewise, many organizations which are represented here must have started from there. So governance is very important, and formal recognition is also very important. Most of us are structured in the form of, because we are civil societies and public organizations, in form of a General Assembly, which General Assembly becomes the major or the main decision-making organ, a Board of Directors, and then you have a Secretariat that operationalizes the activities. Apart from that, the other important thing is for these organizations to understand the context in which they operate. And the context can be global, regional, or national. The most important thing in NCD is recognition that the upstream drivers of NCDs lie outside the health sector. If somebody cannot access healthy foods, there may be trade, agricultural practices which actually affect that, and anthropological aspects of attitudes towards certain foods which also affects that. So this calls for a multi-sectoral approach in NCD control. So ability to engage the different sectors and to coordinate the activities of the different sectors of our environment or our political and administrative environment is very important. The key sectors are not health sectors as such, although the health sector must participate and sometimes lead. But the education sector, the agricultural sector, the trade sector, the security sector, the physical planning sector are all part and parcel of a multi-sectoral approach. And we also must understand the mechanisms of multi-sectoral action. When, for example, legislation of tobacco control comes to your country, there's a process we all go through, and sometimes it's very fluid. So lessons learned, there's a study which we did in Africa looking at tobacco control, alcohol control, countries which actually have legislations on that. How did they reach there? Some took 10 years, others took 5 years, others took 3 years. So we call it the mechanism of multi-sectoral actions. Some of them come by flux and others can come by design. So we must understand the complexity and the web of the play area of the different sectors and be able to coordinate them to achieve some of our goals. So the organizations or the civil society organizations must develop this web and skill to put together these different sectors. Understanding of the global network is also very important. The global trade is of particular importance, knowing how the global trade, the World Trade Organization and the treaties that it makes, especially the Global Agreement on Trade, and also the Global Agreement Treaty on Taxes. So it's also very important so that you may understand access to essential medicines and also ability of multinationals to position harmful products to your country, and the negotiations that your country leaders make at the World Trade Organization and how it affects your advocacy agenda locally, including even the United Nations Security Council resolutions can actually affect NCDs. Mainstream health, and especially mainstream NCDs, where NCDs occupies the SDG 3.4. But if you look at the other sustainable development goals, there is an element of health, element of NCD in all of them, be it poverty, be it nutrition, be it education, be it agriculture, be it security. They all in one way or another affect NCDs. So mechanisms of mainstreaming health in all SDGs becomes important. As our former president of World Heart Federation, Srinath Reddy, once said, us in a government should be health ministers, because all aspects of their decision-making affects health. So our advocacy should go beyond just health. In the composition of the board of directors of our NCD alliances, it's very important for us to reflect that multi-sectoral approach. Having a few lawyers, having a few engineers, having a few businessmen, accountants, is important to be all-inclusive, to reflect that you indeed intend to have a multi-sectoral approach. In our recent formation of board of directors at the East African NCD Alliance, President Joseph Muchumbichi will remember that was a very big consideration in formation of our board of directors for East Africa NCD Alliance. If you look at the Global NCD Alliance, you'll also see a constellation of experts from different sectors of our day-to-day lives. And I would encourage other alliances to do the same, so that the multi-sectoral approach and mainstreaming of NCDs in all sectors becomes a reality. Lastly, positioning health as an investment case. Many governments will not listen to you when you just keep talking about the number of deaths. It's not that they're cold and they don't care, but that's not the language they understand, or the number of disability-adjusted life years, or the number of beds occupied. But indeed, if you tell them that the GDP will go down by 4%, according to our global economic survey, will go down by 4% every year if we do nothing for all the low and middle income countries, then they'll understand that a sick person with NCD is not just sick. The caregivers also leave the work that they're doing. So there is a loss of productivity. And then there's colossal amounts of money spent to be able to restore health. So there's poverty at family level, and there's actually poverty at national level because of the loss of productivity. And therefore, failure to do something about NCDs, the cost of doing nothing for NCDs, costs the family, costs the community, costs the government. And the cost of doing nothing, if positioned to a government, then they will understand that treating and controlling NCDs is an investment, is not a cost. So positioning NCDs in that manner is very important. And then that brings us to the people living with NCDs as the focus. Because eventually, if we look at NCDs, the burden of NCDs, there is a human face at the bottom of it. It's not until people living with many governments began, and even globally, the global community began to take action against HIV, availability of drugs, fighting stigma, creating institutions for treatment began. So the force of union of people living with NCDs is very, very important. So it's not just about involving people living with NCDs, meaningful involvement of people living with NCDs, meaning that they are part and methods to influence allocation of resources, participation on supply chain by creating a registry such that the amount of drugs and the frequency of drugs and the flow of drugs can be informed by the information that people living with NCDs provide to the leaders at regional level. So in a nutshell, the capacity building of our organizations is multifaceted. It begins from a global level. It begins from our structural strategies that we employ to advocate. Thank you. Do I take questions or do I sit down and
Christina.
So, Prof, we do have a presentation, a panel. I think people might reserve their questions, so we can take them at once. Thank you so much. Another round of applause for Prof. Next, we have a presentation from Christina Persons Perez. Did I pronounce it well? From the Capacity Development Manager at NCD Alliance. She's going to present about the meaningful involvement of people living with NCDs as their role in shaping national and regional strategies for NCDs. Please welcome Christina.
Thank you. Hi, everyone. Thank you so much to the organizers of this regional NCDs conference for inviting the NCD Alliance to be speaking to you today about meaningful involvement of people living with NCDs in the NCD response, and specifically looking at their role in shaping national and regional strategies for NCDs. And if we could go to the next slide, please. I want to show a photograph here taken with advocates of lived experience from across the world that got together in 2018 to put together a global advocacy agenda of people living with NCDs. Now, this was 2018. This was at the time that the NCD Alliance started an initiative called the Our Views, Our Voices initiative. And this really is about putting people first in the NCD response and promoting that meaningful involvement of people living with NCDs, supporting and enabling individuals with lived experience to share their lived experience, to take action, and ultimately to drive change. And the reason this initiative was born 5 years ago now was that as an organization, and as an organization that was actively advocating, we were noticing that if you look at the NCD agenda and all the advances that we were seeing by that time, which was high-level meetings, political declarations, a WHO global action plan, targets for all of this was happening on NCDs, and big decisions were being made and commitments were being made and plans drawn and targets. And yet, in none of these discussions were the people directly affected by NCDs. You would go to these meetings at the United Nations, the World Health Organization, and you would have a lot of, you'd have governments, decision makers, and we were just not hearing the voices of people directly affected by NCDs. And we know that that is a problem. And I have a quote here, which I think starts to tell us why this is a problem. Previous slide, please. And it says, we want a person living with NCDs to represent us because they are the only ones who know what we go through. This was from an advocate living with diabetes from Nairobi, Kenya, who shared this with us. And so we went on to create the global advocacy agenda of people living with NCDs that crystallizes the recommendations and asks of people living with NCDs. And since then, it's been absolutely remarkable to see the number of national advocacy agendas of people living with NCDs. And in the previous slide, you can see a snapshot there, and I'm talking specifically about the Africa region. We have national advocacy agendas of people living with NCDs from Kenya, Ghana, Rwanda, Malawi, Tanzania. The Africa NCDs Network is working on a regional advocacy agenda of people living with NCDs right now. And this is all about hearing directly from people with lived experience about their needs and their asks. So what is needed to change the system? Because ultimately, this is about it's about having the voices of those whose the policies, programs are meant to be reaching. And if you don't have these voices at the table, then it's unlikely that policies and programs and services are going to be as effective as needed. And so with the birth of the Our Views, Our Voices initiative, we were having many discussions around what we're talking about, having a seat at the table, and we started talking about meaningful involvement. And we've had many discussions over the last few years about what exactly do we mean by meaningful involvement. And I remember one of the first discussions that we had, again, this was like 5 years ago now, we put out this publication at the time. And I think to help us arrive at what meaningful involvement was, we started talking about, so what isn't meaningful involvement? And you may, some of these, particularly for those of you in the room that are civil society representatives, these may sound familiar to you, but meaningful involvement is not designing or implementing NCD projects without engaging people living with NCDs directly, consulting people living with NCDs after a decision has already been made, collecting inputs from people living with NCDs without making changes to reflect the findings. And I have this this quote here, this always has stayed in my mind. And this was from an advocate with lived experience, Cornelia Sante, from the Africa region, very prominent human rights advocate. And she says, on what isn't meaningful involvement, my government issued an invitation on a Tuesday to a stakeholder involvement meeting on the Wednesday for a report coming out on Friday, already written. You tick the box. And so we start to see here what isn't meaningful. So if we think about what does engagement that is substantive and meaningful look like, what is that? Well, it's about listening to people living with NCDs to understand their views and priorities, inviting people living with NCDs to have a seat at the table to play an active role in projects, having people living with NCDs to take responsibility over different projects. So you start to see what we're meaning by meaningful involvement. Now, since then, I would also have to say that in the NCD space, things are beginning to change. And one of the reasons why things are beginning to change in the last few years was COVID. And I think with COVID and having people living with NCDs so uniquely vulnerable to negative outcomes from COVID, we did start to hear more and more about the need for engagement of communities, and in the NCD space about engaging people with lived experience. And so we've, with the contributions and voices of 500 advocates from across the world in different regions. Many alliances here in the room contributed towards building the global charter on meaningful involvement of people living with NCDs. So now, if we go on to the next slide, so this has now been over the course of 5 years. What do we mean by meaningful involvement? Now, the global charter sets a set of key principles and strategies for meaningfully involving people living with NCDs. And we heard from 500 people from across the world on what exactly is meaningful involvement. And this now is what we understand as it. The meaningful involvement is possible when organizations or institutions recognize the value of the lived experience and of the community. And this is a really important point. The WHO is discussing this as we speak, where they're talking about the lived experience being recognized as at the same level as technical expertise. Meaningful involvement takes place from the first stages of design and planning all the way through to implementation, monitoring, evaluation, and scale up. So from the very beginning, and for those civil society organization representatives in the room, we know what it's like to be invited at the very end of a process. Meaningful involvement means involving from the very first step. It's about co-designing together them, including governance, policies, programs, and services. We heard yesterday from advocates from the disability movement, the whole mantra of nothing about us without us, and that's exactly what we're saying here as a community, that for the NCD response to be effective, policies, programs, services have to be designed with those they are meant to be reaching. And I think that there's when we were in Kenya for the advocacy agenda of people living with NCDs in Kenya, I heard this quote of nothing about us without us, I heard it taken a step forward and further, and I never heard that before. It was nothing about us without us, and something about us without us is against us. And I think that that's incredibly powerful, because it's basically telling decision makers, if you're going to design these policies and programs without the input of communities and of the beneficiaries and of the users and those they are meant to be reaching, you're doing this at your peril. It's likely that they're going to fail. And I think that that's a really important message for all of us as advocates. And meaningful involvement requires enabling environments to leverage the value of that lived experience, to put people living with NCDs and communities at the center to access their knowledge, skills, and expertise. And it avoids tokenism by building a reciprocal relationship. So this means that organizations and institutions doing the involvement are strengthening their policies and programs. They're getting something out of this. But people with lived experience are also benefiting from that interaction. And I encourage you to check out the Global Charter, the principles. But this, I think, when we look at the strategies that were fleshed out in the Charter, I think you can see how over actually quite a short period of time for the NCD movement, we are becoming more and more sophisticated and more specific and concrete by what we mean by meaningful involvement of people living with NCDs. It's not a nice to have, it's something that is essential, and it requires enabling environments. It involves having a culture that is recognizing the value of that lived experience, and it is creating and formalizing opportunities for meaningful involvement. And so this is where we're talking about that there are seats at the table for in governance, decision-making roles. And so this really starts to speaking to social participation, democracy, citizenship, how are governments making decisions on policies, and what role communities and civil society and people living with NCDs can have. So I've got two final slides I wanted to share with you, but this point about this is something that we're really seeing gather traction and momentum. And I really think that COVID, unfortunately, has played a part in that, with those kind of vulnerabilities of people living with NCDs and the absolute need to engage communities in the response. So what I'm sharing there with you was, for instance, there's a tweet there from the WHO, and this was in 2018, noting that the political declaration then actually does call out people living with NCDs and the need to amplify the voices of people living with NCDs. Now, that was in 2018, and since then, and this is really, really exciting, the WHO has been really seeing that in order to accelerate the NCD response, we need people living with NCDs to be contributing and really to be part of that response. And so Nothing for Us Without Us was a report, a whole consultation that the WHO did. And on the right-hand side, there is a consultation that just closed now, but the WHO is producing a WHO framework for meaningful involvement of people living with NCDs. And what is extremely powerful about this framework is that it offers technical guidance for the WHO itself, and for governments and member states to be involving people living with NCDs. And I have to say the draft that we saw that was open for consultation is extremely ambitious and powerful. And I think for us as advocates, this is going to be an enormous game changer when we can call on governments to say, this is what the WHO is advising on. And the Global NCD Compact that was just launched has an area of commitment that is meaningfully engaging 1.7 billion people living with NCDs and mental health conditions in policy making and programming. So this is now, we're really seeing that the discourse on this and commitment is really being scaled up over the last few years. And my final point here, which is really about what is happening at the country and regional levels, this is also really picking up traction. And a lot of this is because of the fantastic work of national and regional NCD alliances. But we know that in Kenya, for example, if I could just point out a couple of very interesting examples, but in Kenya, in Kenya, there's a national strategic plan on NCDs that was launched recently, 2021, 2022 to 2025, 2026. NCD Alliance Kenya, members of NCD Alliance Kenya, including representatives with lived experience, were part of the technical working group of the Ministry of Health that was working on that strategy. So here we start to see people living with NCDs having a seat at the table. We see the mention of people living with NCDs in the strategy itself. Another interesting example for us is in Rwanda. This happened in October 2021. This is now going back 1 year, but a new national strategy and costed action plan for the next 5 years, and a photo there of the Rwanda National Advocacy Agenda of people living with NCDs launched at the same time, and the Rwanda NCD Alliance being an implementing partner of this new strategy. So just in closing, I want to encourage you to really meaningful involvement of people living with NCDs is everybody's business. So if you are a stakeholder in the NCD response, and I believe you are because otherwise you wouldn't be attending this conference, I think there's something in here for all of us, whatever role we are playing. There's something that lived experience of people living with NCDs would really benefit, strengthen the work that we are doing. Thank you so much.
Thank you so much, Christina, for the advocacy. Really amazing job. And yes, we're talking about meaningful involvement of people living with NCDs, and this brings us back to the main theme of this conference, where we are shaping an East Africa free of NCDs through people-centered interventions and transformative development. So this leads us to a panel discussion, which we are going to have the civil society. We thank you so much for the presentation on how people living in NCDs and they're shaping national and regional, but also we need to hear from the civil society. So this panel discussion is going to be moderated by Ferdinand M. Sunuyu. Hope that I'm pronouncing it well. The panel discussion is about the role of civil society and people living with NCDs in achieving people-centered interventions for NCDs. Please help me to welcome Ferdinand. Ferdinand, the floor is yours. Is he around? Okay, there you go.
Good evening. I want to first of all thank the organizers for the opportunity to actually be part of this session and to moderate this session, this panel discussion. As you have heard, Ferdinand from Cameroon. And I want to start by asking a question. What is PCR? PCR. Anybody? Yes. Polymerase chain reaction. Great. When I was preparing for this moderation, I learned something new. And so I hope that by the time we finish this session, you're also going to learn something new. And that's the meaning of PCR. The interesting abbreviation means people-centered responses. Isn't it? You got it. You almost got it. Well, this is the last session in terms of panel discussions. And so if you had not been somehow taking notes or you thought this was going to extend a little more, I want to invite you to be ready. Because if you don't get anything from this one, you will surely not get anything again. Well, there are other sessions coming up. But I want to just say that addressing NCD risk factors and challenges in a rapid and effective manner needs understanding of the multi-sectoral nature of the risk factors and the diseases. In this regard, recognizing the roles and responsibilities of government, civil society, private sector, youth representatives, people living with NCDs, helps us to contextualize ways forward for each stakeholder. Civil society, as opposed to government, is made up of entities and individuals, recognized entities. Not being government means that a great portion of society has responsibility. Civil society, therefore, is not just a consumer of services, but constitutes a major source of services to accompany the whole of government and whole of society approach needed to combat the multi-sectoral challenge of NCDs. So today, we will examine the role of civil society and people living with NCDs in achieving a people-centered response to NCDs in a bid to encourage civil society here present to continue to take up its responsibility with respect to advancing an NCD-free East Africa. So far, I think it's been great in terms of our work as civil society, but it needs to be greater. So today we're honored to have a panel of experts that are going to share with us and examine this topic through a couple of questions, and I'm going to invite them to come up at this time, starting with Professor Gerald Younger, who is, as he comes up, the president of the Africa NCDs Network. He's a highly qualified, experienced specialist in cardiology, internal medicine, and an NCD advocate. He's also a researcher and a healthcare management leader of international caliber. He has a proven record of achievements nationally and internationally. He's the past chair of the East Africa NCD Alliance and currently the president of the Africa NCDs Network. The result of more work is more work. How does Professor Kaushik put it? The reward of more work is more work. He's been building. It's my honor to also introduce the second panelist of this session, Professor Joseph Mukumbichi. It took me time to know how to pronounce this. And it's very special for me because I know very few people have had the opportunity to introduce him since you guys came to this conference. So Professor Joseph is also an experienced and chief consultant pediatrician and cardiologist and an associate professor of pediatrics at the University of Rwanda. He is the founder and president of the Rwanda Heart Foundation, a board member of the Africa NCDs Network, and he is also the chair of the Rwanda NCD Alliance and current president of the East Africa NCD Alliance. He is one of the chief architects, of course, of this meeting. So please, let's give it up for him one more time. And as we have just listened, but I'll introduce her again. It's my honor to call on Dr. Christina Parsons Perez, who is the Capacity Development Director of the NCD Alliance Global. As Capacity Development Director, Dr. Perez has been very involved in the building of the capacity, in building the capacity of civil society organizations to translate NCD commitments into public health and societal gains as a senior leader of the NCD Alliance. Please, let's give it up for her. She takes her seat. It's also my privilege to welcome on stage Madame Ida Rose, who is the Vice President of the Senegal NCD Alliance. She is a socio-anthropologist and public health specialist. She is working at PATH as the NCD team lead, and she is also Senegal's NCD Alliance Vice President and a strong advocate. There's one more person who is going to be introduced, and he's going to take part virtually. I don't know if the tech team is ready, but let me introduce to you John Gikonyo. I hope now I can receive a certificate of belonging to Kenya. John Gikonyo. He's a father of two, and he lives with kidney disease since 2009 and with a kidney transplant since 2015. He holds a bachelor's degree in philosophy and sociology. He's passionate about universal health coverage and prevention and control of NCDs, as well as meaningful involvement of people living with NCDs. He's the chair of the Caucus of Patients-led organizations under the NCD Alliance of Kenya, founder and president of Renal Patients Society of Kenya, and he is also a member of the advisory committee of people with lived experience for the Africa NCDs network. So if everybody is ready, both our panelists and the audience, I would like to just indicate that as we get into this session, we're going to have the interaction with the panelists, and then at the end, we will take questions from the audience. And so I would not like any side of the audience to not have the opportunity to ask any last questions that probably you might need answers to. So as we go through, please make sure you note the different things that our experts are going to be sharing with us. And if there are any steps that you have to learn and take note of, please take note of these. And to our panelists, you're once more welcome. And I hope that our interventions will remain as short as possible and that we will be able to go through the great questions we have for you for this educational session. So I will start the questions with Dr. Perez. Thank you once more for your excellent presentation. And as we introduce you, the NCD Alliance has actually been very active in supporting countries to build the capacity of NCD alliances. And this has translated to impact as far as work done on NCDs at the global level and at national levels is concerned. As Capacity Development Director, you have been directly related with building the capacity of civil society organizations to translate these commitments that we all have into public health gains through civil society action. During this conference, we've had different stakeholders, including civil society. And right now, I just want you to make sure that nobody leaves from here without knowing the true, real definition of civil society. So what is civil society and what is their role in NCD prevention and control in general?
Thank you, Ferdy, and that's a great question and one that that we have thought about, given serious thought at the NCD Alliance over the years. So on the definition of civil society, for us as an organization, we always refer to the World Bank definition of civil society, which is non-governmental, not-for-profit organizations that have a presence in public life. Three things to remember: non-profit, non-governmental, have a public interest. Okay, so that's the key point for us. And if we look at that World Bank definition, they then unpack this and they mention civil society organizations, therefore, refer to a wide array of organizations, community groups, non-governmental organizations, labor unions, indigenous groups, charitable organizations, faith-based organizations, professional associations, and foundations. So you can see how broad this and how embracing this umbrella is. So non-governmental, not-for-profit organizations with a public interest. Now, we have observed the different civil society organizations across the world getting involved in NCDs, and we believe that the role that civil society has to play in NCDs, we refer to as the 4 A's: raising awareness, advocating for change, accountability, holding our governments to account, and access, promoting access to services. Thank you.
Thank you very much. Clearly, no one is going to leave from here when they're civil society and they don't know they're civil society. Okay, I would like to move over to Professor Gerald Younger. We already know.
Somebody will be hearing you cooking.
Do we have an elephant in the room? Oh, okay, yeah. All right, welcome. All right. So let's proceed with the next question to our expert. So, Professor Gerald, we already know what to do when it comes to NCDs as far as interventions are concerned. What is left is to do it. What I mean is that we know the WHO best buys, for example, which have been recommended to member states You have said in a quote during the Global Week for Action on NCDs that many NCD interventions are still suboptimal. And what we need is more hands on deck to change the narrative. You clearly understand the role of civil society, and of course, people living with NCDs in joining this effort. So what are we not getting right as far as implementing the WHO best buys in a people-centered way is concerned, and what should we do to advance the implementation of these best buys in East Africa?
Thank you, Fadi. That's a very loaded and broad questions, but I will take it this way. If you look at the global monitoring framework, and I think some presentations were also made yesterday, we are not making progress and reaching the targets that we're supposed to have reached, and the ones that we pledged to do during the meetings that our leaders have had at the United Nations. Question is why? I think the biggest issue to address here is the nature, the multi-sectoral nature of all these problems, and galvanizing all the tools that we require to achieve this. So what's the role of the civil society in this? Already the civil society has been defined for us, but what's our role? Our first role, if nothing else, is to really support the implementation of these plans. Apart from supporting the implementation of this plan is to hold the governments into account. And I'll give you an example of which I think Christina has already pointed out, of civil society being part and parcel of policy initiation and policy implementation, and therefore injecting the people-centered orientation in the policy process, like the strategic plan that was done in Kenya, for example, the NCD strategic plan. You are privy of an example of yourself, Fadi, when the ANN was implementing its strategic plan, and you initiated some regional focal points, and the regional focal points worked with the national alliances to identify people living with NCDs to have an input into our 5-year strategic plan for ANN. So these are some of the things that we need to have done early, which we are beginning to just adopt a people-centered plan when the bus has already left. But it's not too late, I think we can go on. So you ask yourself, what are these best buys that we are talking about? Let's take tobacco, for example. One of the biggest best buys, the tenets of tobacco control is to ban advertising of tobacco. So who is going to be your police? We know that the police system in many of our countries are not adequate to go and look everywhere on the positioning of tobacco. So people living with NCDs can actually be involved in policing ban on advertisement, ban on smoking in public places, and advocating for increased tobacco taxation to the levels that the framework for tobacco control has recommended. And then if we look at also the the warnings that we need to put on tobacco, we know there are countries where, for example, they don't have the tobacco control bills, or even if the tobacco control bills are there, they're not well implemented. And this becomes, in a regional network like ANN, becomes the porous border for entry of the multinational companies to bring in products that are not well legislated for the rest of the continent, but there's a country where the legislation may be weak, and then they find their markets into other countries. And the regional NCD networks helps us to synergize and to make the policies uniform across the region. The East African NCD Alliance is an example. When we started the East African NCD Alliance, as Kaushik showed you the other day, there were only 2 countries which had a tobacco control bill. The other one didn't. And I always have an example of a friend, I don't know whether to call him a friend anymore, who used to run a cigarette company. So he would import through Rwanda. That time Rwanda did not have, his wife is from Rwanda. He's Kenyan. So he would import, using his wife's connection, his cigarettes from Rwanda. And then, of course, the taxation was less. The labeling also, was not according to the laws. And he would also pay less money because of that. And then the products would find their way, because of East African community and free movement of goods, into the Kenyan market. Okay, so since then, when Rwanda, enacted its legislation, his business closed. So that's an example of, how civil society and regional civil societies can close the gaps for illegal or underhand trade by the multinationals. I can say the same about the alcohol control bill and the unhealthy diets, especially for salt restriction and sugary food and beverage restriction. So involvement of people living with NCDs, strength of civil societies, really synergizing together with the government really is the way to go.
Thank you so much, sir. You've mentioned something I'd like to follow up on because there's this clear challenge that civil society have. We have to go about doing our role, our duty, our work, our responsibility. But in the African context, there is this perception sometimes about the fact that civil society are not necessarily friends but foes of government, especially when you look at it from a political perspective. So what accounts for this wrong perception of civil society and how do we navigate that kind of a perception where we were seen by government, for example, that we have to hold to account as foes and not friends?
So again, as civil society, we have to be tactful and we have to have principles of engagement. I remember in one of our meetings, I'll quote a good friend of mine, in one of our meetings at the Global NCD Alliance, after a long discussion on relationships with our environment, including the government, we divided our environment into three. There are the entities that you must engage in your quest for NCD control. And one of the entities that you must engage is government, insurance companies, private healthcare providers, and financing organizations, because without them you cannot control NCDs. I'll come back on the methods of engagement. And then there are those ones who you must not engage. You can only talk to them. My friend used to say you cannot go to bed with the devil. And that's the tobacco industry, the alcohol industry, and the sugary beverage industry. So if you do not have a conflict of interest policy as a CSO, then you are doomed to have a lot of problems. Even your relationship with other organizations which have those principles will be in jeopardy. So we must not engage these ones at all. We can only talk to them, regulate them. Then there are those entities where we may deal with, and that's the tricky one. One of them is the pharmaceutical industry and the food industry. Because the pharmaceutical industry, though partners are in business, and therefore there could be potential conflict of interest. So if we categorize them like that, then you can have real enemies and sworn enemies. So you can say those are foes: the tobacco industry, the alcohol industry, and the sugary beverage industry. Then let's come back to the government. The government is actually the entity which has the sole responsibility of providing health to its citizenry because they pay tax to the government. So our major role is to hold the government responsible. But at the same time, we are not foes. So where we can be able to support our governments with information, with policy briefs, with the galvanization of people of interest or multi-sectoral interest, then we play our role. One of the key things that we need to do is to have what we call intersectoral coordinating committees. And this was one thing that was advocated by WHO as well. Countries which have a meaningful intersectoral coordination committee, which involves many of the sectors that are concerned, with NCD control within government and outside government and civil society organizations sit together in the implementation of government policy and action that concern NCDs. And therefore, it's like a rat that sometimes bites you and at other times licks your wounds. So we must define our relationship and know when to hold the government to account and strongly at that, and when to support your government, so that we are dual in nature and we are not sworn enemies as such. So I think it's a complex relationship that has to be fine-tuned and well-defined and changing with time. There are governments sometimes where you really need to put your foot down. You need to go underground and really make sure that you get other civil societies go up in arms, and there are times to sit together and talk.
Thank you very much. I remember one of the sessions that I ever attended, I learned this from somebody who contributed, I think from the NCD Alliance, that our relationship with the government is like two people on the dance floor, dancing, I don't know if it's salsa or it's which of the kinds of dances, but you dance. I'll leave that to Christina. Maybe she knows about that and she can explain that dance and in addition to what Professor Younger has described. But I guess a lot of wisdom is needed as far as civil society work is concerned. Before I move to Professor Mukumbichi, again, I'm due for a certificate of being a Rwandan by good pronunciation of that name. I just wish to say that to our panelist who is virtual, you can switch on your video, and then to the audience, please, if you can join the Zoom meeting, don't put on your audio so that we won't have interference when he joins to speak to us. So back to you, Professor Bukumbichi. Did I do it wrong this time? Okay. So considering the great work that East Africa NCD Alliance does in supporting NCD alliances and civil society in the East African community, we wish that you should tell us more about the role of civil society and people living with NCDs in achieving a people-centered intervention. Particularly, tell us about your work in building the capacity of people living with NCDs and civil society to ensure effective advocacy towards policy changes for NCDs in Rwanda.
Thank you. I'm not sure I got it well. You're asking about East Africa NCD Alliance, and at the same time you ask about my work in Rwanda.
Yeah, based on your role across Rwanda and East Africa, because there's been a lot of great things that have happened in East Africa, but also in Rwanda. So what has been your experience?
Okay, so let me maybe start with Rwanda and building on what Gerard has been saying about the work of Rwanda NCD Alliance in interacting and working with the government. Because Rwanda NCD Alliance is very young. But before that, long ago, we had 2-3 main associations, civil societies, organizations, which were active and started advocating for NCDs since 2011, when they created the first desk on NCDs in the Ministry of Health. And it was the Rwanda Heart Foundation and Rwanda Diabetes Association, mainly. And we started doing having different initiatives, but first of all, raising awareness. Fundamentally, and I remember we're celebrating the World Heart Day, and in 2008, we invited the First Lady and the members of the parliament to have a walk for the heart. And it was one of the first time we were doing screening blood pressure and BMI and so on. At that time, we were not doing sugar. It was too expensive. So to say that progressively have been doing screening and education and raising awareness in the parliament, in the Senate, doing screening there, in workplace, and already without having an alliance, the Rwanda Diabetes Association and Rwanda Heart Foundation were working together.
So how were you involving people living with NCDs, and how were you building their capacities to be able to effectively achieve your objectives in promoting NCD response in government as civil society?
So let me then come to the alliance. When we formed the alliance, we have now 26 organizations, and among them, many of them have groups of people living with NCDs. That's how they contributed to the Rwanda advocacy agenda, which was published last year. It was handed to the Ministry of Health after the launching of the Rwanda strategic plan for NCDs. So those groups are always involved in, as members of the alliance, in the different initiatives with the support of our partners, including NCD Alliance, to build capacity for advocacy. For example, the person who gave his stories yesterday, Dr. Joseph, has been trained as an advocate thanks to the initiative through the Rwanda NCD Alliance with Global NCD Alliance. So we try to build up the capacity for advocacy, but we also try to have groups empowered in different areas of the country. We are trying to create kind of section of the alliance, but that needs, it is a long run to be effective. So building capacity is also supporting each other. For every event we organize in Rwanda, when we have any NCD day, cancer, heart, cardiovascular disease, diabetes, all the members of the alliance work together. We support each other because most of our members, all of us are small organizations. So together we have a stronger voice. That's how now we are recognized as really a partner by the Ministry of Health, the Rwanda Biomedical Center, the NCD division, and we work together. We don't need to confront each other because they recognize what we can do and they help us when we need support. The same when we go for an initiative like the Carb-Free Day, we are part of the committee which organized the Carb-Free Day. The mayor is going to come or his assistant, have a meeting with us, and we organize every week how are we going to do the Carb-Free Day and the screening. So it is a dialogue, but that relationship needs to be built up progressively. It is a matter also of trust, of collaboration.
Thank you so much. Before I come back to you, let me just take the opportunity to say, this being my first time in Kigali, I was very impressed, not just by what I heard in terms of the Car-Free Day, but also what I saw in terms of all bikers having helmets. Sometimes we forget road traffic accidents as a key issue. And so I just want to highlight that if I were to send you to President Kagame, I would say you should probably give him a high five for us. Yeah, but let's move over to Ida. Ida, it's been said that nothing for us without us, and today I heard that anything for us or something for us without us is against us. I got that. So this statement really highlights the importance of involving the beneficiaries in policies and strategies designed to address their own issues. And so, please, can you tell us about the status of involvement of people living with NCDs in programs and strategies in the Senegal NCD Alliance?
Thank you, Ferdinand. So, Senegal NCD Alliance is a new baby. I think that it's a long process that we have had to create this alliance through PATH, and now register in 2022. So we have a very short history. But most of the alliance members, 15 organizations right now, are a civil society organization implicated in NCDs, risk factors, fighting, and other NCDs response. So basically what we are doing is to implicate it, so they are implicated in the boards. They are board members, and they participated in two ways on NCD response. First, in policy, because in Senegal we have a multisectorial committee hosted by the Ministry of Health. And in this multisectorial committee, we have people living with NCD, member and have seats on this committee. And as part of the discussion, they contribute on policy making, they contribute on policy decision. Recently, we were revising the Senegal strategic plan on NCD. And most of the organization was part of the discussion and have contributed on that important document. The second way is on awareness. Awareness raising is maybe one of the priority that we have in Senegal, as most of the investment in the country is focused on response, on care. So the civil society is mobilized through the NCD Alliance on organizing a weekly radio show where we talk about NCD risk factors. We have many followers on this radio show. And we also raise many screenings within the community. Recently with the Pink October, I think that it's the same in many countries. We have screened for breast cancers and other particular diseases on the country. So to say that this multi-sectorial committee is really one of the organization where civil society are really part of and contribute on the policy in the country.
So that sounds like a lot of work for you. You said baby. You used the word baby. Baby alliance, and I'm sure maybe there are also other baby alliances here, but even if you're not a baby, what are you? Adult, young, adolescent alliances here. I mean, I would like to know from you, what are some of the challenges that you're facing as an alliance in doing all what you're saying that you're doing?
Yeah, sure. We have many challenges, like many other countries and alliance, but I want to focus on two of them that I think are really important. The first challenge is on creating a commitment within all these civil society organizations, scientists, so journalists. We have really many members from diverse organizations. So how to speak on the same voice? This is one of the challenges that took many times to create commitment and agree on what will be the engagement in this alliance. So having a same goal, a same engagement on fighting against all the NCDs risk factor. That was what we agree with. And the second is, yes, let's say our particularity for French country speakers. We are missing so many opportunities as French country speakers because most of the document, even for people living with NCD, when you have awareness documents, they are in English. So are they accessible for the people living with NCD? This is a huge challenge that we have, even for financing, pursuing opportunities. So there are so many opportunities that we want to pursue, but this is something we don't know really how to handle it, but yes, that's something important for us.
Yeah, thank you. Thank you for being such a strong advocate and for actually being here as well. I think what you've expressed, there are so many solutions in this hall, and they were all ears as you were speaking about some of those challenges. So let's go to John Giconyo. Is he able to connect online? John, are you there?
Yes, I'm here. Can you hear me?
Great. Welcome on board. We have one question for you.
Okay.
Very direct. Having introduced you, I wish to find out from you what capacities do you need to drive a people-centered NCD response as needed in East Africa?
Okay. Thank you very much. For there to be people said at the NCD response, of course, the people must be in the center of all deliberations and preparations that are made for that. And for them to be such involved and engaged, first of all, they need to be mobilized and organized. And because if, for example, the people who ought to be in these deliberations are not mobilized and not organized and not easy to reach, then it becomes very difficult for them to add their voice. I've seen some examples given there by Christina Parsons about our NCD Alliance NCD strategic plan. And sorry for not saying, I'm speaking from Nairobi, Kenya. And yes, we do have an NCD strategic plan. And the reason why we were able to participate in that is because we were already organized as patient-led organizations. And so it was easy for us to come together, spell out things that we felt ought to be in that strategic plan. And so then after that, we selected two representatives who now were incorporated in the technical working group that was working now on the strategic plan. And therefore, our interest, our views, and our contributions were captured. So what I'm trying to say is that this was possible because we were already mobilized and already organized. And we have also been able now to get access to the Ministry of Health through the NCD Alliance of Kenya on a raft of various issues because we are somewhere we are easy to reach, and
so John,
it becomes easy for us to cooperate.
Hello, John. Can you hear me well?
Hello?
Can you hear me all right?
Yes, I can hear you. Am I still audible?
Yes, you're very audible. I want to just, extract out from you if you can, tell us directly, like, what are some of the capacities you think you need as someone with lived experience of NCDs to as an advocate, make sure that there is a people-centered response for NCDs in East Africa. Is there a list? Is there a couple, 1, 2, 3 points you have?
Okay, I think that's what I've been trying to get at. And what I'm saying is that, first of all, is a capacity building for organizations that need to engage with government and ministries who make up policies and programs and projects that affect people living with NCDs. So people living with NCDs to be able to with this and have a representative, they need capacity building so that they are able to be realized, they're able to scrutinize government policies when they are made, and therefore be in a position to respond and also be able to hold government to account where government has made commitment and those commitments are either not being met or they're being. So capacity building is one is important aspect. And like I've said, we need to be able to mobilize, we need to be able to hold meetings. And if we are not able to do that, then we shall not be in a good position to respond. I don't know if that answers your question.
Absolutely. I think if the audience is satisfied, then I'm satisfied. Are we satisfied? Are we satisfied? For want of time, we're not able to extract more from you, but we are sure that within the groups where you and many other people with lived experience have found, there will be that mobilization that you're mentioning, and more capacity can come and more things can get done. So thank you so much for joining us from Kenya, one of the places that is almost out of Africa, even though in Africa, due to their good network. You were able to speak to us clearly. So thank you very much for joining. We will not be able to take further questions for our great panelists, but I think we have had this session, which has examined the role of civil society and people living with NCDs in accelerating a people-centered response. We have been able to define what civil society constitutes, sharing experience and learnings around actions that are being taken to ensure a people-centered response. And I hope that the audience has been able to pick up things that they can apply in the different organizations. Okay. Do I have the 1 minute?
Okay. All right. Yeah. Otherwise, I will say I'm not satisfied, and you are not going to be happy either. No, because I had the proposal in mind. Why do we organize here these gathering of alliances, and we have never organized a gathering of people living with NCDs? Because when we saw this experience we had with putting together an agenda, advocacy agenda, we saw that there are so many things they have to say. You just need to sit with them, organize, and you come out with a proposal, with a document which can represent. Here are the asks of people living with NCDs in East Africa. And we should think about doing something like that. That's kind of consultation. Until the day, maybe, we have a representative in this African Legislative Assembly. By the way, in Rwanda, we have people living with disability have a representative in the parliament. We are really thinking on ways we should have not only disabilities, but all NCDs with a representative in the parliament. Why don't you try to work on that as a regional alliance? That was my proposal. So a big meeting for people living with NCDs, with delegates from different countries, and then we come out with something. Thank you.
Thank you very much. Please, let's give it up for the team. And before I hand it over to you, I just want to thank you for your kind attention and to say that there are note takers, and I'm sure all of these points, including the one that Professor has gone into proposing, will be taken into consideration. Thank you very much, and thank you.
Thank you so much. Thank you so much. Can we give them another round of applause? That was really powerful discussions. So the main goal of convening like this is because we want to learn from each other. And if you want to shape an East Africa free of NCDs, it's really important to share knowledge, practices, policies. So the next session is really interesting because we are going to hear from different actors, from what they have achieved, so that maybe each of us can can have a takeaway from home, so that we build an East Africa in harmony. So I'll let Ange introduce the presenters from these sessions, which is dubbed Best Practices in NCDs Prevention and Care.
All right, thank you so much, Claude. Before we get our next presenters, we would like to have some few principles for the next presenters. As you can see, we are behind the time for a very long time. So now if you can see me, I'm holding one tool that we're going to use to time the next presenters. If you can kindly stick with 6 minutes, and then I will just kindly remind you with this thing, I will only ring once to know that your time is over. All right. Great. So we're having the first presenter, who is Florence Wamwezi. Florence Wamwezi is the lawyer by profession, NCD advocate. She hosts the lifestyle show on national television. She's also the executive director for Care for Them Wellness Organization. A very big round of applause to Florence, please.
Thank you. Thank you, organizers, for the opportunity for me to present on the experience with obesity management in Rwandan women. In Rwanda, obesity stands at 21% in women. That is according to the National Institute of Statistics. The report has it that obesity is actually rampant in women in towns, much more than those ones in the villages. Now, a story is told of Mucheshimana Serafina, a Rwandan woman, 40 years old, who 3 years back weighed 200 kilograms. Serafina was a hub of NCDs to include diabetes, high blood pressure, mental disorders, and as if that was not enough, Serafina underwent gender-based violences to the point the husband packed his things and left her alone, as helpless as she was. It was not until Serafina had the good news about Mission Slim and Fit that is featured by Care for Them Wellness Organization that Serafina's story turned around. Let's take a look.
n'ukuri pe ntararwara narikoreraga ngenzi kwikorera kuba narwaye gutya byarambabaje ariko mbonye hano kurambika umusaya umva maze gufatwa umugabo twarabana ko twabyaranye umwana w'imfura apfa afite imyaka 10 mpita mbyara uwo mfite ubu nafite 11 urabona nta bushobozi bwo kuvuga ngo natunga umukozi ntaki n'abantu oya n'abaturanyi ntabwo nabishobora kuko nkijya n'indera nicyo kintu bambuje iby'imbabura urusaku ntabwo nabishobora cyabikora wenda atari imbabura ngo ngireho isereri mfite nk'ako kagaze wenda ibyo byakunda kuko kaba katagukurura mfite impinduka ubushize twaganiriye ndira none tuganiriye seka ni ukubera bo Imana ibamugisha utagabanyije aho bari babyumve ko mbashimiye rero ikindi cyakurikiyeho cyatumye numva akamwenyu nabonye abantu banyitaho kuri siporo
Three, good. 4, good. 5. Then in 2, 3, 4, 5. Yes, yes, come on, yes, yes, last one, last one. Okay, good, 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 good.
nari mfuye banyigishije imirire numva bimfashije ko ntogose imboga cyangwa togose ishu cyangwa iki ariko nkamenya poroteyine rero ifite amagi ushobora gufata igi ni poroteyine uriye wafata indagara wafata isambaza wafata inyama y'inkoko y'urukwavu ibashije kuyibona ntabwo bigoye aho mariye guhura na Simanifit ikanyigisha isahane imirire myiza ikamporesha siporo ikanyitaho buri munsi buri kanya ibigerageza mbese njye mbona yarambereye umubyeyi kuko niyo iritumye nikunda ubwo aho menyaniye nayo rero nshobora kunama nkaba nakoropa nakwitekera nakwikorera uturimo tumbeshaho singiteze ngo barama singiteze ngo kuko namaze kwimenya kwikunda namaze kumenya uwo ndiwe kwiha agaciro ndashimira na leta y'u Rwanda
$85 kilograms. So from her story, she summarizes all that Care for Them does for the girls and women around the city in the fight against obesity, one of the risk factors of NCDs. My time is up, but briefly, this is me 3 years back. I also was obese, and I thank God I graduated. Put it back, bring the picture back. Yes, that is me. I was obese plus, but I thank God now I am overweight. I'm not yet normal, but I'm the journey towards that. So as I wind up, all of us in the house are champions of NCDs. Just with a show of hands, may I have a look at the underweight in the house? If you have your BMI and it's below 18, the underweight in the house, anyone underweight?
No one?
Any normal people in the house? 18.5 and 25, just with the raise of your hands. The normal people in the house? A quarter, not even a quarter. Yet we are the champions. The overweight in the house, I am overweight. Wow, and you are the champions. The obese class 1 in the house. I thank God I'm no longer obese. The obese, she's there, obese class 2 with BMI 35 and 40. These ones cannot be found anywhere else apart from Slim and Fit. You know why? You people stigmatize them. You don't give them a chance to be seen in public. So our very humble way, why we do what we do, is just to be champions in the campaign against NCDs. My time is up.
Thank you, Florence.
Thank you so much. Thank you so much.
These are really, truly champions of NCDs, and thank you for your work. It's really inspiring. Our next presenter is Bo Danielson, the Vice President of Dental Health Without Borders, Oral Health, and NCDs. Bo Danielson.
Yes, good afternoon.
Yes.
My first slide's on?
Yes, please go ahead.
Yes, thank you. We started delivering pain relief for children and adults in countries where the access to this was spare about 20 years ago. However, we realized that pain relief could not stand alone, and that it was mandatory not only to try to eliminate pain, but that we should also try to eliminate the cause of the pain. Could you have my second slides on, please?
Well, I think you can proceed.
To share slides, so okay.
Yeah.
It's not very easy to do pain relief treatment under the field conditions that you have when you go out in the rural areas in East Africa. So a lot of untreated dental decays is present, and a lot of people are suffering from pain. When we go out in rural Rwanda, more than 50% of all children at any point of time have some sort of pain or discomfort from the oral cavity. So we therefore, together with the SOS Children's Village, made a program where we made hygiene programs for school children. So together with our colleagues in Rwanda, we made different materials so that we had the teachers and the parents starting making all hygiene and hand hygiene with the pupils. What we achieved by doing that was that we were actually able to eliminate the frequency of children having toothache from more than 50% until less than 7% of the children in different age groups. We did investigate also children in some similar schools in the same areas as those who were on the program. And we also saw a fall in the amount of children having a toothache. That was the reason for that was that when we did pain relief treatment, we included all children in that community. So also children from our control schools went for treatment during our missions. We also found that the number of children having gum disease, where they had bleeding from the gums, fell dramatically in the schools where we did our programs and interventions. However, this was not the case in the control schools, not at all. They stayed at the same level. Also, the hand hygiene improved dramatically in the schools in which we were intervening. However, this was not the case for the children in the control schools. So we have published papers in the African Journal of Oral Hygiene, and you can look some of the results up if you are more interested. Periodontal disease is also a widespread disease that is manifested by inflammation of the gum tissues around teeth. Inadequate oral hygiene is the essential cause of periodontal disease. However, several other important risk factors, including tobacco use, several different systemic diseases, unhealthy diet, genetic factors, stress, and excessive alcohol consumption plays an important role, as it does in many other non-communicable diseases. For many years now, there has been considerable interest in links between periodontal disease and systemic disease. The link between periodontal disease and various diseases, with the main areas of interest being atherosclerotic cardiovascular disease, diabetes, and adverse pregnancy outcomes like pre-eclampsia, premature birth, and underweight children. Respiratory diseases, chronic kidney diseases, rheumatoid arthritis, cognitive impairment, obesity, metabolic syndrome, Alzheimer's, morbus Crohn, and certain type of cancer is associated and linked with all infections. Thus, obtaining oral health, including periodontal health, is important not only for the function of the oral cavity, but for the health of the person. All health and all diseases are therefore important components in relation to many non-communicable diseases. The cost of doing nothing when we are talking about all diseases is extremely high. We can demonstrate that the number of days that children are going to school are much more frequent than when they have oral hygiene than if they don't. Adults are working much more efficiently and if they are free of oral pain.
Daniel,
So,
can you hear me?
I would finish up saying thank you for having the opportunity to use this.
Thank you so much.
We will.
Thank you so much. For the sake of time, we have so many items on the agenda, and you bear with me. But we appreciate your work and your time. We thank you for the work you're doing for fighting NCDs, especially oral health.
Thank you.
Yes, thank you for being with us. Moving next to the next presenter, we have Amir Gasarabwe from Health Alert Organization. He's going to talk about skin cancer prevention in people with albinism. You have 5 minutes to go through your slides.
Thank you so much. A good afternoon to you all. I'm called Amir Gasarawe and I'm here representing Health Arts Organization. I work as a program manager, but professionally I studied dermatology. Health Arts Organization is a community-based, non-governmental organization. It started way back in 2016, founded by a group of health professionals aimed at giving their hand in the fight against NCDs. And among the program we offer, we have NCD and other chronic disease prevention program. Next slide. Okay. Next slide. Next slide.
Technical team, if you don't have the presentation, I mean, maybe you can go ahead.
Yeah.
As we wait for the.
Well, among the program we offer, there is NCD and other chronic diseases prevention program and child malnutrition prevention program. These two are done in Chichucho district where we are based. And we have another program called Albino Healthcare Program. This one is done countrywide. So far we are operating in 7 districts. That's where this program has reached. You may be wondering why we decided to choose Albino Healthcare Program. As you may know, albinism is a non-contagious, genetically inherited condition. It is characterized by a complete lack or a reduction of melanin in the skin, hair, and eyes. Melanin is a protein found in the produced by melanocytes. These are cells found in the skin. And among the main function of melanin is to protect the skin from damage by UVA and UVB rays. And hence, due to lack of melanin, people with albinism are at high risk of developing skin cancers. That's why we choose this project, because we want to help these people to prevent skin cancer from them. That's the main reason why we chose it. Albinism seems to be a neglected condition, hence the need for special attention. Albinism is a worldwide problem. You can find it in every country. So far, the statistics say that at least the whole world, 1 in 40,000 people may present with albinism. But in Africa, 1 person in about 15,000 people may be found with albinism. In some countries of Africa, like Tanzania, you find 1 person in about 1,500 people found with albinism. However, in Rwanda, we don't have any statistics because this condition has never been given any due concern. But we expect about 1,000 to 1,500 people with albinism. Since we started this program in 2016, so far we have identified 695 in 7 districts. Those are people we are following them up at least regularly. The main objective of this program is to improve the quality of health for people with albinism by providing them with regular skin and eye care aimed at preventing skin cancer related to sun exposure and correcting visual defects associated with albinism. That's our main objective. Specifically, we work to identify these people wherever they are scattered in the country. We educate them and their relatives about albinism and dangers associated with the exposure to sun. And we try to enlist the health problem they face, particularly skin and eye problem related to sun exposure, and we try to manage them, those which can be managed. Another objective is to fight stigma associated with albinism and manage psychosocial problems among people with albinism. These are some of the objectives of this program. The strategy we use to implement this program are mainly described in 4 pillars. We have health education, which is the most important one. These people, they are not aware of their condition. So through health education, we are able to educate them about the cause of albinism. Then we do regular skin and eye examination aimed at early detecting skin cancers so that they can be managed early. Another thing, we also we do preventive measures and possible treatment for the problem they have. Another thing is follow-up care and advocacy. The methodology we use, we work in collaboration with the RBC, district hospitals, and the district authorities. We carry out albino health care. We move as a team. Then we conduct those health care clinics and examine them regularly. So far, we operate in 7 hospitals, as you see them. The activities we do, as I said, we do, majority of these are young people. At least from 0 to 24 years, they contribute 75% of them. So among the activities we do is health education, as I said. We do mental health services. We have a mental health officer in our group. So we use group counseling and individual counseling. We do regular examination of the skin, and the lesion identified, we try to manage them accordingly. So far, among the lesions that we have been, the condition we have been finding include lentigens. Lentigens means the dark spot. They are dark spots that are found on sun-exposed area. They are erythema, sunburn, solar elastosis, actinic cheilitis, actinic keratosis, and cancer. These are the figures. Please move to another slide, please. Yeah. So we also do eye examination. We use the OCO, ophthalmology clinical officers based in these hospitals. They examine their eyes to find out the visual problem they have. These are some of the visual problems, but they are not projected. I don't know why. Well, we also treat, there are some regions which are precancerous, like actinic keratosis. We treat them using cryotherapy. Cryotherapy is a procedure we use using liquid nitrogen. And then we freeze them. Once we freeze them, they are cured. And then we reduce the chance of them developing skin cancer. Yes, then another thing we do, we supply them with the sunscreen to protect their skin from sunburn.
Yes,
and we give them,
excuse me, I'll have to cut you short. Yes, this is really wonderful work you are doing. As you highlighted, you still have gaps, and this is the reason why we are sharing these best practices to look for partners and also to appreciate what you're doing. Thank you so much for your time so that we can have a floor for others. Next, I'll suggest maybe if we skip slides, since these are the best practices we are sharing, we try to be more of a freestyle so that you can share what you're doing so that we can all learn from you very quickly. So next is Hobabagabo Arsene from Rwanda Diabetes Association. He's going to talk about nutrition and psychological status among type 1 diabetes patients. Please keep it short. Keep it short. Be precise enough. Thank you.
Thank you very much, audience. Arsene here. I'm Paul Mbonyi, Programs Manager at Rwanda Diabetes Association, and I'm going to present you about psychological and nutritional status among type 1 patients in Rwanda. Rwanda Diabetes Association is a national organization created in 1997 with four main points of its action: advocacy, education, care, and also promotion. We have conducted a small scale, a rapid assessment on psychological and nutritional status among children and young people living with type 1 diabetes. We used a desk review, but also we used paid problems areas in diabetes for psychological assessment, and also we used nutrition and diversity of diet for assessing the nutrition status. Next. 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 What have been as results? For psychological status, the number of participants was 84, and we conducted the assessment at clinic of RDA and also in rural district hospital, Kabgai. And what we've found is that 27 of participants were having severe distress, 43 low distress, and 30 were having moderate distress. What are key factors that worsen that situation? Factors are found at family level, community, at school, because many of those participants are in schooling age, and you also have some factors related to sexual and reproductive health. There is discrimination. They fear to tell to their peers or at school that they are living with diabetes, and it's still a problem, and then they live in distress. For nutrition status, 17 were overweight, 14 in chronic undernutrition, and 69 were normal. The conclusion have been that intervention to address the cause of psychological distress among type 1 diabetes patients are needed to prevent its negative impact on the level of diabetes control. And the nutrition, education, and food diversification should be emphasized in the management of type 1 diabetes. Some recommendations: integrated approach in diabetes and other NCDs care. That means that when a patient comes, he have to have a nurse or a doctor, but if he manifests symptoms of distress, he directly have someone to give him counseling instead of come other days. And in many health facilities, there is not enough psychologists to help those people, and nutritionists are in a small number in our health facilities. There is a need of education and awareness in the general population, but especially in schools, and also there is a need to build the capacity of schools leadership members, because when a children or students say that he is living with diabetes, many headmasters, they say, go to your home, you are a burden here, you are not able to follow you, and then it's still a problem. They are somehow stigmatized and discriminated. And also there is a need to enhance health and sexual reproductive health by linking this education to diabetes, because we've experienced that many adolescents, because they have misinformation that people living with diabetes, they cannot get pregnant, and then they try to test. And when they test, there is many number, the rate of teenage pregnancies is very high in those, in the adolescent girls. Ladies and gentlemen, I'm going to conclude by talking about what have been done now for counter or overcoming this problem of nutrition and a psychological issue among type 1 diabetes patients. In Rwanda, we've initiated youth diabetes camp where young people go together, they learn peer-to-peers, and now in collaboration with Rwanda Biomedical Center, we are at the level of organizing youth camp diabetes at regional level. And I call upon to everyone here, if we join the effort, the issue is that when we talk about diabetes, people directly think to type 2. Know that our children, they are diabetes diagnosed when they are hospitalized. We need, as we say, early detection. I think we have to be engaged in doing early detection among our children in schools and also in the community. Thank you very much for kind attention.
Wonderful. Thank you so much, Bonyi. Thank you for highlighting that. And thank you for the great call. Stigma is really a real challenge among people living with NCDs. Our next speaker is Mrs. Caroline Akope Aisu, the Secretariat of East Africa NCD Alliance. She's going to talk about media engagement for NCD awareness and advocacy, the experience from East Africa NCD Alliance.
Thank you so much. Thank you so much. My name is Proscovia Navate. I'm standing in for Caroline. I'm a communication specialist and a journalist by profession. I work with East African NCD Alliance. So, 3 years back, we started a project on strategic media engagement for advocacy on diabetes and other non-communicable diseases. As Professor Yonga said, we need a multi-sectoral approach to fight against NCDs. So we felt like we need to engage media and see how we can bring their role on front so that we can fight NCDs. Our main aim was to create awareness and enhance government action on NCDs by establishing sustainable framework of media engagements. Let's go to the objectives, please. So we looked at the role of media in advocacy and their main objective of fostering the agenda. Media is also the fourth estate. They engage the political arena in policy formulation and implementation, as well as regulation enhancement. So we felt like when we bring them on board, it will be easier for us to raise our voice and also enhance our accountabilities and act, force governments or engage governments to act on NCDs, policies, and other regulations. So our major objectives of the project was, 1, to establish partnerships with at least 4 media houses in East African countries that have demonstrated commitment to providing regular, accurate information on NCDs in collaboration with member alliances. The second objective was to increase capacity and interest of the media to provide more coverage on NCDs. Then the third objective, which was so critical, was to increase by at least 30% of the volume of media coverage on NCDs through a collaborative process of developing, disseminating, public interest, evidence-based content, and compelling stories, and use of diversified channels of communication. I would like to applaud the alliances from East Africa, that is Burundi, Kenya, Rwanda, Tanzania, Zanzibar, and Uganda, that we have truly moved with throughout this project. So as I clearly said, we couldn't eliminate the fact that media is so critical when it comes to bringing out the accountability on government work when it comes to development sectors. So when you look at our summarize, when you look at the activities we did strongly, we had to engage people in capacity development, media, among the 6 countries. I would like to say that around 244 journalists were engaged in these 18 months, and we are trained on how to report on NCDs, and also we allowed them to engage with advocates and experts for more information and critical analyzing and understanding of NCDs and other related issues. In addition, also we ensured that we engage media with people living with NCDs so that they can understand their stories and voice them and also give them the platform. These are some of the things we have incorporated in our report. We have a report already here. Because of time, I'll summarize. We have had constructive results like knowledge enhancement. We have had development of sustainable media programs. A key one of a bi-monthly virtual fitness and health life education show was initiated here in Rwanda, and other programs that have been initiated in different countries, basically to talk about NCDs. Another thing I can say that expanded platforms for people living with NCDs to share their experiences. We have also enhanced those programs. Then we have also built comprehensive and cohesive communication systems among alliances, basically to communicate about NCDs. Another critical result that I can also highlight is the breaking the language communication barrier among NCDs and communities. We realize that our region is multilingual with, I can actually say that only in Uganda, we have over 54 languages. So we felt like the media can do this work and communicate our language, our communication in these local languages. Yes, as I said, we can have this detailed information in our report. It's a well-detailed report. Because of time, I will not, I have summarized what we have done, but I can also talk about the sustainability approach that we have put in our report. You can have the details. We have said with such a great stride, it's critical to note that a landmark of the project for the sustainability was reasonably highlighted. We can tap into the development of professional short courses to enhance journalists' knowledge. It can be a monthly, 6 months, 12 months for the journalist actually get to understand the NCD approaches. Creating incubation centers to nurture youth in the region on NCD aspects. We also need to recognize the role of the media in driving the NCD agendas through maybe the biannual media awards. Because of time, thank you so much. I would like to also recognize our funder, the WDF, the World Diabetes Foundation, and all alliances and your association, experts and ministries of health. Thanks for your support. Thank you so much.
Thank you so much.
In case you need it in digital, we are here. You can register with us with your emails and we shall forward you. Thank you.
Wonderful. One of the key stakeholders in fighting NCDs, media is among them. As they help to fight the myths around NCDs and raising awareness. Thank you so much for the presentation. Our last but not least speaker in this session is Mr. Sevutare Elias from Health Builders. Sevutare, are you present? Yes, he's going to talk about involvement of rural communities in prevention and early detection of NCDs. Please be brief. You see the pace we are running at, and I hope you're gonna bear with us. Thank you.
Thank you very much. My name is Elias Seutare. I work with Health Builders, a locally registered organization whose aim is to reduce inequities, healthcare inequities between urban and rural places. Our focus is in the primary healthcare, whereby we try to strengthen the areas by training of healthcare workers, developing healthcare infrastructure, and healthcare technologies to make sure that they have all that is required to provide quality healthcare. I'm honored to be speaking in front of you today to talk about one of the success stories on how the rural communities have joined efforts to overcome the challenges of low treatment enrollment for non-communicable diseases. The previous speakers have made it clear that one of the factors leading to the current high mortality due to NCDs is delay in diagnosis and treatment enrollment. And today I will be talking about how the districts, next slide please, how the districts, that's an entity below the province, for those who don't know the administrative structure of Rwanda, that's how they work together with the health facilities and civil society organizations to provide screening services and health education to the population on non-communicable diseases. The aim is to increase the treatment enrollment. Next slide. The role of the district in this intervention is to integrate health targets in the annual performance program, which is locally known as IMIHIGO, whereby they establish targets of the numbers of people to be screened depending on the demographics of each area in the district. And other stakeholders, of course, besides the health centers that are responsible for direct care provision, are non-government organizations like Health Builders and others who support the health facilities in the logistics, transportation of staff, purchase of materials to reach out to the communities in the different corners, to do screening and identify those who need to be enrolled into treatment programs. Can you please move forward? When you look at the data from the HMIS collected between 2020 and 2021, we tried to look at, to explore whether these systematic screening have been leading to improved treatment coverage. And as you can see, the next slide, please. As you can see, between 2019, that's a year before initiating this intervention, the number of people screened increased by over ninefold, from slightly less than 1,000 to over 170,000. I mean, over 179,000 in the next year, and then 190,000, with the numbers of cases detected dramatically increasing from almost 800 to over 8,000 and 7,000 the next year. The association testing shows that this increase in the NCD screening can be associated with this increased number of new cases, I mean, number of patients who have been enrolled into treatment programs. And we really believe that if this multidisciplinary approach between the districts and other stakeholders is upheld, we can reach another mile. We can go even further. We hope this is a good experience to share with others. However, there are also some challenges. Some of the challenges include age and sex inequalities between the population, whereby the youth look to be more likely to attend to the community-based screening, while those aged and especially the females are more likely to attend. There are also low unawareness that persist and the low participation of private sector in the mobilization of resources and screening activities in general. We thank you very much for your attention and look forward to even improved cooperation between all the stakeholders to sustain these achievements and even go further. Thank you.
Thank you so much. Thank you so much. We have heard successful stories, and I think this was inspiring. Another big round of applause for all the presenters. I think we took notes and derive from their interventions. So we have come so far, and we are approaching the end of our agenda today. I thank you for hanging in there. We had a lot today, and to just end at a high note, we would like to bring in more energy, and Angie's really good at that.
Great. As you know me, we have to stand up now. Sorry? There are people who have questions?
Please, let's end up and try to end at a higher note. The session we're going to have is really exciting. And I want to step in with a good energy.
Thank you very much. I just had a comment going to what the President NCD Alliance was talking about today, Professor Joseph. We were discussing here and we felt critically that every country or each alliance has an advocacy agenda for people living with NCDs. The president noted that the same way we've had a regional conference, we should be able to have a conference for people living with NCDs. Now, the idea here is that since we have an advocacy agenda for the people living with NCDs, in the next meetings that we probably should organize, they should all be given chance to review this agenda as a team, and then they will be able to be given chance to come up with an East Africa agenda advocacy booklet for those living with NCDs. And we believe that to avoid, to reduce the challenge that we have on finances, we can be able to invite each of them from every country. So while we are in this meeting, they can be deliberating in a side room so that after they can present to us and say, this is what we feel. So I'm adding a voice to what the President NCD Alliance East Africa said, so that we'll have an advocacy agenda for those living with NCDs in East Africa. I thank you. Asante sana.
All right, that was really insightful. I think it's Dr. Perez who said anything for us without us, then it is against us. So that is very well noted. I hope the organizing committee is going to note that down. So it's now the energizing time. I would like to ask people to hold their hands like this. All right, then we're counting 2, 1, 0. You get what I mean? That means we are using our hands and feet to count 2 until 0. 0, we will write it with the whole our body. Then this is how it goes. We start with our right hand. We say 2, 1. 2, 2, 1. 2, 1. 1, 1, 1, 1, 0. Great. All right. So we start by 2 and we count downwards. So hold your right hand and then we go together. 1, 2, 3. 2, 1. 2, 1. 2, 1. 2, 1. 1, 1, 1, 1, 0. Thank you. Thank you so much. You can go ahead.
Wonderful. All right. So the next session is really exciting, and it's my great honor to invite the Vice Chair of the Rwanda NCD Alliance for the release of the policy brief on integrated people-centered care and integration of NCDs and HIV. Please welcome Madame Rose, the Vice Chair.
Good evening, everybody. Me, I wanted to ask you, she has done so, but I wanted you to write your first name with your body. Everybody writes their first name with their body. If you're Caroline, you write your Caroline using your whole body. Would that be simple? Okay, let's continue. Please, the presentation. I have only 3 slides. It's on. Okay, thank you. In Rwanda NCD Alliance, we did a quick survey on the policy report, and we are looking at integrating NCDs into HIV services. We feel that we shouldn't be having parallel programs in Rwanda. And this was done in the spirit of universal health coverage. Continue. So there was that need of integration, and why was it there? People with NCDs have a lot of comorbidities, and you find that when you have HIV, sometimes you have the diabetes, you have hypertension. So we looked at it, and we are looking. Someone said yesterday, let's look at a person, treat a person, but not treat a disease. So we are looking at treating a person, not a disease. The second reason why we did it is that people take a long time going from one, looking for medical treatment. You move from one doctor who is in charge of treating diabetes, then you go to another one of hypertension, then you go to another one of HIV. So we felt that it takes a long time for that person to be treated, and of course it is very costly when it is not integrated. Then we looked at it as, again, that people living with HIV/AIDS, there is a lot of increase in comorbidities of other diseases. So we felt that we should really integrate it into our system, and then that person is treated holistically. Next. So how did we come about that one? We did the research, first desk review. We looked at all the policies we have in Rwanda, the NCD policy which was done. We did some consultation with different stakeholders. And of course, we approached people living with HIV and those living with NCDs. And also we consulted people living with both HIV and NCDs. And what did we find out? Well, the numbers whom we approached. Next. People living with NCDs, total number we reached were 93. People living with NCDs were 34. People living with HIV/AIDS were 12. People living with both, that's HIV and NCD, were 12. We went to the head of our health centers. We reached about 10. We looked at people in the health centers who are focal points for NCDs and HIV. Both we reached 10, so the total. And then we also contacted the organization which work in the area of HIV. You know, there are some organizations with HIV and AIDS, and then some organization, of course, ours, who work with NCD. So the total people we reached or informants were about 93. Next. So what did we find out? One, we found out that a well-positioned of integration of NCDs and early detection, care, and treatment should be done at all levels where we do our HIV services. But however, what came out when we talked to the people who are now dealing with HIV services, there is a need of awareness increase for integration. They still want to do vertical. Integration is not yet into their minds. And secondly, what we found out, as I said before, there is a lot of costly in terms of time and quality care if we have these integrated services when they are not integrated. Next. In addition to stigma on the people living with HIV and AIDS community, clinics which have screening for HIV, in fact, HIV has been in progress for so many years. I think the word NCD came recently because it looked like a must, because HIV mostly has become like an NCD these days. So the NCD, they have that stigma. And then also, the integration of NCDs and HIV, the nurses are they expressed that that would be an added workload if an integration is done. So need to train more nurses, need to train more health professionals so that the integration becomes much easier. Again, the organization working on HIV and AIDS have shown that they are active and supportive in championing for NCD and HIV integration, though most of them are not well conversant with NCDs. So there is a need also to train those organizations which has been doing vertical services to people living with HIV/AIDS. Next. We had also a roundtable with stakeholders, as I said, the NGOs or the organization which are dealing with HIV. There is a need, they were saying that there is a need for alternative program funding. I don't know why they said so, maybe if we had a lot of discussion, we could say, to achieve integration of NCDs. Taking in account, of course, there will be structural health systems at the facility level, and then adoption of the health technologies, as well as capacity building for medical staffs, as I had said before. Next. So, in conclusion, we said people-centered and integration care for NCDs and HIV/AIDS is urgent, and it's now, and it's timely if we do it now. And to achieve this holistic approach, we appeal to Ministry of Health, By the way, I forgot to recognize our Rwanda Biomedical Center Director General, who has just come. Maybe most of the people, you don't know him. So when I talk about integration with the Minister of Health, he's Professor Mambo. Maybe you can show yourself to participants. So when I'm saying he's the well-placed person to hear that recommendation, so we are appealing really to the Ministry of Health, development partners who are here, people living with NCD and HIV, advocates, civil society, and the community organization and researchers to put this action now, not tomorrow. So before, next. So that word, who knows that word, what it means? Those who are not Rwandese. You are Rwandan, though you are from Uganda. So murakoze, but before I end up, I would like to invite my chairperson to come and we hand it officially to the Minister of Health, the policy book which we did. And he's going to lead the ceremony. Thank you.
Thank you very much, Rose. This is to, first of all, to recognize the work done by our alliance in collaboration with and with the support of Global NCD Alliance to have this happen. And we wanted to launch this report as a ceremony somehow. So as you see, there is a ribbon, and we would like to invite the Director General of RBC and yes, Dr. Francois, he cannot come alone, so please come. I may also invite the representative of WHO Rwanda, so he can join us, so that we can officially launch this report. So people living with NCDs very here. I don't know. People living with NCDs are abagomba kuza. Indeed. And is Dr. Joseph here? Rukeribuga? Apparently not. He's there, so please join us. Yeah, and Christina from Global NCD Alliance, if you can join us. And Prof. Kaushik, could you join us? Because now I'm Rwanda NCD Alliance, so we need to have East African NCD Alliance to stand with us. And Prof. Yonga, please join us as the President of Africa NCD Network. So, this is just to say that integration of NCDs and HIV services, we think it is the way to go. That's why we want to emphasize the importance of all of us working around these. The way I got it yesterday from Prof. Yonga, this is already accepted on PEPFAR side. That would make things easier. So I think it is to us now to be proactive and propose the way it should be done. So as a symbol, so I would like to ask our DG to cut the ribbon so that seizures do not look to be good, but the most important is the symbol. Thank you very much. Can you clap hands, please? And allow me to give you a copy of this report. looking forward for your support to have this integration happen as soon as it is possible. Thank you very much for being here. Thank you to all of you for supporting this. We are grateful to have you all here, and please let us join our seats before we hear about the recommendations of the meeting. Thank you very much.
Thank you, Chair. Over to MC.
Thank you. Another big round of applause. That was really wonderful program. All right. I would like to call upon the chairperson of the conference, Mrs. Maeva Pietier, to come and give us the recommendation, and then she will go ahead as well and also invite the chairperson. As the chairperson will also help us to invite the guest of honor. A very big round of applause to this lady. She put all of this together. Ladies and gentlemen, I'm here as a fellow young lady, proud of this one. So another big round of applause again. Thank you.
Thank you very much, Ange. I'm not the chairperson, I'm just the conference coordinator. And I am very grateful to be the one who has been under the leadership of Professor Muchumbitsi as well as RBC to be the one coordinating the organization of this whole thing. I'm pretty much humbled. So without further ado, I just want to Thank you very much. Without further ado, I'm just going to be presenting the recommendations from this conference. They are not long, but those are takeaways that have been put together as we're all together in this platform as the member state of the East Africa community. And starting, the first one will be about this platform recommends East Africa member states to develop strategies for a comprehensive approach to decentralized mental health and rehabilitation services in the primary healthcare facilities. There is a need for a shift from mental health services as a standalone care and integrate it in other healthcare services at all levels. Secondly, in a sense of increasing the funding gap for NCDs, it is recommended to amend the legislation regarding unhealthy commodities like tobacco, alcohol, and sweetened and trans fatty food to discourage their consumption by increasing taxation and also regulating their social marketing. Finally, as it is being implemented in Rwanda, countries of the East Africa community are recommended to design people and community-centered interventions. Governments are also recommended to decentralize NCD management with specialized NCDs clinic managed by trained nurses and doctors and meaningfully involve people living with NCDs, including mental health and disabilities in policy making. We also need to establish a costed national cancer control plan, highlighting services to be delivered at each level of the health system, and calls for multidisciplinary approach, including private sectors, for cost-effective interventions. This was all about the first day. Today, we had a couple of discussions around research, digital health, capacity building, and everything. One of the things that was recommended was to harmonize the registry of disease outbreaks and patient records to ease the accessibility of various informations required for effective management. So far, there is a roadmap that has been developed and will guide the healthcare system and providing effective integration of such interventions. It is critical that all healthcare facilities digitalize their health data and harmonize them. Therefore, harmonizing health facilities will also improve patients' record and bring everyone together to monitor minimal changes and progress that align with disease management. Thirdly, appreciating the advocacy that has been made so far, emphasis has been highlighted to boost NCD's research department as a helping tool for comprehensive research funding oriented for stakeholders. Moreover, during advocacy, NCD funding should be viewed as an investment rather than a cost of the implications of the health burden it leverages. To close up, a national level gathering of groups of people living with NCDs from various regions is required to converge on purposefully ideas for a larger global policy recommendation. This will furthermore enforce capacity building of NCDs alliances, civil society, people living with NCDs in a multifactorial approach. People living with NCDs must be fully involved in the decision-making process so that we can understand their needs and priorities, and this will also further help to develop realistic policies that will have a greater impact. Ladies and gentlemen, I was honored to be in front of you and putting this together. Thank you for having me. So, as I said, I was under the leadership of Professor Muchumbitsi here present and also Rwanda Biomedical Center. It is also my honor to invite him here. Thank you very much, Prof.
Can you please clap hands for Maeva? We are used to have strong women, but she's a strong girl, young girl, and she did very well. Thank you so much. So it is really a good moment to celebrate because we have made it. We have made it together. There have been so many people involved in this, and I'm not sure I will try to give a list of all who contributed to this, but of course, I cannot not mention, as I said yesterday when we were opening, the Minister of Health and the Rwanda Biomedical Center, and we recognize the Director General Rwanda Biomedical Center, who is in the Minister of Health. He is sitting, I think, for the Minister of Health. Thank you so much. We have been so supporting. Yes, please clap hands for them. I think this is really a very important sign of collaboration, because we work for fighting NCDs, and having this meeting was really an important landmark for the country, but also for the region and for Africa beyond, because as I said, here we have many countries represented. Of course, it is not only the Ministry of Health, we have also different other sponsors and actors who have contributed to these. Later on, we are going to give certificates of participation and recognition of appreciation. But I mention again WHO Rwanda, UNICEF Rwanda, Rwanda Africa Medical Supplier, Biosensor, Christian Brand Mission, Medtronic Labs, Partners in Health, Global NCD Alliance, East Africa NCD Alliance, and Danish NCD Alliance, to name a few. But there are so many other people who have supported this event to happen. We are so grateful for your support. Of course, we have seen all the people who have intervened as speakers, as panelists, as moderators, the whole team of our beautiful young ladies and men who have been doing the protocol, and even other people have not seen in the room here who have been behind these. The technicians. This morning someone asked me, do you have a professional team to organize this conference? I said, no. We did it all with so many volunteers as well. We need to recognize them. A lot of, volunteers who have been working for the last month, actually. We had volunteers sitting every week for meetings to prepare this. So we are so grateful to them for having made this possible. And of course, people living with NCDs, Dr. Joseph Rikeribuga was representing them, would have like to bring more, to testify, to tell us their stories, but he was representing them, and we always think about them. And many of them are members of Rwanda NCD Alliance, so we need to really recognize that without them, this would not have been possible. And of course, the staff for Rwanda NCD Alliance, I was asked to say how many permanent staff we have. I said we have 3 permanent staff, 3 interns, and a lot of volunteers. That's the team which has been behind this. So, but of course, I need to recognize this. We had a technical preparation meeting with stakeholders, and that was really the last 2-3 weeks where many of our sponsors here were there to help us putting this in place. And of course, without the guidance, it would not have had this quality. Yeah, so let me thank all the participants. It has been so good to see. It is rare that in meetings you have so late on the second day, quite everyone still attending. So I hope it is a sign that it was interesting. And I think that this is a proof that probably we have presented something good to you. I would like to recognize especially our guests from abroad. Of course, all the delegates from the East Africa NCD Alliance, we have 6 member alliances, and all of them were represented here. And of course, our office in Kampala, they did a very good job to support us as well. And I'm really grateful to them for their support. We had also the Danish NCD Alliance team, the Global NCD Alliance team. We had meetings together, we had a workshop together, and these also, even it was not in the conference, it was also supporting the conference. Thank you very much to everyone, and I would like to give the floor to the Director General of Rwanda Biomedical Center, invite him to say a few words and close this meeting for us. Thank you again. Murakoze cyane. Asante sana.
Hello, good afternoon. Thank you very much, Prof. Muchumbechi. I think it's really unusual, as he mentioned, to really see a lot of participants still being there in the room, following the discussion until now. It shows that NCD is one of the topics that really concern everyone, and this is also a priority for us. So I think Chair of the East African NCD Alliance, all Rwandan officials who are here, representative of the UN agency, and also all development partners who are present in this room, head of the international national non-governmental organizations, representative of the East African Community member states, chairs of the NCD Alliance from EAC members of states, private sectors represented here, patient groups, and also distinguished guests, ladies and gentlemen. Again, good afternoon. I'm really pleased to be today as we are concluding the 2 days regional NCD conference. Unfortunately, I did not manage to be with you from the beginning, from yesterday, due to many conflicting priorities that I have to handle, but I'm really glad that I'm here today, and I really managed to really hear some of the recommendations that have been come out from this 2 days conference. And it's really showing that those are very good recommendations, and we are really glad to be here to hear about those recommendations. So allow me to start, as Prof said, to thank East Africa NCD alliances for trusting Rwanda to host. I assume that this is the first regional NCD conference, so it's really our pleasure. And our gratitude goes to the organizing committee team, which I think did a very great job, and also which was led by the Rwanda NCD alliances in collaboration with the NCD division team from RBC and our distinguished partners for the excellent coordination that has really made this conference a success. I want to especially thank the panelists, the speakers, moderators, for really bringing decisive ideas and also expertise that was really formative and also innovative. They, I think, they brought the diverse experiences that revealed current evidence, policies, and also implementation models that will help all of us to build back better for a sustainable response to the NCD epidemic. I want to thank you, delegates, for your attendance and also active participation. You made a significant contribution to this successful conference. This is also another moment to reiterate our heartfelt gratitude to our partners for the technical and also financial contributions that made this gathering possible. Let's continue working hands in hands to defeat NCD. Ladies and gentlemen, this has been a very fruitful 2-day conference, as I can notice from this recommendation. And also it serves as a useful platform to exchange information, experiences, and also ideas in tackling the NCD burden in the East African region and beyond. I have no doubt that this has been a momentous event towards promoting partnership and also, of course, dialogue for sustainable solutions to this ever-growing burden of NCD. We have all listened to a lot of speeches, panel discussions, and also presentations contributing to the shaping of East Africa free of NCD through people-centered interventions and also transformative development, which was the theme of this conference. This is the right time to walk the talk. We have all the tools in our hands to drive the NCD response in the region. The conference has clearly showed that everyone here has an important role to play, and the fight against NCDs goes beyond the health sector. As you can imagine, all sectors, including private sector, public institutions, and also UN agency and development partners, all the non-governmental organizations, civil society organizations, and also patient group should really be brought on board, and also that the only way we can achieve our goals and objectives is to work really collaboratively. So this conference is ending, but also opening up the new commitments that we all made today during the 2 days conference. And it's really important that we implement the recommendation from this conference, as our colleagues, the coordinator iterated very well, that we need probably to really work on taxations. We also need to also make sure that we decentralize all our interventions to the community where the burden is seen. We have also committed to really make sure that we really invest in NCD. I know that really treating NCD is affordable, but I think we make more investment in preventing those NCDs. So it's really important that we really implement those recommendations from this conference, and we need to really make really progress so that in the next conference that we can all report together a significant achievement in reducing the premature mortality due to non-communicable disease and also achieving the universal health coverage for NCD. I would like to end my speech by again reiterating the commitment of Rwanda through the Ministry of Health and also the RBC to fight against NCD and also to continue to collaborate with East Africa member states to shape a community free of NCD burdens, which will accelerate the socio-economic development of our region. Ladies and gentlemen, distinguished delegates, I'm really pleased to announce the official closing of this first regional NCD conferences 2022 and looking forward to continue having this crucial gathering on annual basis. I think this is something you have really debated on, and also we also continue to implement the EAC framework on NCDs. And I'd like to wish you probably, I know that we have the very long 2 days discussions until now. Maybe some people could wish to stay for more days and also enjoying our vibrant city of Kigali and also make a tour. So I think they are welcome to visit this beautiful place in Rwanda, in our country. So thank you very much again. For those who are going back to the respective countries today or tomorrow, I wish you a safe and happy return to your respective countries. And again, thank you very much for really coming together around this topic of NCDs. And we look forward to the implementation of these recommendations. Thank you very much to all of you.
All right. As you all know, no one is allowed to speak after the guest of honor has already closed the conference. I would like just to deliver some few announcements. One of them is the people who would like to have their mission orders signed. There is a protocol team which is behind there. They would like to support you into that. Again, as you all know, some of you have been receiving invitation for the gala dinner. So we would like to ask you just to move out for the hotel to arrange this place and then network with your fellow participants. Then afterwards you will come. I think the organizing committee will help us to know exactly what time we are coming back into our dresses to impress. So thank you so much again for your cooperation for today's moderation and emceeing. It was an honor and I was very honored to be here with my colleague Claude. Thank you so much.